Hello friends, hi, good evening to all of you. I'm Dr. Shonali Chandra, your Obs-Gynae faculty at PrepLadder, and we are here with the last minute rapid revision session. So let's hear it. Who's joining us? So good evening everybody, those who are joining in. Let's just take a couple of minutes before everybody joins in. And Nazia, good evening. Prem Kishore, good evening. And I'm not able to pronounce the third name. I'm so sorry. Dr. Trader and Alam Noor. Good evening, everybody. So everybody who's joining in, I'm getting a hang of your names and everything. And I'm seeing that all of you are joining in. Yes, Malika, Arjun, Devin, Pratyusha. Good evening, everybody. And so all of you are geared for your INI-CET exam that is upcoming. Right. So good evening, Arvind and Jerry Stephenson and Shagundeep Singh. Good evening, everybody. Good evening, everybody. It will be very difficult to take everybody's name, but as and when you respond to the questions, we'll acknowledge that you're there. Namaskar, everybody. So for your INI-CET for the LRR, I have devised a plan today. We have 40 questions, okay, and we have 4 hours, and we have to maximize the output. Now, how are we going to do that? With the 40 questions that I have, we are going to grasp as many side questions as possible, right? So, this is the strategy that we are going to use. So, I think now we can start with the discussion. Let's have a look at the first question. 25-year-old woman presents with amenorrhea for 6 weeks with crampy lower abdominal pain and mild vaginal bleeding for past 2 days. Her vitals are stable, beta HCG is 1500. Which of the following will support the diagnosis of ectopic pregnancy in this particular woman? You have 4 options, but you have to choose the best combination. All right, so what is your response? So first is empty uterus on transvaginal sonography, presence of adnexal mass, free fluid in pouch of Douglas, POD is pouch of Douglas, and low serum progesterone. Yes. So I'm getting B, I'm also getting A, and I'm also getting D. See, you have to say which of the following will support the diagnosis. Okay, so the correct answer here is option number B, right? So first of all, the symptoms, right? Look at this here: crampy lower abdominal pain, mild vaginal bleeding, and amenorrhea. So pain generally is more pronounced in ectopic pregnancy as compared to vaginal bleeding. HCG is also elevated. That just supports that yes, pregnancy is there. Now the first clue to diagnosis of ectopic pregnancy would be that it is not inside the uterus. So yes, this would support the diagnosis of ectopic pregnancy, right? And we can visualize on ultrasound and adnexal mass also, right? So most of the times it is a complex adnexal mass that is identified. So this is also yes, will support our diagnosis of ectopic pregnancy in this woman if we were to find an adnexal mass along with an empty uterus. And we may be able to find some free fluid in the pouch of Douglas. This free fluid could be blood also, remember. So if the tubal abortion is taking place, some bleeding is happening, it will first of all collect in the pouch of Douglas. So free fluid in the pouch of Douglas will also support the diagnosis of ectopic pregnancy, but not low serum progesterone. So, so low serum progesterone will not support the diagnosis of ectopic pregnancy. See, yes, serum progesterone levels in normal healthy intrauterine pregnancies are usually more than or equal to 25 nanogram per ml. That's correct. And serum progesterone levels which are less than 5 nanogram per ml, these are considered low for pregnancy, right? So these can be low in ectopic also, and they can be low in abortion cases as well. Okay. Fine. So low serum progesterone will not help you make the diagnosis, and free fluid may not required for unruptured ectopic pregnancy. Yes. So from the clinical profile, it does seem like it is an unruptured ectopic, but even in unruptured ectopic, sometimes free fluid can also be there. So free fluid in pouch of Douglas will support the diagnosis of ectopic pregnancy. They are not asking you in this question whether it is unruptured or ruptured per se, but yes, from the looks of it, it looks like an unruptured ectopic pregnancy, right? Now, let's have a look at this chart and try to remember the key important points, right? Whenever you are given a clinical situation where you have to differentiate between unruptured versus ruptured tubal ectopic, you have to look at the entire clinical profile of the patient. Obviously, there is going to be the triad amenorrhea plus pain plus or minus bleeding PV. Bleeding PV in case of ectopic pregnancies is generally mild, okay? It is not going to be heavy as in abortion cases, right? See, if the patient is stable, it goes more in favor of unruptured ectopic. Ruptured ectopic patient will be unstable, or patient could also be stable. Understand here that what is making the patient unstable is blood loss, right? Hemoperitoneum. So it depends how much hemoperitoneum has already occurred. But if the patient is already unstable, it goes in favor of ruptured tubal ectopic. The pain in case of unruptured is generally going to be localized, and in ruptured tubal ectopic, it is generalized. Pain is generalized all over the lower abdomen and can also then later on, depending upon how much hemoperitoneum is collecting, can be generalized all over abdomen also, right? Now, tenderness is towards one side, and in ruptured ectopic, there is going to be abdominal distension. You may also find fluid thrill depending upon how much hemoperitoneum has collected. So, signs and symptoms of hemoperitoneum are typically going to be absent in unruptured tubal ectopic. And these signs and symptoms of hemoperitoneum, like bluish discoloration around the umbilicus, which is called as what sign? Yes, bluish discoloration around the umbilicus. Umbilicus in the center, so it is called as Cullen sign. Remember, recall, and you turn the patient and try to see for the bluish discoloration in the flanks, that is called as the Turner sign, Gray Turner sign. Okay, shoulder tip pain. Shoulder tip pain will happen if there is massive, all these signs happen when there is massive hemoperitoneum. So much so that, blood collects underneath the diaphragm because the patient is, prostrated and she's lying down. So, blood collects under the diaphragm, and shoulder tip pain is called as Danforth sign. These signs are not typical to ectopic. They're basically signs of hemoperitoneum, massive hemoperitoneum. Now, on PV examination, if it's a unruptured ectopic, the uterus will be felt to be normal sized. There will be tenderness in the adnexal region, tender adnexal mass will be there, or cervical motion tenderness will be there. Now, on PV examination, as far as ruptured tubal ectopic is concerned, it sometimes becomes very difficult to appreciate that the uterus is normal size. If they tell you that there is bogginess in the fornices, why? Because blood has collected all around the pouch of Douglas, right? So you tend to appreciate clinically not much of anything except that there is bogginess that is felt through the fornices. Your investigation of choice, first line investigation, is an ultrasound, right? So when we go for a transvaginal sonography in a case of an unruptured tubal ectopic, we will find gestational sac in the region of adnexa. Mostly it is a complex adnexal mass with signs like Bagel sign or blob sign. And in a ruptured tubal ectopic, hemoperitoneum can be appreciated. Please also remember that the uterus will be appreciated to be empty. So this is how you make the diagnosis, right? You place it in the entire clinical perspective if they ask you to differentiate between ruptured versus unruptured ectopic pregnancy. Now, another question that I want to ask you people, tell me, supposing there is a patient with amenorrhea and early pregnancy, okay, let's say 6 weeks, 6 weeks, 5 weeks, 7 weeks, whatever. So, amenorrhea, early pregnancy, UPT positive, let's say, and she may be asymptomatic or she may be mildly symptomatic. Mildly symptomatic meaning she may be having some pain, some bleeding, little spotting and everything, and you do a transvaginal sonography and the uterus is also empty and there is no adnexal mass, there is no finding actually. Okay, the clinical examination is also unremarkable. Clinical examination is also unremarkable. Okay, so this is also a situation where it could possibly turn out to be an ectopic pregnancy. Right now we don't know the location of the pregnancy, so right now it is pregnancy of unknown location. Right now it is pregnancy of unknown location. So review for follow-up ultrasound, somebody is saying, and Hemant is saying review for follow-up USG, and Dipanvita is saying beta HCG. So Dipanvita is correct here. You see, if you're going to follow up for repeat ultrasound, when are you going to call for follow-up? A week down the line, right? A week later, it may turn out to be too late in case it is an ectopic pregnancy. So you don't want that. So right now, there is another thing. Yes, you are going to go for serial. Yes, answer would be serial beta HCG estimation. Yes, that would be the correct answer in the serum. So, serial serum beta HCG estimation, in which it has to be repeated every 48 hours. Repeated every 48 hours, right? So, if there is doubling of serum beta HCG, it goes in favor of normal intrauterine pregnancy, right? If there is plateauing of beta HCG, plateauing means they are neither increasing too much, they are neither falling down too much, then it goes in favor of ectopic pregnancy, and if they are falling more than 50%, then it goes in favor of abortion. Right? So, serial beta HCG estimation can help us in those circumstances. Clear? Fine. Now, let's move on to the next question. A woman is seen at 12 weeks of gestation with complaint of mild spotting. Ultrasound reveals a gestational sac of 5 weeks gestation and fetal pole is measuring 10 mm in CRL, but cardiac activity is absent. What is the diagnosis? So, very quickly, Danish and Dipanvita very quickly responded, it is missed abortion. So, they tend to ask you questions on clinical presentations of abortion. These are simple questions. These questions should not go wrong. Please, these are simple questions. They should not go wrong. These are very basic questions, right? So, let's see. She is 12 weeks gestation. She is mildly symptomatic. She may be asymptomatic also, right? Missed abortion, early pregnancy loss means that there is a dead embryo that has been retained inside, right? So, 5 weeks gestational sac is there. That means beyond 5 weeks, no growth happened. There is a fetal pole which is measuring 10 mm, that is more than 7 mm. By now, the cardiac activity should have come. It has not yet come. So, the diagnosis is missed abortion. So, how do you diagnose missed abortion? Missed abortion is diagnosed when there is a CRL of more than or equal to 7 mm and there is no cardiac activity. One is this ways, and second is there is a gestational sac with a mean sac diameter of more than or equal to 25 mm and empty. So, that means gestational sac is there, but there is no fetal pole inside. It is still empty. There is no yolk sac inside. There is no fetal pole inside. These are the two ways you need to remember. And Sanjay, you will have to mug this up, dear. That CRL more than 7 mm. This has to be mugged up, the two criteria for early pregnancy loss or missed abortion, right? Now, I will tell you the I'll tell you the differentiation between these different kinds of abortion also, if that is what you're asking me, right? Now, see, understand here that threatened, inevitable, incomplete, complete, right? There's no mugging up here. It is in the name itself. It depends upon when we are seeing the woman. See, process of abortion is that the gestational sac, the early embryo is going to, it is going to separate from its attachment and it is going to get expelled. In the process, there will be bleeding, there will be crampy pain, and the pain and bleeding will stop once the products are completely expelled. So, this is the process of abortion, process of spontaneous abortion, right? In this process, when we happen to see the woman, in which stage is she? So, hear my words very carefully, right? Now, threatened abortion, right now, there is just, when you happen to see the woman, she is just experiencing a threat of abortion. The process of abortion has not yet started. So, yes, there is some bleeding, okay, right, some spotting, mild something, pain may or may not be there, so she's just mildly symptomatic, or may, right? Vitals are stable. Vitals stable or not stable will depend upon how much blood she has already lost in the process, right? Now, the size of the uterus is corresponding to the period of gestation, because whatever the embryo, the fetus, the gestations, whatever the products of conception are, they're still inside the uterus. Os is closed, right? How do you get to know the uterus size? By clinical examination. How do you appreciate the cervical os, whether it is open or closed? By clinical examination. And at times we also go for an ultrasound to appreciate these things, right? And we have to confirm the diagnosis of threatened abortion by transvaginal sonography, because that is the difference between the threatened and the missed, okay? Please remember, missed abortion, also the os is going to be closed, but it has to be a dead embryo inside or an empty sac inside. In threatened abortion, there is a fetus or embryo inside and cardiac activity is present. It's a live fetus or it is a live embryo, and the management is conservative. Okay, fine. Now, inevitable abortion means, inevitable means there is no going back. Okay, now the process has started, there is no going back. So, bleeding has increased, pain has increased, she may be stable, unstable depending on how much blood she has lost in the process. Process has just started, contents are still inside. So, uterus size is corresponding to POG. Right. So, process has started, contents are still inside, but the os has started to open up. So, you can check on ultrasound, the fetus or embryo is inside, whether the cardiac activity is there or is not there, it doesn't matter, it doesn't make a difference. And the management is let it progress. Incomplete abortion meaning that part of the products have been expelled already, part are remaining inside. So, bleeding is more, pain is more, patient stable, unstable depending on degree of blood loss. Obviously, if part of the products have been expelled already, the size of the uterus is less than the period of gestation. Now, as far as the os is concerned, I'll give you two scenarios, please remember. There's one patient who comes in shock, all right, and you examine the patient, right, you start resuscitating, obviously she's come in shock, there's a lot of vaginal bleeding, you start examining, the uterus size is less than the POG, you do a PV examination and the products are felt in the vagina, the os is open, it is definitely incomplete abortion. Okay. Now, I'll give you another scenario. Let's say a woman had a lot of bleeding, a lot of pain, and she, came, and when you examined the patient, the size of the uterus was less than the POG. The os was closed. Let's say the os was closed. So, you thought, okay, os is closed, size is less, let me check on ultrasound. On ultrasound, reports said RPOC is present, retained products of conception present. So, this is also an incomplete abortion, right? Now, incomplete abortion patients will need an evacuation of the uterus, right? Now, complete means that all the products have already been expelled. So, history of bleeding is there, pain has now stopped, right? Bleeding has also now stopped, and she may give the history of passage of fleshy mass per vaginum, stable, unstable, again depending. Size is much less than the period of gestation. Os has already closed, and you need an ultrasound to confirm that the uterus is empty. Okay. So, broadly, this is how we are going to differentiate. Okay. Now, moving on to the next question. According to the MTP Amendment Act of 2021, MTP is allowed till 24 weeks of gestation in all cases except, so there is only, so till 24 weeks of gestation, MTP is allowed under certain circumstances. What those circumstances are, if you don't remember that, what you need to remember is, yes, for contraception failure, this is what you need to remember, most important of all, that for contraception failure, MTP is allowed only till 20 weeks. So, that's the correct answer. So, all of you are getting it correct, right? So, just let's see. Consent of the woman is obviously the most important consent, right? And now our government allows it till 24 weeks, right? For the first 20 weeks, one registered medical practitioner has to give the opinion that it is desirable for abortion to take place, and between 20 to 24 weeks, two registered medical practitioners will give the opinion, right? Now, for failure of contraception, it is only till 20 weeks. It is allowed till 24 weeks in these exceptional circumstances, particularly, most importantly, rape survivors. And beyond 24 weeks, mind you, beyond 24 weeks, there's only one situation where it can be allowed in case of substantial fetal anomalies, and that too on approval by a medical board. So, this is also very, very important question point that you need to keep in mind. And Indrashish, okay, which instrument images are important for the exam? Now, right now for INI-CET instrument images, I have not got in my, I have more got clinical questions. But if you do ask me, yes, your abortion instruments, first trimester instruments, which they are used, like your MVA syringe and your Pipel's cannula for endometrial aspiration, these are the important instrument images that you need to see, right? Now, moving on. Let's have a look at the next question. A 30-year-old Gravida 3 abortion 2 is seen at 16 weeks gestation. She has history of 2 prior spontaneous pregnancy losses at 4 months and then another at 3 months. She is planned for cervical cerclage in this pregnancy. All of the following are contraindications to the procedure except. All right, so I'm seeing your answers. You have to say except. All are contraindications except. Mahesh and Danish, except. Indrashish, except. Except. Do you want to change your answer, guys? See, all are contraindications except. All right. So, the ones who are saying funneling of internal os, that is the correct answer. That is not a contraindication. Come on. See, what is the diagnosis? This is recurrent pregnancy loss that is happening in the second trimester. She is right now in the second trimester. And her prior pregnancy losses are also like 4 month and 3 month gestation. So, one happened at 4 month and the second happened at 3rd month. So, with each subsequent pregnancy, what is happening? The period of gestation at which the abortion was taking place, at which the pregnancy loss was taking place, is getting shorter and shorter, right? Earlier and earlier. So, this is cervical insufficiency. This is cervical insufficiency, right? And how we diagnose cervical insufficiency? One is based on classical history. See, there has to be classical history. Classical history, like I told you, spontaneous pregnancy loss, each subsequent pregnancy, loss happening at, lesser and lesser gestation, and painless expulsion of the fetus is happening. This sort of classical history. If 3 such pregnancy losses are there, if 3 such recurrent pregnancy losses are there, one could go for history indicated cerclage as well. History indicated cerclage as well. Okay. Now this patient has got 2. This patient has got 2 such prior pregnancy losses. So she's not qualifying for history indicated. So like you said, yes, ultrasound indicated. So what do we check on ultrasound? Transvaginal sonography we do. First of all, what do you check? You check the cervical length less than 25 mm between 16 to 24 weeks. So this is the time when we follow up. We do weekly follow up with transvaginal sonography, measurement of cervical length we do weekly between this time 16 to 24 weeks time, and if it is less than 25 mm it will fulfill the criteria for ultrasound indicated cervical cerclage, right? So the cervical length that is closed, that is remaining closed, okay, see this is the internal os, let's say, this is the external os, let's say, closed, right? This is T-shaped, okay, it starts to open up from the top. So this is like, this is Y-shaped cervix, okay, this is the funnel, and this is the closed length of the cervix. Funneling is there, funneling alone is not important. What is important is how much of the length of the cervix is remaining closed, or how much of the closed length of the cervix is still left. That is important. Then it opens, you get a V-shaped cervix, then it opens further, U-shaped cervix. So these are all ultrasound findings, right? So this is like this. A T-shaped cervix, closed cervix. Then this opens up. Funnel. This is the funnel we're talking about. But what is important is this length of the cervix that is remaining. So funneling, or let's say small length, will actually become an indication, right? Not a contraindication. Now, so that much is clear, right? Now, if the patient is already having vaginal bleeding, okay, if the patient is already having uterine contractions, then you won't want to put a suture material and tie the cervix, because obviously if uterine contractions are there, blood bleeding is there, that means the process of abortion is already started, right? You put a stitch there, cervix will tend to open up and then it will tear the cervix apart, right? If the membranes are already absent, you're putting a suture material there, you risk the infection also, and when membranes rupture, leaking happens, labor will start eventually. Right. So these are all contraindications. These are all A, B, C are contraindications to the cerclage procedure. Now, these are the cerclage procedure images that you need to remember. The first image here is showing McDonald's cerclage. Okay, this is vaginal root cerclage, right? Multiple bites are taken through the cervix and tied like a knot, like a purse string suture. This is the one that is most commonly employed. Okay, this is most commonly done. Then the image on the right is showing modified Shirodkar cerclage. Modified Shirodkar cerclage. See, understand here that when Shirodkar, the original Shirodkar cerclage was that he wanted to place the suture much higher up on the cervix, going from the vaginal root much higher up on the cervix. So for that, dissection had to be done. This dissection had to be done. Okay, and then he placed the suture there. This is a tape here. It could be a tape, it could be a suture, it doesn't matter. What is important is that dissection of the cervix was done and then he tied it. He tied a knot. Okay, then the modification came that the knot was buried. So in the modified, the knot is buried. The entire suture, the entire tape is buried. That is the difference. And the image, the third image here, this one is the worm's suture. This is also called as Hefner's cerclage. Okay, so in this you can see that the os is already open. So this is done in emergency cerclage. This is done in emergency cerclage. Okay, and there is another which is called as abdominal cerclage. The abdominal cerclage is Benson and Durfee cerclage. Remember this Benson and Durfee cerclage. Abdominal cerclage is generally done when there is history of failed vaginal cerclage, right? Or sometimes the cervix is so small or amputated that there is no space to put the suture vaginally, so then abdominal cerclage is done. So it is not routinely done. In special cases it is done. Abdominal cerclage can be done laparoscopically, can be done laparotomy wise also, but please remember that once the abdominal cerclage is put, we do not remove it. If the abdominal cerclage is done, then patient undergoes cesarean section. Okay, we don't remove it because we've made a lot of effort in putting it. So cesarean section is done and the cerclage can stay there for the next pregnancy as well. But if we are putting a vaginal cerclage, please remember, if we are putting a vaginal cerclage, it needs to be removed. It needs to be removed at 37 weeks, once 37 weeks are completed, or if bleeding occurs, or if leaking occurs, or if membranes become absent, or if she goes into labor. Okay, so then it needs to be removed, right? And Rukmini, you're talking about lash and lash cerclage. Lash and lash cerclage is one cerclage which could be done, which could not be done in the pregnant state. Okay, so these cerclages are generally done in the pregnant state, right? These vaginal cerclages like McDonald's and this modified Shirodkar cerclages, they're done when the patient is already pregnant, right? So lash and lash cerclage is one cerclage which cannot be done if the woman is already pregnant, because it requires dissecting the cervix and stitching a defect in the cervix. So that is lash and lash. Okay. Now next question. A woman presents to you at 32 weeks of gestation with complaint of feeling lightheadedness and dizziness when she lies on her back. She feels all right when she lies on her side. What is the most likely reason behind this? Now this is a very simple, straightforward question. You must have seen it being repeated many times in FMG, in INI-CET, in NEET PG. They're very fond of this question because it has a lot of clinical correlation. So very good. This is IVC compression. This is happening because of IVC compression. So pregnant uterus, especially beyond the second trimester, it becomes dextro-rotated, tilted to the right side, puts pressure on the inferior vena cava, right? So that is responsible for feeling of lightheadedness, dizziness. That is responsible for the supine hypotension syndrome. Supine hypotension syndrome. Agreed? Right? And that is why you also see that, they will have decreased cardiac output near to term. Cardiac output slightly decreases near to term because of this IVC compression, because IVC compression occurs, decreased venous return to the heart, decreased cardiac output, and decrease in blood pressure. This is how it goes. Now, what is the clinical correlation? A, it is something that is expected to happen. So this is something that is physiological in pregnancy. So left lateral position is the best position to be in pregnancy. In this pregnancy, what is better? Yes, the cardiac output for the patient is better, A, this. And obviously, if the cardiac output is better, that same cardiac output is perfusing the placenta also. So placental perfusion is also better. So this position is better for both the mother and the baby, right? So if you wonder, there is like, for example, we generally tend to tell our patients to lie down in left lateral position. So that is the reason why. All right. The other clinical correlation is that sometimes in cesarean section, okay, not sometimes, basically, during cesarean section, another clinical correlation, during cesarean section, right, the woman is lying down supine on the OT table, right? So ideally what you should be doing is, what we tend to do is, we do a slight left tilt. Okay, now OT tables are designed for these tilt, so that we put the patient in a left lateral position, right? Because during cesarean section she will also receive spinal or epidural anesthesia. She will also receive this anesthesia. It also causes hypotension as a side effect, right? So we don't want to add to that hypotension, right? So during cesarean section, a left tilt is preferred, and if the tilt cannot be done with the OT table tilting, then we can place a wedge under the right hip to give this left lateral tilt to the woman. So if you ever have seen a cesarean section being performed, you must have noticed this, that these staff does this for our patient, right? The other clinical correlation is, again, have you heard of perimortem cesarean section? Perimortem cesarean section. Have you heard of this perimortem cesarean section? What is this perimortem cesarean section? Under exceptional circumstances, I for one have had to, not myself been a part of that perimortem cesarean section, but witnessed it once, only once over all of these years. This is a perimortem cesarean section is very rarely, yes, within 4 to 5 minutes. Within 4 to 5 minutes, different guidelines say different things, right? So 4 to 5 minutes is fine, okay? It has to be done within 4 to 5 minutes of what? Yes, within 4 to 5 minutes of a cardiac arrest. Very good. Cardiac arrest in, this is a cardiac arrest in pregnant woman, let's say, and the CPR has started, okay? It should be done within 4 to 5 minutes. Now, see, please remember that this perimortem cesarean section is actually being done for the woman's sake, right? Because see, the uterus is filling up all of the abdomen, it is compressing the inferior vena cava, and the cardiac output is not able to increase. So the CPR efforts are not becoming fruitful. Okay, so we want to remove that IVC compression, and that is why a perimortem cesarean section is beneficial within 4 to 5 minutes. It will save the life of the woman also, and it will happen to save, if the fetus is viable, it gives a chance to the viable fetus as well, right? And this is generally done when the patient is beyond 24 weeks if it is needed, right? So many clinical correlations from one simple point, that of IVC compression. So you need to keep this in mind. All right, next question. So we have, I have a set of labor questions, right? Now, a low risk primary at term is admitted to labor room. Read the question. I'll just read Hemant's doubt. Hemorrhoids and varicose veins also because of compression of veins, so progesterone, smooth muscle relaxation, both will contribute. Both will contribute, right? And yes, much role will be of the compression. Much role will be of the compression of the iliac veins. Okay, but smooth progesterone related smooth muscle relaxation will also contribute. Okay, and Rukmini, classical C-section perimortem, yes. The only reason being one has to reach the fetus as fast as possible, and that is the reason why it's considered classical, but without any much of the dissection to the lower uterine segment. The goal is to reach faster, right? So it is not mandatory. Frankly speaking, it is not mandatory to do a classical cesarean section. Okay, but again, one may reach the baby faster, that's why. So now you read the question, and now some of you are saying B. So I hope you've read the question. Now I'll read the question in a way so that you understand how you grasp at the keywords. So oxytocin, nobody's choosing. Cesarean, nobody's choosing. Some of you are choosing B, some of you are choosing C. All right, so let's just read. It's the low risk primary, fine. Uterus term size, okay. She's term, cephalic, okay. Head 3/5, all fine, right? Fetal heart rate, fine. Localized towards the right flank. So fetal heart rate is towards the right flank. 3 contractions in 30 minutes, each lasting for 20 to 30 seconds. So okay, these are moderate contractions, okay, moderate, let's say moderate contractions. On PV, cervix is 4 centimeter, 50% efface, loose hanging bag of membranes. Sagittal suture placed obliquely with anterior fontanelle on the maternal left side towards the pubic symphysis. So this is ROP position. Okay, now I have particularly made this question like this so that you can appreciate you can appreciate what ROP presentation will look like on clinical examination. How will it be described? Even if this was LOA position, whatever position, your answer would not have changed. What should be done next? She is low risk. This is first examination. Okay, she is right now only 4 centimeter dilated, partially effaced cervix. Even if we go by the WHO standards, we need 5 centimeter at least dilatation with a good enough effacement to tell, so to say that she's entered into active labor. So why would I want to intervene unnecessarily, right? So she is getting moderate contractions, fine, but I don't want to unnecessarily intervene, no, right now. So any intervention will be done once I will say that she is in active labor. So right now there is no need for oxytocin infusion. If you are going to rupture the membranes right now, see the bag of membranes, the dilated, tense, bulging bag of membranes also helps in dilating the cervix. Okay, so this is, so early rupture of membranes unnecessary, no. There is the mother is doing well, the fetus is doing well, why? Right? So wait and watch for spontaneous progress. Now, haven't you read in your lectures that if there is ROP position, most of the times favorable rotation will take place and there will be normal delivery, right? So wait and watch is the first management of ROP position. Okay, even if in this question it was other position, LOA, LOP, LOT, whatever, answer would have still remained wait and watch for spontaneous progress of labor, and cesarean section is out of the question. Right? So where will you say cesarean section? Please remember, cesarean section you will say when there is arrest of active phase dilatation. Then you will say cesarean section should be your answer. What is the definition of arrest of active phase dilatation? She is at least 6 centimeter dilated. Okay, and she is stuck at whatever dilatation she is. So stuck at 6, maybe stuck at 7, maybe stuck at 8, maybe stuck at 9. So at least 6 centimeter dilated with 4 hours of good contractions, membranes absent, and no change in dilatation. Then you will say arrest of active phase dilatation, and then your answer becomes cesarean section. If there is slow progress, if there is slow progress, but not arrest, she is not qualifying arrest, the definition of arrest. She is qualifying the definition of slow progress. If there is slow progress in active phase, then you see if contractions are inadequate. If contractions are inadequate, then you think about giving oxytocin infusion. So you see if your membranes are already absent, you give oxytocin infusion. If your membranes are present, then you do ARM first. Then you do ARM first, followed by plus minus oxytocin if needed, followed by plus minus oxytocin if needed. So generally ARM we will do, and immediately after ARM we don't tend to start oxytocin. We wait for half an hour or so to see if there is any spontaneous increase in contraction because of the ARM, and then we'll decide whether or not we need to go for oxytocin infusion. So this is how you are going to approach such questions. Now let's have a look at the next question. A low risk primary at term was admitted in active labor, cephalic presentation. Okay, so far so good, low risk cephalic, second stage for 2 hours, right? So this does not qualify as arrest of second stage, but still this is definitely prolonged second stage. This is definitely prolonged second stage. There is fetal bradycardia, that's not okay, right? So you need to act fast, right? She's getting 4 contractions in 10 minutes. That is good enough contractions, each lasting for 50 seconds. The fetal head is at +3 station and sutures in AP diameter. So things have been simplified for you. It's a rotated head. The membranes are absent. There is caput, but there is no molding. So right now there is no evidence of CPD as such given in the question. So first of all, you decide that you have to act fast and you have to deliver. right? So criteria for instrumentation is being fulfilled. So instrumental vaginal delivery we have to do. Now what is the most appropriate next step? Very good, very good, all of you answering correctly. Outlet forceps, the forceps that you're applying when the skull has or the head has reached the pelvic floor, okay, sorry, has reached the perineum, has descended to the perineum, that will at least be +3 station, at least be +3 station. That is outlet forceps. Mid cavity forceps we are not doing anymore. Low forceps are at +2 station. Low forceps are at +2 station. Why not ventouse? Ventouse we did not prefer because there is caput already, so the grip with the ventouse would be not that good. So ventouse, that's why not preferred. There is caput and there is also significant bradycardia, so that is why outlet forceps are the best answer to choose in this situation, right? Same question, if the criteria for instrumental vaginal delivery was not getting fulfilled, maybe she was not completely dilated, right? Maybe not completely effaced, right? Maybe station was +1, 0, -1. So basically +2 and beyond. Na? For instrumentation, you have to have +2 station and beyond. So if the criteria was not getting fulfilled, then your answer would have been cesarean section. If there was any evidence of CPD, if they had written, grade 3 molding, you would have said cesarean section would have been the answer. Clear? Now, next question. 26-year-old multiparous, previous cesarean, at term active labor, right? Pulse rate, tachycardia, her BP is fine. She's getting good contractions. Baseline fetal heart rate 120, which is okay, but with persistent late decelerations. Cervix fully dilated, efface, vertex +1, sutures LOA. So as far as PV findings are concerned, PV findings are looking fine. There is nothing wrong with the PV findings, but the liquor is meconium stained. Which of the following is the most appropriate management? And you will also give me the diagnosis. You will also give me the diagnosis. What is your most likely diagnosis, right? So yes, you want to go for an urgent cesarean section, right? With a previous cesarean and fetal heart rate changes, maternal tachy also. Maternal tachy is non-specific, but persistent late decelerations. Initially, there is fetal tachy. Initially, in such situation, I am giving you clues. Initially, there is fetal tachy, but later on, it will evolve to variable decelerations and then late decelerations, and eventually fetal bradycardia may happen, and then fetus may die also. So this is uteroplacental insufficiency you are saying, but something very specific I am pointing at. Bache, uteroplacental insufficiency, yes, but I am pointing at something very specific. Okay, even if there was uteroplacental insufficiency, right, why would you be in such a rush to go for an urgent cesarean section? I mean, you could have, taken your sweet time, maybe give her an hour or so, but you can't. You have to do a category 1 cesarean section in these situations. Now, can you come to the diagnosis? You have to do a category 1, meaning that the moment you decide to take her up for cesarean section, within 30 minutes, one should be delivering the baby, and you would have seen this rush happening in the labor room at times, when we completely just go, berserk, and we kind of, okay. So meconium aspiration syndrome. Now, meconium aspiration syndrome is something that will be identified, mind you, once the child is born. So meconium aspiration syndrome is something that you read up in pediatrics. Why? See, the baby is in the, yes, the meconium has been passed. Whether the baby has aspirated it or not is another matter, right? What is happening here is fetal distress. Yes, of course, only one person has come up with the answer. Uterine scar dehiscence. Yes. This is potentially, now scar dehiscence is something, scar dehiscence is something which is a, scar dehiscence meaning that the scar is giving way. It is incomplete rupture. Okay, this is, I would say, impending scar rupture. This is impending scar rupture. This is impending scar rupture, meaning that The scar is giving way. Yes, scar dehiscence, impending scar rupture, all the same thing. Incomplete rupture. What is incomplete rupture? Where the peritoneum lining is still intact, right? So I have to act fast because it may progress to rupture in a matter of no time at all, right? And there are times when we take up a patient for impending scar rupture. By the time we open her up, we realize that the scar is completely gone away. It is complete rupture. So final diagnosis, whether it was impending scar rupture or whether it was complete scar rupture, many times is made on table after opening up the patient. So this is urgent cesarean section you have to do. After so many clues, we came to the right answer. So they could have asked you, what is the diagnosis? And they have asked this question, what is the diagnosis? They could have given you placental abruption as options, scar rupture as options, as meconium aspiration syndrome as another option, as uteroplacental insufficiency as another option. This is impending scar rupture. Look at the entire clinical profile. The earliest, most definitive sign of, which should not miss, of impending scar rupture is fetal heart rate abnormalities in a woman with previous cesarean section during trial of labor after cesarean. Clear? Right? All good? Let's see the next question. Yes? All right, next question. A primigravida at 37 weeks present with complaint of decreased fetal movements. There is no history of abdominal pain, leaking or bleeding PV. Per abdomen shows that the uterus is term size and relaxed. NST is done and the strip is shown below. What is the most appropriate next step? So yes, this was a recent question in the exam, and this is from the recent INI-CET exam also. So yes, you are right. Correct answer is perform NST for full 40 minutes. Before we label as non-reactive NST, we do for complete 40 minutes, right? So what is a reactive NST? Reactive NST meaning that there are 2 accelerations in 20 minutes. Remember? And each acceleration should be at least 15 beats per minute, at least lasting for 15 seconds. Correct? Right? And this you have to do for 20 minutes to label as reactive. Along with that, there should be, along with that, the beat to beat variability should be 5 to 25 beats per minute. The baseline also we have to see. It should be between 110 to 160 per minute. Right? Acceleration should be there. So all of this has to be seen in a reactive NST. If it is not reactive, then we have to go for full 40 minutes before labeling it as non-reactive and intervening further. So immediate induction of labor, whether cesarean will be needed or not needed, what we will do, we will decide based on what is the complete, whether after full 40 minutes. And I would also like to see the AFI in this patient, or I would want to do a biophysical profile in this patient after I have labeled a non-reactive NST. And then I will decide whether I want to go for a cesarean or whether I want to induce labor in such a patient. That will depend upon, again, my clinical findings, PV findings, whether the cervix is favorable for induction or not. So that decision, that choice will come later. Right now, you perform NST for full 40 minutes. Now, also remember, INI-CET very fond of asking you questions on CTG traces. So please remember variable decelerations. Remember this image, okay? You'll get the PDF, so don't worry, you can revise them there. So variable decelerations will have an abrupt decrease in the fetal heart rate, and it is not related to contractions in the sense that it can come with contraction, without contraction, after contraction, like that, right? Now, concerning features of variable deceleration are if they are also having absent beat to beat variability, if there are no shoulders. See here, this is a variable deceleration. This is also a variable deceleration, right? So this is with shoulders, these are the shoulders, and this is without shoulders. So when the without shoulders it is there, no shoulders are there, then it is a very concerning feature. If the depth of the deceleration is more than 60 per minute, it is a very concerning feature. If the variable deceleration lasts for more than 60 seconds, it's a very concerning feature, right? And they happen because of cord compression. For INI-CET particularly, also remember that variable deceleration are mediated by the baroreceptor reflex of the fetus, blood pressure fluctuations. Okay, so I'll just write it here, baroreceptor mediated. Okay, now early decelerations, as you can see here, the decelerations are going to be a mirror image of the contractions, right? Now early decelerations are associated with head compressions. They are because of vagal stimulation. Remember this also for questions. And late deceleration, see here, the deceleration is coming late. There is a delay in the deceleration as far as the contraction is concerned. They are associated with fetal hypoxia, uteroplacental insufficiency also, right? And also remember here that they are basically chemoreceptor mediated. Okay, chemoreceptor mediated. These are extra pointers for INI-CET. And also note that these are the definitions of category 3 trace. Category 3 trace meaning that if this is the feature of the CTG trace, then delivery has to be expedited. Right, so absent variability with any one, absent variability with bradycardia, or absent variability with recurrent variable, absent variability with recurrent late decelerations, or a sinusoidal baseline. So any of these traces, it is category 3 trace. This is definitely a dangerous trace, ominous, threatening, and delivery has to be expedited in this situation. Next question. All right, next question. So, labor room progress of labor questions we have done, basic CTG question we have also done. Now, Primey is admitted at 34 weeks with complaint of leaking for past 4 days. Okay, 34 weeks leaking for past 4 days. Pulse rate is 110, that is tachycardia. BP settled, temperature 102 degrees Fahrenheit. Symphysiofundal height is 32 centimeter, less than the period of gestation. Uterus feels tender. Fetal heart rate is 160. So, what do you see here? Fetal tachy, okay, maternal fever, and history of leaking. You have to connect the dots. There is foul smelling vaginal discharge, os is closed, cervix is long. She has not yet gone into labor. Ultrasound shows a single live fetus, absent like a fundal placenta. Baseline investigations are sent. What's the next step? So, this is what? This is PPROM. This is PPROM, preterm pre-labor rupture of membranes. And she's 34. Okay. So, baseline investigations are sent. What is the next step in management? Yes. Very good. Option number D. Option number D. See, steroids, first of all, what you're missing here is PPRM. Very good, Dr. Panigrahi said, and I think the first one to say. A clinical case of PPRM, but now also having chorioamnionitis. In the context of leaking PV, right, the single most important finding going in favor of chorioamnionitis is fever. The additional findings, tender uterus, foul smelling vaginal discharge, these are all going in favor of chorioamnionitis, right? So, right now you have to give antibiotics, and with chorioamnitis there is no conservative management anymore. Okay, the fetus could die. Very high grade fever could itself kill the fetus. Fetus can die also in utero now, or fetus can also have, newborn may have neonatal sepsis, maternal sepsis can also happen. So, this can lead to complications even further. So, there is no question of conservative management. Induction of labor has to be done and antibiotics have to be started. This is broad spectrum antibiotics. Broad spectrum antibiotic covers you have to give. Please remember that. And yes, fetal tachy also goes in favor of chorioamnionitis. So, you mentioned Rukmini, fetal tachy also. Yes, but fetal tachy again is not very specific, but in this context, maternal fever, tender uterus, foul smelling discharge, vaginal discharge, these are more in favor of chorioamnitis. But fetal tachy, yes, I would take that, but not very specific, right? So, you give antibiotics and induction of labor, no tocolysis, no delaying delivery at all. Giving antibiotics alone, not the best answer. And what about steroids? See, steroids are contraindicated when there is chorioamnionitis, right? And also she is already 34 weeks, so the question of steroids does not come. So, that's why steroids are not chosen, right? And Rukmini, if you think about broad spectrum antibiotics, ampicillin and erythromycin will not give broad spectrum antibiotic coverage, right? Your broad spectrum antibiotic coverage would either come from ceftriaxone and metronidazole combination, some penicillin and your metronidazole for anaerobic coverage, or it will be Ampigenta plus metro, like that, right? Fine. So like that. Next question. A woman delivered a healthy baby vaginally followed by delivery of intact placenta. Okay. After an hour after delivery, she gets up to pass urine and collapsed. Her pulse rate is 110, blood pressure is 80/50, and uterus is well contracted. Vaginal bleeding is within normal limits. What is the most likely diagnosis? Think before you answer. Okay, that is what I would like to tell you guys. Think before you answer. Okay, let's go step by step. She's collapsed. She's hemodynamically unstable. Let's say she's having postpartum collapse, pulse tachy and low BP, right? So the first thing that comes to my mind is blood loss. First thing that comes to my mind is PPH, an hour after delivery, right? Uterus, first thing that comes to your mind after PPH is atonic PPH. Most common is atonic PPH. This is how, the point is that you know it. You guys know it. You know the basics. You've read this, right? But you have to also train yourself to thinking fast, right? So the first thing that comes to your mind is what is it, atonic uterus? And the moment you see that the uterus is well contracted, it's not atonic uterus. Vaginal bleeding is within normal limits. Okay. Even if it's a succenturiate placenta, if you are picking a succenturiate placenta as the answer, what do you mean succenturiate placenta? You are saying that a lobe is left behind. You are saying that an additional lobe is left behind. Additional lobe is left behind and it is causing bleeding. How is it causing bleeding? Because it is not allowing the uterus to contract. So if it is left behind, where is the bleeding coming from? Yaar? It would be visible, no. It would be visible, it would still be visible. If there is any genital tract trauma and that is causing bleeding, it should be visible. So, succenturiate placenta, I will not say, is the answer. Why? Otherwise, the uterus will not be able to get contracted very well, right? Now, amniotic fluid embolism. Now, retained placenta bache followed by delivery of intact placenta. 1 hour later, the situation has happened. So, placenta has already delivered, okay. Now, amniotic fluid embolism and genital hematoma. Anybody wants to change their answer? Only a few of you only chose option D as the answer. Amniotic fluid embolism typically presents, either during labor or within 30 minutes of placental delivery. This is quite late presentation. Moreover, okay, in amniotic fluid embolism also, visible bleeding may be within normal limits initially because DIC and vaginal bleeding sets in later. I agree. But what is the problem with the embolism? What is amniotic fluid embolism? Particulate of amniotic fluid are gaining access to the lungs. That is embolism per se. Anything circulating in the blood, when goes to the lungs, it's embolism, right? It could be thromboembolism, air embolism, it could be amniotic fluid embolism, right? So the patient will have immediately cardiorespiratory symptoms, breathlessness, cyanosis. That is the clinical presentation. Right? Initially, there is hypertension also, but later on cardiogenic shock will happen and then hypotension will happen. So, that is why it is not amniotic fluid embolism. Okay, genital hematoma is a more likely possibility. Hematoma meaning blood getting collected, right? Fine. Abhi isme they have not told that what is the local examination findings. Maybe there is a vulval hematoma, maybe there is a vaginal hematoma, because it is all collecting inside the hematoma. The bleeding is within normal limits. The vaginal bleeding seems to be in normal limits on the pad, but it may be collecting inside a hematoma. So, genital hematoma is the most likely diagnosis based on the findings that are given to you, and I will not choose amniotic fluid embolism as the answer here. Clear? Right? So, we need to see a flow chart. We need to see a flow chart of postpartum collapse. Okay, most common cause is PPH. First thing, please notice vaginal bleeding present or not. If vaginal bleeding is present or vaginal bleeding is excessive, the moment you see that the uterus is relaxed, the fundus may be palpable above the umbilicus. Why? See, fundus may be palpable above the umbilicus because the uterus may be filled with clots. That happens. You'd say atonic uterus is your answer. Okay, you start managing the atonic uterus. Atonic PPH is not responding to uterotonics. What do you think? You ensure that you are not missing out any trauma. Ensure that you rule out genital tract trauma. Okay, fine, because there may be a component of genital tract trauma which is also contributing to the PPH. If the uterus is well contracted, right, then you think about genital tract trauma, explore the cervix and the vagina. You think about the possibility of genital tract trauma. Okay. If the uterus is well contracted and there is no tear in the vulva, vagina or cervix, meaning that you have explored but you found nothing, okay, and bleeding is coming out of the os. See, bleeding is coming out of the os. That means you have examined everywhere, okay, you have examined the vulva, you have examined the vagina, you have examined the cervix, but there is no tear or laceration anywhere and bleeding is coming from out above, from the os. Then you're thinking about uterine tear, you're thinking about uterine tear, you're thinking about uterus rupture, and then they would be telling you something in the history which will say, okay, that uterine tear or rupture is likely to happen in a patient. Circumstances around the delivery are going to be your biggest clue in attempting such questions. They may tell you that there is hemoperitoneum because if the uterus has ruptured, maybe some bleeding is collecting inside the peritoneum. History of difficult delivery, history of VBAC may be there, grand multiparity. Some clues in the history would be there to help you with the diagnosis. Now, if the vaginal bleeding is within normal limits, so it is not visible to the outside. So, if it is not visible to the outside and the patient is hemodynamically unstable and collapsed, you then think about the possibility of it being hidden. So, if there is features of hypovolemic shock, uterus is well contracted, and the other clue which was not mentioned in the previous question but could be provided to you to ease your answer, perineal pain, history of perineal pain, not past urine, think about genital hematoma. And you explore the vulva, vagina, cervix, explore the lower genital tract. If vulva and vagina and cervix are normal, if vulva and vagina and cervix are normal, and per abdomen the uterus is deviated to one side, per abdomen the uterus is deviated to, let's say, one side, and blood, there may be a possibility of broad ligament hematoma. And broad ligament hematoma is also not very common, it is uncommon. Then circumstances around delivery, difficult vaginal delivery, maybe a previous cesarean section, patient was there and had a difficult vaginal delivery, difficult instrumental vaginal delivery, then you think about these possibilities. So, broad ligament hematoma, very good, Preeti. And if you have a situation where there is bradycardia, sudden bradycardia in postpartum collapse, per abdomen fundus not palpable, this is going to be your biggest clue. Don't miss this out. Disregard everything else, just focus on fundus not being palpable. Any history suggestive of mismanagement of third stage of labor, you're looking at uterine inversion. Okay, very good, Danish. And breathlessness, if you see, if your primary complaint, okay, if your primary pointer is breathlessness, cyanosis, hypoxia, signs of heart failure, you think about pulmonary embolism. Think about pulmonary embolism. Always look for signs and symptoms of DVT also. Pulmonary embolism with signs and symptoms of DVT, you can think of thromboembolism. Thromboembolism. And then this one here, during delivery of or within 30 minutes of placental delivery, first hypertension and right ventricular failure followed by hypotension, later DIC and cardiogenic shock. This is amniotic fluid embolism. This is always a diagnosis of exclusion. This is a diagnosis of exclusion most of the times. Okay, Fine. So remember this flow chart, keep this flow chart in mind, all right? Next question. You are delivering a multiparous woman in the LR. Baby delivers uneventfully. You're following AMTSL protocol. You encounter difficulty in delivering the placenta. In another 10 minutes, you realize the placenta has not separated and complete uterine inversion occurs, right? So, you see some mismanagement in the third stage, some difficulty experienced, right? Placenta has not separated and uterine inversion occurs. Heart rate is 160 and BP is 80/42. Postpartum collapse with maternal bradycardia, what would be the best course of action? Excellent everybody, manual reposition with placenta in situ, right? So please remember that when you were doing the placental separation and uterine inversion occurred, right, and placenta has not separated, it could be a morbidly adherent placenta, you don't know. And the more you try to, pinch and remove in bits and pieces, the more it will bleed. So, any attempt at placental removal should be undertaken after manual removal of, after manual repositioning of placenta. Then you go for manual removal of placenta. First reposition with placenta in situ, and then we go for attempting manual removal in this particular situation. So, manual reposition with placenta in situ, obviously ideally in OT. Okay. So, immediately attempt to remove the placenta? No. Right. Oxytocin infusion, see, when acute inversion happens, like this, we stop oxytocin because we don't want the uterus to contract when the inversion has happened. We want to first reposition immediately and then start oxytocin. Okay, because with a contracting uterus, it will become very difficult for repositioning the uterus. So, oxytocin infusion not now. Oxytocin infusion is started after repositioning. And obviously not in labor room. Yes, under anesthesia, Preeti. Yes, under anesthesia, ideally in the OT, under and by a senior obstetrician also. With simultaneous resuscitation, if blood is on its way, then blood, preferably with blood in hand, but blood has to be on its way, so you cannot delay. So, resuscitation will also continue simultaneously as in every case of PPH, right? Now, next question. A G2P1L1 woman, history of previous cesarean, delivered vaginally. While delivering, placenta umbilical cord gets avulsed. Patient starts to bleed profusely. What's the best course of action? Yes, Sherlock, hello. What's your answer? Everybody. Yes, history of previous cesarean delivered vaginally. Umbilical cord gets avulsed. That means avulsed meaning you were pulling at the umbilical cord, maybe with a lot of force, or maybe with a good enough force, with an adequate force, but something is wrong here. And that is why even with the moderate degree of force, you were pulling and it just got avulsed. It was too much force that was applied, right? So, the possibility of morbidly adherent placenta is again here. So, this is, what is your diagnosis? This is a retained placenta. This is now a retained placenta, okay? And it could be a morbidly adherent placenta, particularly because she is previous cesarean also, because the more the number of prior cesarean sections, more is the risk of having a morbidly adherent placenta, right? And the patient starts to bleed profusely also, so maybe the placenta is separating in bits and pieces, who knows, right? As long as the placenta doesn't separate, it's very interesting, as long as the placenta doesn't separate at all, bleeding does not happen, because bleeding is happening from the placental attachment site, which is which is exposed. So maybe it's separating in bits and pieces. So now manual removal of placenta in OT. Okay, this waiting and watching and oxytocin infusion and allowing for some more time for the placenta to separate, it is only applicable as long as the patient is stable, as long as there is no active bleeding. Then only you can continue with this uterine massage and oxytocin infusion and attempt at controlled cord traction. There is, and cord gets avulsed, cord is in your hand, it has gotten avulsed, so this is anyways out, right? And anyways the patient is continuing to bleed profusely. So this option of this waiting with oxytocin infusion in these circumstances is, let's say, only till 60 minutes from delivery if patient is stable and no active bleeding, only in that circumstance. Otherwise you proceed with manual removal of placenta in OT. Clear? Fine. So with this question we revise the scenario of retained placenta as well. And one more thing, since I have been talking a lot about morbidly adherent placenta, can you tell me what is the problem with morbidly adherent placenta? It is attached to the myometrium, it is penetrating deeper. What is the defect here? What is the defect here? Monica, yes, these MCQs can definitely help in FMG also. I personally feel there is no difference left now in an FMG exam or NEET exam, or you have to clear your concepts, bache. If your concepts are clear, you clear any exam, and none of these questions are difficult. Yes, so there is defective Nita Bush layer, very good, and there is absence of decidua basalis. The most common risk factor, as we saw in the previous questions where I kept emphasizing, is the previous cesarean section, right? And the risk is directly proportional to the number of previous cesarean sections. That means more the number of previous cesarean section, more is the risk. And maximum risk. Now, what do I mean by maximum risk? If I have a patient who comes to me antenatally and there is history of previous cesarean section, and in this pregnancy, history of previous cesarean section, and in this pregnancy, she is having placenta previa, this will give the maximum risk. Okay, so with morbidly adherent placenta, we can have a surprise diagnosis, meaning that we were not aware this was a morbidly adherent placenta. We ended up with a complication like uterine inversion. We ended up with a complication like retained placenta. And when we tried attempting manual removal of placenta, under these circumstances, when we were caught in those circumstances, we tried attempting manual removal of placenta and plane of cleavage was not found. Or history tells you that there is placenta separating in bits and pieces. Then your diagnosis is a morbidly adherent placenta. Right? This is one situation. The other situation is that I have my eyes and ears open when I do my antenatal checkup, and I know that this is a risky situation, and I try to make an antenatal diagnosis. So for antenatal diagnosis, yes, what is the investigation of choice, or let's say what is the initial investigation? Yes, right? So let's look at this chart here. Let's look at this chart here and try to remember the key points. You can have increta, you can have accreta, and you can have percreta. Increta is that it is just in the myometrium, just entering into the myometrium, so infiltrating into the myometrium. Accreta is, it is just attached. A for accreta, A for just attached superficially to the myometrium. And percreta could be that it has perforated the myometrium, and perforated the myometrium meaning completely perforated, reaching up to the serosa or maybe even to the nearby structures, like anteriorly it could be the bladder. Right? So investigation of choice, anybody, the images that I have given to you, see, this is a grayscale. On the left here, this is a grayscale sonography where this is the placenta, okay, where this is the placenta. Yes, this is the placenta here, okay, this is the placenta. The overlying myometrium, you will have to remember this, the overlying myometrium is thin and there is a sonolucent zone Okay, there's a sonolucent zone behind the placenta. There's loss of this retrolucent, retroplacental sonolucent zone. And grayscale ultrasound will not be able to give much information. Information will be by Doppler. Okay, so ultrasound Doppler. We need to see the blood vessels. So you see on ultrasound, placental lacunae or lakes with turbulent flow. So what do we see here? These lacunae. This is the placenta and these are the lacunae that we are seeing. And on Doppler, turbulent flow. Okay, or hypervascularity of bladder and serosa interface. This is the bladder in front. This is the bladder in front, placenta here. Okay, just label it for you. This is the bladder in front, this is the placenta here, and the interface between the two, hypervascularity, right? So this would tell us about morbidly adherent placenta as far as antenatal diagnosis is concerned. Okay, MRI, of course, I will do depending whether I need it or not, right? So MRI is needed, let's say in difficult cases when ultrasound is not giving a diagnosis and the suspicion is there. So inconclusive ultrasound findings, sometimes the placenta is posterior, difficult to visualize on ultrasound, then we order an MRI. And surgical planning, like if I have any doubts that this could be infiltrating inside the bladder, or it could be, and I want a urosurgeon with me also, right? Or it could be a percreta, which is, perforating into the nearby tissues, and I want assistance, and I want basically a multidisciplinary approach to planning a surgery, right? Then I would like to order an MRI. I don't want to enter the OT unprepared. I want to be prepared and enter the OT, right? So that is the thing. So MRI, yes, if needed, would be done. Okay. Now, next is your these images. As you can see these images, right? This is the patient which we had an antenatal diagnosis, and this is the anterior placenta here in the lower uterine segment. It is this is percreta. It is almost coming up to the serosa, but it is not perforating the serosa. What we did was we gave an incision at the fundus. We gave an incision away from the placenta. Okay, we don't want to cut the placenta and cause bleeding, and we don't want any more blood loss than is necessary, right? So what have we given? Incision here we have given on top. This is a hysterectomy specimen, right? So we gave the incision, delivered the baby, okay, cut the cord, and did not try to attempt to remove the placenta. So the placenta is in situ, as you can see, and one has proceeded with hysterectomy. So please remember, what you need to remember here is, if we have an antenatal diagnosis, the standard of care, meaning what is counseled to the patient is that she has an elective cesarean section at a tertiary care hospital where multidisciplinary approach is available, right? Anytime between 34 to 37 weeks, right? Okay, so elective cesarean section, right? And we are also going to advise her to proceed with hysterectomy. After delivery of baby and leave the placenta in situ. Because we may end up, if we try to separate the placenta, we may end up having a situation where placenta separates in bits and pieces, and bleeding happens. And what we tend to see is that this bleeding becomes very difficult to control, because the bleeding will get controlled only and only once the placenta is completely removed. So we don't want to end up in that soup. So we try to proceed with hysterectomy straight away. This is the standard of care. This is what is advised to the patients. And conservative surgery, I mean not proceeding with the hysterectomy, is only and only if the woman understands the risks involved and she categorically says that no, I don't want a hysterectomy. But this is the standard of care. Okay. Next question. You are conducting the delivery of a multiparous woman with gestational diabetes in labor. The estimated fetal weight is 3.5 kg. These are just clues to tell you that, okay, there is, possibility of a large for gestational age fetus. These are clues to tell you that there is a possibility of large for gestational age fetus. After delivery of the head, the shoulders do not deliver spontaneously and head recedes back onto the perineum. This is the turtle sign. extra pointer, please remember. Identify the maneuver used to deliver the shoulders. So again, they're asking you a lot of questions on shoulder dystocia. They're asking you a lot of questions on shoulder dystocia. Please remember that with shoulder dystocia, first is call for help. First is call for help, right? Do not push from above and do not pull from below. No fundal pressure, no pulling at the baby's head, immediately shifting the woman to McRoberts maneuver. What is McRoberts maneuver? Flexing the thighs, flexing the woman's thighs onto the abdomen and abducting the thighs. That is McRoberts maneuver, right? And we can ask in addition the assistant to give suprapubic pressure. So what is most important? McRoberts maneuver is most important, and that is what is shown in the image, right? What about the other maneuvers? Let's just see here. This is the Ridzen maneuver. This is the image showing the Ridzen maneuver. Okay, now Ridzen maneuver is for controlled delivery of head. Controlled delivery of head in cephalic delivery, right? In vertex delivery like this. Controlled delivery of the head by extension. We all know that head delivers by extension, isn't it? So we have to control the delivery of the head. This is done by Ridzen maneuver, and one hand is supporting the perineal area and also, you know, helping to lift the chin up also. So this is basically to prevent the perineal tears. And this is the Lancet's maneuver. Lancet's maneuver is for delivery of extended arms. Delivery of extended arms, right? Delivery of extended arms in breech presentation, right? And also remember here that the Zavanelli is the last resort maneuver. So we try McRoberts first, okay? After that, we can try the other, rotational maneuvers where we'll have to rotate the baby. So if McRoberts is successful, fine. Otherwise, we can try later. What we can try? We can try the rotational maneuvers. Rotational maneuvers like the Rubin's maneuver, right? Wood's corkscrew maneuver. And if that also doesn't work, then we can ask the woman to go on all fours. Gaskin's all fours. Yes. Somebody mentioned Gaskin's all four, right? So woman is asked to get down on all fours, right? Knee chest position, and then all the maneuvers, they are repeated again. And if that is also not successful, then comes the maneuvers of the last resort, like fracturing the clavicle, cladotomy, symphysiotomy. And Zavanelli is basically pushing the head back in and then delivering by cesarean section, something that I've never witnessed in my real life at all. I've also read in textbooks only about the Zavanelli maneuver. So there are maneuvers of last resort also, right? So this is about the shoulder dystocia maneuvers, and please also remember other maneuvers I've given with your, the image is I have given you, right? Okay. So look at this Shiv, I'm not able to get your question, right? अभी ये देख लो बाकी maneuvers अगर तुम्हें यहाँ दिख जाता है कोई जो आप पूछ रहे हो, right? So Morisot smelly wheat is for delivery of after coming head in breech, as you can see, and Burn Marshall is again for delivery of after coming head in breech, right? Piper's forceps again for after coming head in breech. So these are together for after coming head in breech, and this is again after coming head in breech, but when the back is posterior, dorso-posterior. Okay, Pinard's, P for Pinard's, P for finger in the popliteal fossa. This is how we all have remembered when we were also giving exams. So delivery of extended leg, right? And groin traction is for delivery of the buttocks, and Ruchen's incision is for after coming head through an incompletely dilated cervix. Please remember that the incision is not given at 3 o'clock or 9 o'clock position, because so you can see the incision is given here, maybe also here on the other side, and one at 6 o'clock may also be given, but not on 3 o'clock or 9 o'clock. Why? Because of the descending cervical artery, right? Fine. So we may cut the artery and then it may lead to a lot of bleeding. So these are the maneuvers and these are the images that you need to recall in the last minute. Okay. Now, moving on. Let's see another question on breech. This is a clinical question on breech. Now, 28-year-old G2P1L1 comes for routine ANC visit at 37 weeks with breech presentation. She had a cesarean section for fetal distress in last pregnancy 3 years ago. So, she is currently breech with previous cesarean section. That much we know, breech with previous cesarean section. That is the gist for now. Ultrasound shows a single live healthy intrauterine fetus. Flexed breech, estimated fetal weight about 3 kg, AFI 10 centimeter, placenta fundal. Nothing stands out, isn't it? Everything seems okay. Baby is okay, baby is healthy, flexed breech. All of the following options are offered to her except, yes, very good. So, I've got one correct, one incorrect. Let's see more. She is 37 weeks. She is 37 weeks. Breech with previous cesarean section, right? Whatever needs to be done. See, I don't even want to look at other option. I mean, why would you want to admit right now for a cesarean section? Is there any indication for an urgent cesarean section straight away? No, there is no indication for an urgent cesarean section straight away. So you can offer her the other options, but not this. I mean, I don't think there is, she's low risk, breech with previous cesarean section. Baby is doing well, mother is doing well, she is not in labor right now, right? Everything seems fine. Why would I admit her immediately for a cesarean section to LR, right? Give her options, right? One option is that she fulfills the criteria for external cephalic version, and we can schedule it in the next few days because she's already 37. We can give her that choice and we can decide when we will want to plan, right? She can say, okay, I am okay for external cephalic version. She may say that, no, I don't want external cephalic version. You say breech vaginal delivery, she actually, if you look at it, she can be allowed for a breech vaginal delivery also, if you look at this. But with the previous cesarean section, I don't want to go for a breech vaginal delivery. With the previous cesarean section, I don't want to go for an external cephalic version also, but previous cesarean section patients can be offered an external cephalic version. Right. So, these are options that are there. Previous cesarean section is not an absolute contraindication for a breech vaginal delivery. Previous cesarean section is not an absolute contraindication for external cephalic version also. So, that option is also there. She says, no, I don't want external cephalic version, I am not willing for breech vaginal delivery. She says, okay, you have the option of going for an elective cesarean. We say, okay, fine, we will plan an elective cesarean section for you. But why right now? If we want to schedule, we will schedule at 39 completed weeks. Even with one previous cesarean section, patients, or even if she did not have a cesarean section, whether she had a cesarean section or not, whenever elective cesarean sections are planned, we want to plan them after 39 completed weeks. Okay, there will be only exceptional circumstances when I would say, okay, there is some other indication, some obstetric, some medical reason why I want to do it earlier. For now, it doesn't seem anything like that I want to do it earlier. So, I will schedule a cesarean section at 39 completed weeks. So, all three choices are there. All three options are fine, which can be offered to her. But I don't want to scare the hell out of her and just admit an LR for cesarean section straight away. That is malpractice without giving her options. So, admit an LR for cesarean section is not the correct thing to do. So, all of the following options are offered except admit an LR for immediate cesarean section. That's your answer. So, I've had students telling me that, this clinical management of breech presentation, it becomes very difficult to remember what to do under what circumstances, right? The point of the matter is that they will not ask you everything from here, right? You have to get the gist. First of all, remember that all women who fulfill the criteria, whether they are primary, whether they are multi, all women who fulfill the criteria, they should be offered external cephalic version, right? And Rukmini, like you said, ECV is not preferred in ECV is not preferred in women with previous cesarean section. It's a relative contraindication. It's not an absolute contraindication. The prerequisites, I tell all my students just to remember these 6 points. These are the absolute prerequisites of offering external cephalic version. She should be more than 36 weeks. Okay, and we tend to do it at 37. Singleton fetus. Now think about it. If there is prematurity, you don't do. These are absolute contraindication to external cephalic version. Look at this. Prerequisite, remember, more than 36 weeks, singleton. Prematurity. If there are multiple fetuses, multiple pregnancy, how are you going to go for external cephalic version? It becomes technically not feasible. Pelvis adequate, needs to be adequate. If pelvis is only inadequate, how will it help in turning the baby from breech to cephalic? So, pelvis inadequate. Okay, if the placenta is low-lying, that itself is an indication for cesarean section. If placenta is low-lying, what difference will it make if I shift the baby cephalic, right? Liquor adequate, membranes present, right? Liquor should be adequate, membranes present should be there. So, oligohydroamnios, the procedure becomes technically difficult and fraught with complications, so not preferred to do, right? Membranes absent, we will not do, because if the membranes are absent, cervix is opening up and you're doing external cephalic version, cord prolapse can happen. You don't want that, right? No GCA, healthy fetus. Baby should be healthy. There should be no GCA, right? If there is a GCA in the baby, if there is a fetal distress, then you don't want to go for external cephalic version, right? And there should be no preeclampsia, hypertension. So preeclampsia or hypertension are also absolute contraindications. So these are the absolute contraindications. You remember this. Previous cesarean section is a relative contraindication. Macrosomia is also a relative contraindication for external cephalic version. Okay, clear? Now only two absolute indications for cesarean: footling breech. Okay, woman comes, let's say, many times what happens is footling breech generally tends to be picked up during labor when the os opens and the only feet are felt on PV examination, the buttocks are high up. One can also confirm with ultrasound, but generally clinical examination is good enough. So footling breech, absolute cesarean section. Breech with hyperextended head, which is also called as stargazer breech. These are the only two absolute indications for cesarean and breech. The rest in between situations. Wherever you see complicated breeches, cesarean is the preferable choice. Okay, not the absolute choice. All right. So sometimes, like I described to you with the question, I discussed with you with the question that patient can discard the other options, say I want to choose cesarean. So patient request. Large baby, right? Previous cesarean, apparently healthy, viable preterm baby, right? So basically estimated fetal weight less than 1500 to 2000 grams, and she's either in active labor with breech presentation, or we are planning to go for a indicated preterm delivery for some medical or obstetric indication. We're going for an indicated preterm delivery. Then it is better that we go for a cesarean if it is apparently healthy and a viable preterm baby, severe fetal growth restriction, or there is a fetal anomaly that is incompatible with the vaginal delivery. There's a fetal anomaly like a huge hydrocephalus, okay, and even if we make it cephalic, it will not deliver by vaginal route. So think about it like that, right? And history of prior perinatal death, right? So that is why I say remember this absolute indication for cesarean, remember the prerequisites, understand this, and because your options will have, your questions will have 4 options. Nobody is asking you there in your exam to enumerate these things, right? So you understand with logic, and these are the 2 most important tables to remember, and then the rest will make sense to you. Right now, Dipanvita, your question is internal podalic version still preferred in a twin pregnancy with the latter at breech? No, see, okay, your question is, okay, we are answering Dipanvita's question, right? So second you are saying is breech, okay? Latter meaning you are saying second twin as breech, right? So first twin was cephalic, okay, and the second twin is breech. So the first twin delivered cephalic, okay, first twin, this is twin 1, this is twin 2, first twin delivered cephalic, second twin is breech. It will have an assisted breech vaginal delivery. Why will you do any version of anything? The version is when the first twin is cephalic and the second twin is transverse. Okay, right? So first twin deliver and the second twin which is in transverse lie, that can be delivered by internal podalic version. That is the only place in obstetrics where internal podalic version is done. Delivery of second twin in transverse lie. Internal podalic version, only situation where it is done, delivery of second twin in transverse lie. Got it? Right? Now, next question. An unbooked multiparous woman, grand multiparous woman seen in emergency in labor. Vitals are stable. So, you are seeing her for the first time. Okay, vitals are stable. Per abdomen shows that the fetal heart, fundal height, corresponds to 30 weeks and the fetal head is in the right flank. Fetal heart sound not localized on stethoscope. Local exam, cord is lying outside the introitus and cord pulsations are not felt. What would be the best course of action? So, this is cord prolapse with a dead baby, right? What would be the best course of action? Very good. Very good of those of you who are saying cesarean section, right? So, right now, see, understand here that we are doing now cesarean section not for the baby's sake but for the mother's sake, because it is transverse lie. It is transverse lie. Okay. So, repositioning the cord back inside the vagina, okay, it makes, see, anyways, any undue fiddling of the cord is discouraged. Okay. No repositioning of the cord is done. Positional changes are done, Trendelenburg position or Sims position, all that is done so that the cord slips inside the vagina on its own. Any undue handling of the umbilical cord by undergraduate students is strongly discouraged, because any fiddling causes further vasoconstriction in the umbilical vessels and further compromises the oxygen delivery to the baby. Right. So, this is one thing. So, this is not the answer right now, right? Now, internal podalic version and vaginal, I just told you that there is only one situation where internal podalic version is done, that is delivery of second twin in transverse lie. Here we are talking about singleton, this is out. Waiting and watching for spontaneous vaginal delivery. If in this particular situation, it was a cephalic presentation, for example, or it was a situation where vaginal delivery was for the patient, but there is no chance, right? But there is no chance of a vaginal delivery. This is a term pregnancy with transverse lie, right? So, that is why answer is a cesarean section. So, that is the reason the answer here is a cesarean section. Clear? Now, next question. What is the correct sequence of active management of third stage of labor? Yes, correct sequence of active management of third stage of labor. D? Are we saying D, or these are for the new question? Okay. So, mix, I am getting your responses. But majority of you are saying option number C. So, yes, option number C is the correct thing. But see, now you see, this is how, when you read in textbooks, you read the components of active management of third stage of labor, which start with uterotonics. So, you disregard other options and you say uterotonics are the first thing to give. Okay, yes, but if you understand here that delivery of all the babies have to happen, then only third stage of labor will start. So, if there is a second twin, the second twin will have to deliver, no? Then the third stage will start, na? Then the active management of third stage of labor will begin. If there is another fetus on the way, you don't start with the active management of third stage of labor, no? You deliver all the babies, whether it is twins, triplets, whatever. Right. So, this is a PYQ, this is a straightforward PYQ. Yeah. So, I always tend to twist PYQs a little bit so that it becomes a sort of different and we can analyze multiple things. But you check for another fetus is the first thing that you need to do. And after that, yes, uterotonics, right? And after that, yes, controlled cord traction. And after uterotonics, you've given the uterotonics. Even before controlled cord traction, if there was another thing, then you would have, so this would have been checked for another fetus, then uterotonics, then after uterotonics would have been delayed cord clamping, and after cord clamping would have been control cord traction, right? And uterine massage, according to WHO, it is not a component, but there's no harm in doing uterine massage. Government of India says uterine massage needs to be done, so that's okay. But WHO says intermittent uterine tone assessment is also is recommended if we have already given the uterotonics, right? Now, uterotonic of choice, please remember, uterotonic of choice for us is oxytocin 10 units IM. This is the drug of choice for active management of third stage of labor. Please keep in mind this chart. I'm not going to go through the entire chart. I'm just going to tell you the important things to remember. In PPH, it is basically we give IV infusion. Please remember, it is never IV bolus. That is an important point to remember. High dosages should never be given IV bolus. Whenever it is IV, it is by IV infusion, because IV bolus can cause sudden hypotension, tachycardia, right, or even cardiac arrest, right? Methergin is something that we, again, the dose you need to remember, 0.2 milligram. It can be given IV or IM. It's generally not preferable for active management of third stage of labor, because it can lead to increased risk of retained placenta. And one also has to rule out other contraindications like hypertension, preeclampsia, heart disease, peripheral vascular disease, Rh negative pregnancy. We don't give methergin. Please remember the contraindications also. Hypertension, vasoconstriction are the very specific side effects of methergin. Misoprostol is also a drug that can be given for active management of third stage of labor, where maybe oxytocin is not available. Then this misoprostol can be given. For PPH, 800 micrograms sublingual. These are all WHO recommended dosages, right? Fever and shivering are the most common side effects. Nausea and vomiting are also there, and there are no specific contraindications as such for oxytocin or misoprostol. Carbetocin, please remember, highlight here, carbetocin is only recommended for active management of third stage of labor. The dose is 100 microgram. Remember, the question have been asked about the dosages also, and it is not used in PPH management, right? Symptometrin is a combination of oxytocin plus methergin, and it is also, it can be given for active management of third stage of labor. In our labor rooms, it is not used, and nobody is going to ask you question on that, but just to fill the chart. For PPH treatment, is it not recommended? Now, yes, they ask you questions or carboprost, which comes under the trade name Hemabate, right? It is not recommended for AMTSL, not for active management of third stage of labor, but for treatment of PPH, yes. 250 microgram every 15 minutes, maximum 8 doses can be given at a go, so maximum of 2 milligram dose in one go. And diarrhea, nausea, vomit. Diarrhea is the most common side effect. Diarrhea is the most common side effect, and it's contraindicated in bronchial asthma because bronchoconstriction is a side effect. Also, please remember that PGE2, that is dinoprostone. Dinoprostone is not recommended for AMTSL. It is not recommended for PPH. This is another prostaglandin that we are talking about. This is for cervical ripening agent in induction of labor. That is where this is used. So remember this chart of uterotonics as well. Now, next question. 25-year-old woman delivered her first child by cesarean for arrest of labor. We had a similar question in your INI-CET this time, and even in FMG. You are assisting with your senior. Placenta and membranes are expelled, but the uterus is atonic. So we're dealing with atonic PPH. And if you read through the story, fluid resuscitation is begun. So resuscitation is begun. Bimanual uterine compression is being done. Okay, and all the uterotonics, as we discussed above, they are exhausted. Her pulse rate is 120, BP is 90/60, so she is still unstable. So we have taken time, we have exhausted the uterotonics. It is atonic PPH, right? This is how you're going to go for the keywords. Atonic PPH, unstable, 2-unit blood on its way. What would the most appropriate step? Uterotonics are exhausted. Bimanual uterine compression you're doing. What would be the most appropriate next step? Patient is already, acha. See, cesarean was done. Patient is already in OT. Open abdomen. Patient unstable. Blood is also taking time. It has not yet come. It is on its way, right? Balloon uterine tamponade we were doing as a step in which we were hoping to avoid a laparotomy. है ना. Balloon uterine tamponade we were doing with the hope that we would avoid a laparotomy. Okay, this will work. So if it works and the bleeding stops, we will not be going for a laparotomy, and the patient becomes stable, and we will continue with the resuscitation. That was what we had in mind. Now the patient is already on table, already open, cesarean was being done. So now B. Lynch sutures is your answer, and not stepwise devascularization. For those of you who are saying C as the answer, but you just think about it, just think, B. Lynch suture, just visualize that B. Lynch suture, visualize the tamponading that we are doing, when we are trying to, compress the uterus. Basically, the anterior and posterior walls of uterus, they are compressed like this, right? Why? Because bleeding is happening from the placental attachment side, from the open sinuses. That is why we need to tamponade the uterus, right? B. Lynch sutures are exactly doing that. That is what we are doing, right, with B. Lynch sutures also. So they are working better. B. Lynch sutures are always preferable when there is atonic PPH. Okay. Now, what your stepwise devascularization, it will take time. Patient is unstable here. So in the face of atonic PPH, stepwise devascularization is less preferable. Okay, sometimes during cesarean section, it so happens that the uterus incision in the lower segment, that is bleeding a lot. And obviously the location is such that if I do a uterine artery ligation, it will take care of the bleeding at the incision site. Okay, sometimes the incision could be extending upwards, and then I may plan to go for internal for a ovarian artery ligation also. So stepwise devascularization is not preferable when there is atonic PPH. So keep that in mind, right? And internal iliac artery ligation, which is also component of stepwise devascularization, will be again time consuming. We will have to dissect the retroperitoneum. So in the face of atonic PPH, usually, and especially with unstable patients, we don't have time like that, right? So that's why B. Lynch sutures is the answer, not balloon tamponade, not stepwise devascularization. And even your internal iliac artery ligation also is not very effective in atonic PPH, not very effective, right? And uterine artery embolization, what is uterine artery embolization? It's basically ligating the uterine artery. Think about it, na? Ligating the uterine artery, but without a laparotomy. The purpose is the same, right? Whether you ligate the uterine artery after opening up the abdomen and laparotomy, or you do our interventional radiological procedures and block the uterine artery circulation by uterine artery embolization. What you're doing is depriving the uterus of the blood supply from the uterine artery. But this embolization is an interventional radiological procedure. You cannot think of doing this for a patient who is unstable. The patient has to be stable, and the active massive bleeding should not be there. Only then it will make sense for going for uterine artery embolization, not like now, isn't it? So this is out. So that's your answer to this question. Next question. A pregnant woman at term fell on her stomach, and now she has come with complaints of continuous pain abdomen, right? So these are questions. I could have asked this question and I could have said, give me the diagnosis, and I could have given you options like, I'll not give you the option. I want to know from you what is the answer. So fell on her stomach, so trauma, continuous pain abdomen, bleeding. Since that episode, uterus term size feel tense, tender. She's getting contractions, so she probably has gone into labor also. Fetal heart rate 120, her pulse rate is 90, BP is 120 by 70. So she is otherwise stable right now, but uterus is tense and tender. Emergency ultrasound shows that the placenta is in the upper segment and no retroplacental clots are seen. What is not done in the management? So for that, you need to know the diagnosis. Yes, it's a diagnosis is placental abruption. Diagnosis is placental abruption. Abruption is essentially a clinical diagnosis. We have ruled out that placenta previa, right? We have done a scan immediately. See, whenever a patient presents with antepartum hemorrhage, please remember, before doing a PSPV, first thing you need to do is an emergency ultrasound to rule out previa. Placenta is in the upper segment. Okay, no retroplacental clots are seen. See, retroplacental clots can, look very similar to placenta also on ultrasound appearance. So, that is also there. No retroplacental clots could also mean that everything is revealed. She's coming with bleeding, so it could be revealed abruption. That is why no retroplacental clots are there. So, clinical diagnosis is that of abruption, right? So, when abruption is there, she is at term. So, there is no question of, conservative management at all, right? So, you are going to deliver. Right. So, augmentation of labor is done. Yes. Right. Urgent investigations arranged for blood. Yes. Per vaginal examination. Obviously, yes. Right. Now, you have ruled out whether it is previa or not. Placenta is upper segment. So, now you want to do a PV and see if she's already dilated. If she's already dilated, we can do ARM. On ARM, blood stain liquor will come out. Our diagnosis is anyways confirmed. Doing an ARM will also improve the contractions, increase the contraction. It will help in augmenting the labor, right? So, you see here, she is getting contractions also. So, it fits into this classical clinical presentation of placental abruption. This is what we do. We rule out placenta previa, proceed with the PV, decide what needs to be done. How we need to augment the labor? Does she need induction? Does she need only augmentation? So, yes, this is done, but there is no point in delaying the labor. There is no point in doing tocolysis. Tocolysis in cases of placental abruption is only under exceptional circumstances when there is extreme prematurity, the bleeding has stopped and it is exceptional circumstances. Let's not talk about that, but tocolysis to arrest labor with bleeding abruption is not the norm, okay? Right. And yes, you are right, Rukmini, Page classification is the clinical classification system to grade the severity of placental abruption, right? So, whenever we have previa with abruption, how are you going to differentiate? Look at the antecedent history also. Abdominal trauma, hypotension goes more in favor of abruption. With previa, it's the painless, causeless bleeding, right? And generally, the first episode is the warning hemorrhage. It generally tends to stop, but it can recur anytime. With abruption, the bleeding can be altered, dark colored bleeding that can be there in concealed abruption, or everything could be fresh bleeding if it is all revealed also. Pain is going to be present, that goes more in favor of abruption. Then go for the abdominal exam. Fundal height is going to correspond to period of gestation in previa. With placental abruption, fundal height is more than period of gestation. Like for example, if there is concealed hemorrhage, or it could also be equal to period of gestation if it is all revealed hemorrhage. Okay. Now, concealed is more dangerous. Why? Concealed is more dangerous. Why? Concealed is more dangerous. Why? Because there is more risk of DIC. There is more risk of DIC. There is more risk of DIC if the concealed abruption is there. Okay, so please remember this also. Per abdomen, uterus tense, tender, contractions are there, and the tone is increased. The uterine tone is increased. Please remember this as well. And fetal heart rate, fetal distress could be there. Fetal distress more goes in favor of placental abruption. And with the placenta previa, the uterus is going to correspond to period of gestation, uterus is going to be relaxed, and the fetal heart rate is usually going to be normal. PSS PV is not done till you rule out previa, right? So, ultrasound is done to rule out placenta previa. This is the investigation of choice. If placenta is in the lower uterine segment, we will make the diagnosis of low-lying placenta, and placenta in the upper segment, placenta previa is ruled out. Now, I'll just take up the other question. Now, management of placental abruption is simultaneous resuscitation and delivery. And wherever possible, vaginal is preferable. Please remember, cesarean section is for obstetric indications. DIC with the abruption is also correction of DIC and delivery, which is preferably again vaginal delivery. Indication of cesarean section is one, fetal distress, or if there is any contraindication to vaginal delivery. And the other indication for cesarean is far from delivery with severe abruption, right? So, this is on a case, this is judged on a case to case basis. So, generally questions are not framed on this, because again, this is not expected out of undergraduate students. Now, there is a question here, even if patient is 32 weeks, in case, can we proceed with delivery with steroid coverage? Yes, yes. Yes, so you got it right, right? So even if there is a preterm patient who's less than 34 weeks, has placental abruption, is actively bleeding like that, right? You would start with the steroid cover, go with the steroid cover, and start the process of augmenting the labor also simultaneously, right? So please remember that, okay? So one thing that will be added in that situation would be steroid cover. Right? Now, the most common fetal complication with abruption is prematurity, because of the simple reason that these patients will most likely deliver. The conservative management for placental abruption is under exceptional circumstances, where it's like under exceptional circumstances. So most of these babies, most of these fetuses with placental abruption, we will end up delivering them, and that's why prematurity is the most common complication. Now, what about bleeding placenta previa? If there is a patient with bleeding placenta previa, now let's just finish off the APH flowchart. Okay, always admit, resuscitate, and work up. That is going to be the first thing, and decide what needs to be done. If she is already term, that means she is already beyond 37 weeks, more than 37 weeks completed. If she is already in labor, if any of these is there, if she is hemodynamically unstable, if fetal distress is happening and the fetus is considered viable and healthy, so for the fetus's sake, or if the fetus is already dead. If the fetus is already dead, fetus is already out of the equation, then we don't want to end up losing the mother also. And the only way that the bleeding stops is when the baby is delivered and the placenta is out and the uterus contracts, right? So when the baby is out of the equation, we don't want to sacrifice the mother, and then we go for a cesarean section. Okay, bleeding placenta previas are always delivered by cesarean section, right? So please remember, placenta previa is placenta that is covering completely or partially covering the internal os, that is placenta previa. Please remember this. What is low lying placenta? A placental edge within 2 centimeters of internal os. Even if the placental edge is within 2 centimeters of internal os, vaginal delivery cannot be allowed and will not be allowed. Okay, so whether it is placenta previa, whether it is partially or completely covering the internal os, whether it is low lying, when the placental edge is within 2 centimeters of internal os, management or the delivery option is always by a cesarean section. Okay, now let's say the woman is preterm. Provided that there is no active bleeding, all have to be there. Provided no active bleeding, fetus is viable, there is no fetal distress, and she is not yet in labor, we can go for conservative management. Conservative management here is called as McAfee protocol, right? Where we admit the patient, keep her under observation with monitoring, give the steroid cover also, rest, and anti-D is given if she is RH negative, right? Now, let's say for example, there is a woman in the second trimester, she has a low lying placenta on scan. Okay, then please remember, you repeat the scan again at 32 weeks to check if it is still low lying. If it is still low lying, you will repeat again at 36 weeks. Okay, if it is still low lying, then what do you do? She's never bled. She has never bled. What do you do? Fortunately, she has never bled. She has not come to the emergency with an episode of bleeding. She's following up in the OPD. So you checked again at 32, it is still low lying. You checked again at 36, it is still low lying. Now don't wait for her to bleed. We plan for an elective cesarean section at 37 completed weeks. 37 completed weeks. Don't wait for her to bleed, right? Now, next question. 18 weeks primigravida presents with a high risk of neural tube defects and low risk of trisomy 21 on quadruple testing. What is done next? Yes, high risk of neural tube defects on quadruple testing. How would you know? Raised, what levels would be raised? Raised maternal serum alpha fetoprotein levels, more than 2.5 multiples of median, right? So what is done next? Yes, if there is neural tube defect risk, these are structural lesions. Neural tube defects meaning anencephaly, and encephalocele and meningocele. They are diagnosed on ultrasound, structural anomalies. So targeted sonography is done, right? We don't need a genetic diagnosis, we don't need a DNA analysis, we don't need to check their karyotype. So why would we go for chorionic villus sampling, right? So chorionic villus sampling, amniocentesis, even NIPT, NIPT I'll just discuss in a bit, chorionic villus sampling, amniocentesis, these are all procedures to take the fetal tissue and analyze that fetal tissue for karyotyping analysis. For fish you can do, right, chromosome microanalysis you can do. So when we want to check for genetic disorders, right, we want to check for aneuploidies and have a confirmatory diagnosis for that, then we would go for such sort of invasive fetal testing. Your investigation of choice and diagnosis for neural tube defects is made by targeted sonography. So that is going to be done. What is NIPT? Let's have a look here. NIPT is also a screening test, cell-free fetal DNA testing. NIPT is also a screening test. These are all screening tests. These are all prenatal aneuploidy screening tests, right? So we have first trimester combined screening, right, and we will offer depending upon when the patient is seen by. So first trimester combined screening consists of serum beta HCG and PAPE. So serum beta HCG and PAPE, if they are the only test that is done, this is what we called as dual screening. This is what we called as dual test. Okay, to this we add nuchal translucency. Nuchal translucency is seen on transvaginal sonography. Look at the image on the right here and try to remember. This is what nuchal translucency is. This is what nuchal translucency is. At the nape of the neck, this sonolucent zone of fluid, right? And this is your NB, nasal bone. This is your nasal bone, right? So this is also sometimes called as this anti-NB scan. Anti-NB scan done here. 11 to 13 weeks, 6 days, right? Quadruple testing is done in the second trimester, contains of serum beta HCG and maternal serum alpha protein, unconjugated estriol, inhibin A. Okay, please remember high, also asked in question, right, that what is elevated in Down syndrome. Please remember in Down syndrome, high. So HCG is high, right, and inhibin is high. Rest all are low. So low PAPE, low this thing, and low unconjugated estriol, right? Remember this in Down syndrome, that is trisomy 21. Okay, extra pointer again in trisomy 18. Trisomy 18, this is trisomy 21. Trisomy 18, both are low. In trisomy 18, HCG is also low. All are low and inhibin is not included in the calculation of the risk. And less than 3 mm is normal. Yes, for NT, abnormal would be more than or equal to 3 mm. Okay, please do not confuse NT with nuchal skin fold thickness. Nuchal skin fold thickness is second trimester soft marker. Okay, this NT, that is why don't say this as, call it as nuchal thickness. Call it as nuchal translucency, and nuchal skin fold thickness is something else. It is a second trimester soft marker. And nasal bone should be present. Nasal bone absent is going to be a soft marker. Okay, nasal bone absent is going to be a soft marker for Down syndrome. Now NIPT can be done anytime beyond 10 weeks, right? Cell-free fetal DNA which is circulating freely in the maternal blood. So maternal blood sample is taken. There are techniques by which we can extract the cell-free fetal DNA, and that fetal DNA can be analyzed nowadays for trisomy 21, 13, 18 and monosomy X, and also now for checking fetal blood group and RH status as well. So these are the extra pointers, keep them in mind. Now, next question. In which of the following conditions affecting a woman, treatment of the male partner is definitely needed? Yes, very simple question, very simple question. Vulvovaginal candidiasis, see the risk factors for vulvovaginal candidiasis would be like risk factors for any other fungal infection, right? Like when the immunocompromised is there, when immune status is compromised, or when immunomodulated state of pregnancy is there, then vulvovaginal candidiasis happens. Or sometimes also there is a history of taking prolonged antibiotics, that can also affect the risk and can increase the risk of vulvovaginal candidiasis. candidiasis. Okay. Now, bacterial vaginosis is not a sexually transmitted infection. Vulvovaginal candidiasis can be transmitted sexually, but it is usually not a sexually transmitted infection. Very uncommon for it to be sexually transmitted. So this is out. Bacterial vaginosis is not a sexually transmitted infection. It is just altered vaginal microflora, right? Now, this is not the answer. Now, you people are telling me genital herpes and trichomonas vaginitis, both are sexually transmitted infections, right? So, which one will you choose if you have to choose one best answer? I would say trichomonas vaginitis. I would not say genital herpes. I'll tell you why. Because the male partner is usually the carrier. Okay, the male partner is usually the carrier and asymptomatic, right? So what happens is that you cannot eradicate herpes. You cannot eradicate genital herpes like that. You know, you cannot get rid of it forever, right? So yes, you do test the husband. You do test the husband if he is the carrier, right? But any acute episodes of genital herpes are treated. Even the woman who is having this genital herpes, right? As long as she is having those herpetic lesions, she is contagious. You heal the lesion, you give the acyclovir treatment and the lesions disappear, but still she will keep shedding the virus. In her, so the partners will keep giving it to each other. There is no getting rid of the herpes virus. Right. So there is no point, and you don't just treat the male partner unnecessarily. You will definitely examine the male partner, take a history, test the male partner if he is a carrier or not. Supposing he is not the carrier. Then you will have to advise barrier contraceptives to prevent that infection from reaching the male partner. Isn't it like that? Right. So herpes, yes, you are right. Herpes, obviously it will go to latency and can reactivate later. वो तो रहेगा. So that's why answer is not genital herpes. Right. And we have read up in the notes. That with trichomoniasis, partner treatment is definitely needed. So syndromic approach to vaginal discharge, I will quickly go through this flow chart. The PDF will be available to you, so do not worry, right? Whenever a woman comes with vaginal discharge, right, take the history of the patient and the partner, PS and PV, additional test if needed. Please remember, when we are doing a per speculum examination, if we have to take any sample, then please take it. Okay? Don't do this that you do a per speculum and then we, then we do a PV, and then we forgot, oh, sample had to be taken, then you reinsert, you were already washed away the discharge, everything. So even when you take a pap smear for that matter, now you put in a speculum, you take the sample, whatever is necessary, and then remove the speculum and then complete your examination and do a PV. So keep this in mind. So extra bit, right? Cervix is healthy. If the discharge is coming from the vagina, it's vaginitis. If these are the characteristics of the discharge: thin, milky white, fishy odor, no itching, pH is alkaline, wet mount showing clue cells, whiff test positive, all this is part of Amsel's criteria. The diagnosis is bacterial vaginosis. The treatment is metronidazole, the drug of choice, right? The other drug can be given is clindamycin, right? In pregnant woman, it is the same. The drug is not changed, it is the same, but vaginal metronidazole, that is what you will give. Curdy, cheesy white discharge, dysuria is also there, itching is also there, pH less than 4.5. Wet mount, we can see fungal pseudo-hyphae, whiff test is negative. This is candida. Treatment is fluconazole. Okay. In pregnant women, fluconazole oral is contraindicated, so vaginal clotrimazole. Right? Greenish, frothy, foul smelling discharge, again intense itching. Remember, greenish and pH is alkaline. And the other clue they can give you is strawberry, cervix or vagina. Flagellated organism, which has a tennis racket appearance, can be seen on the wet mount. So this is how they can also, integrate it with microbiology slides also. And whiff test is positive. This is trichomoniasis. Treatment is drug of choice is metronidazole. Right? Then they also tend to ask you on NACO kit. So please remember the green colored kit, kit 2, I remember green for the greenish discharge of trichomoniasis. and that is how I know that it is for vaginal discharge. Okay, so secnidazole and fluconazole are there in this kit. And treatment is given for the symptomatic partner. If the cervix is unhealthy, they may tell you that the cervix looks unhealthy, bleeds on touch, there is discharge coming out of the os, and there are no signs and symptoms of PID. See, if there is uterine tenderness or adnexal tenderness or cervical motion tenderness, the clinical diagnosis is that of pelvic inflammatory disease. If there are no signs and symptoms of PID, it's only cervicitis. Always one does additional testing, like, if there's a cervical discharge, one can go for gram stain or nucleic acid amplification tests. If the discharge is actively not coming out, then endocervical swab can also be taken. Now, gram stain, if showing WBCs and no organism, presumptive diagnosis is that of chlamydia, because it's a fastidious organism that does not show up on the gram stain. If the gram stain is showing gram-negative diplococci, it is presumptive diagnosis is gonorrhea. Okay, and for chlamydia, you have doxycycline, you have azithromycin, right? And for gonorrhea, you have ceftriaxone plus azithromycin. So, with ceftriaxone plus azithro, in the sense that ceftriaxone plus chlamydia coverage also you have to give. So, when you have this cervical discharge, you have a grey kit given by NACO. I think this is also covered from your derma faculty, right? They are also teaching you the syndromic approach. So, anyways, cervical discharge is grey kit, right? So, I remember G for gonorrhea and G for grey, and I remember cervical discharge with gonorrhea. That's how I keep in mind. So, azithro single dose and cefixime single dose is there. Treatment of symptomatic partner. And for pelvic pain, that is PID, I remember P for PID, P for pelvic pain, P for pus, and then I remember yellow, right? This is the kit for yellow kit, right, for PID, and this is for treating the patient. And for the male partner, remember, treatment of symptomatic partner with grey kit. For the male partner, you have to give the grey kit. On this also question was asked. Okay. Now, next question. Which of the following is true regarding cervical cancer screening in low resource settings? Okay, so all of us know that in low resource settings, a lot has been said about via visual inspection with acetic acid, and it makes a lot of sense, right? Because all you need is acetic acid, all you need is a speculum, right? And actually, currently also in our peripheral healthcare centers, in our community healthcare centers, we have visual inspection with acetic acid only. But this question now, I think they've probably asked from the latest WHO recommendations. They are not very latest also. These are 2022 or late 2021 recommendations. So, they've been around for quite some time now. And the thing is that nowadays the WHO is promoting and also asking the governments to make low cost point of care HPV test kits available, where even self sampling by women is okay. So, co-testing, so if you understand this question by logic also, co-testing means doing two tests simultaneously. Pap also, HPV DNA testing also, it is going to add to the cost, right? Pap smear will need all that infrastructure, need the pathologist, need the equipment and everything, the centrifugation of the sample and analysis of the slides and everything. So, these are not cost effective, right? So, that's why these are not the answer. So, we had to choose HPV DNA testing of some sort, right? So, HPV DNA testing starting every 5 years, starting at the age of 30. So, the WHO says starting at the age of 30. The WHO says starting at the age of 25 only for HIV positive women. Okay. So, for in general population, it says start at the age of 30. So, that is why this is your answer. Option C is your answer. Okay, and also you want to offer it in low resource setting. In low resource setting, WHO is also saying that you do at least do one HPV DNA testing at the age of 35 and then do another at the age of 40. So, 10-year interval. So, they are saying actually WHO is saying 5 to 10 year interval between two HPV DNA test. So, lifetime, in the lifetime, every woman should at least get 2 HPV DNA tests. That is what the WHO is saying, right? And that is applicable in low resource settings. Okay, clear? But yes, every 5 years starting at age 30 would have been the best choice answer. This is an exact PYQ. I did not fiddle with this because I wanted to discuss this with you. And that why this answer is the best choice answer. Right. So, this is the WHO update that screening starts at age 30 for general population, it is only with HIV positive where screening starts at 25 years of age. The most priority age group is 30 to 49 years. HPV DNA testing as the primary screening test every 5 to 10 years is what the WHO says. We in our setups are doing it every 5 years if we are offering it to a woman. Cytology, that is pap smear, is acceptable. Via, according to WHO, is acceptable if they are done every 3 years. Via is particularly useful for us in our setups with particularly low resource settings where even HPV DNA testing is not possible, where the low cost HPV DNA tests are not yet available. So Via for us is very good. That is what we are doing. And the WHO approach says screen and treat, screen, triage and treat, right? So when we are doing screening and treating, we screen at the same time and we treat at the same time. So again, we can screen with HPV DNA testing or with any of these tests, but this screen and treat is only for low resource settings. Screen and treat is for low resource settings. Otherwise, mostly it is going to be screen, triage and treat. So if there is a screen positive, then you triage. That means you do a colposcopy, right? So if screen is positive, then colposcopy needs to be done to identify the abnormal area to take the biopsy from, right? Now, Rukmini, if Via was in the option, then you would choose Via. Okay, if Via was in the option, choose Via because that is particularly good in low resource settings. So I would go, considering Indian scenarios, we are still stuck on Via for low resource settings. Next question. A 28-year-old woman with BMI of 30 kg per meter square presents to the infertility clinic, right? So she is obese naturally. She has irregular cycles and has been trying to conceive for past 3 years, so infertility. Husband semen analysis normal, pelvic exam normal, mild hirsutism. So 2 out of 3. Right, are there. Irregular cycles is there, mild hirsutism is there. So clinical evidence of hyperandrogenism is there. So your diagnosis is PCOS. Right, diagnosis is PCOS according to Rotterdam's criteria. Right, so lifestyle modification always has to be told to the patient whether she wants to get pregnant or not get pregnant, doesn't matter, right? So weight reduction obvious, right? And ovulation induction she will need, yes, and drug of choice for ovulation induction is letrozole. Gonadotropins are second line drugs, right? Metformin is given as a part of insulin sensitizer, right? Now also remember here finasteride, spironolactone, these are anti-androgenic drugs. These are anti-androgenic drugs, right? They are drugs which are second line for hirsutism. These are second line for hirsutism. Okay, even so first line for hirsutism, what is the first line drug for hirsutism? Oral contraceptive pills, right? And second line for hirsutism are the anti-androgenic drugs. Which among the two, finasteride or spironolactone? Spironolactone. Cost also and less effects on liver function also. 2 reasons why spironolactone is going to be preferred. But please also remember, whenever anti-androgenic drugs are given, they have to be given along with oral contraceptive pills. Okay, woman cannot be expected to conceive while on these drugs because these drugs will cross the placenta, will reach the growing baby. These are anti-androgenic drugs. If there happens to be a male fetus, then the sexual development of the male fetus will be compromised if these drugs reach the fetus. So while the woman is taking this treatment, she is not allowed to get pregnant. So anti-androgenic drugs, these are generally prescribed along with oral contraceptive pills. So they are out of the question. Not needed, right? So the criteria for diagnosis of PCOS, just let's have a quick rapid recall. This is what we were talking about, the Rotterdam criteria, right? So menstrual cycle abnormalities will be there. Clinical and or biochemical evidence of androgen excess will be there. So in this particular case, there was hirsutism, clinical was there. Ultrasound appearance of polycystic ovaries, right? So remember this image was asked in your latest exams, right? So if you look at the ovaries, there's nothing too peculiar about the ovaries to look at on laparoscopy. It's just that they are bulky. They are bulky, right? And they are bulky not because they have cysts. Actually, polycystic is simply a misnomer. There are numerous follicles, right? We are counting the 2 to 9 mm follicles. 2 to 9 mm follicles is what we are counting. And to call as polycystic appearance of the ovaries, it is the number of follicles that is important. So follicle number more than or equal to 20 is the latest. Original Rotterdam said 12. Original Rotterdam said 12, but the new ESHRE guidelines say 20. More than or equal to 20 follicles on transvaginal sonography, right? And or the ovarian volume is more than 10 ml, okay? And both ovaries need not be polycystic, okay? Even one ovary, so ultrasound appearance of polycystic ovaries in either ovary, one or both, doesn't matter, could be polycystic in appearance, right? Now also please remember that there are other features like stromal hyperplasia, right, and this necklace appearance, okay, or the string of pearls appearance. See how they are organized in the ovary, they are looking like a necklace appearance or string of pearls appearance. No, so these are not part of the criteria. Part of the criteria is number of follicles, which is important. Also remember the hormonal changes. LH is to FSH ratio is more than 2:1. Sex hormone binding globulin levels are decreased, and the serum AMH levels are elevated, because serum AMH is coming from the smaller preantral and antral follicles. They are numerous. So serum AMH levels are also elevated, more than 5 nanogram per ml usually, right? So Shiv and Mani, again telling you, I think in each you are mentioning, in each ovary not necessary. Even if one ovary is polycystic, it is enough for the criteria to get fulfilled. So polycystic meaning polycystic appearance in either ovary. That means even in one or both, doesn't matter. Okay. Now lifestyle modification, weight reduction encouraged, not willing to conceive. The drug of choice is oral contraceptive pills. I have already told you this. First line drug for hirsutism in PCOS is oral contraceptive pills. For ovulation induction, letrozole is the drug of choice more than clomiphene citrate, but both are first line drugs. Role of metformin is as an insulin sensitizer. So all of this has been discussed. Next question. All right, so let's do one thing. We have a couple of more questions left. I think we have done a lot of OBS questions. I think now gynae questions are left. And before, I think we all need a break. Before we do these questions, which will require at least some major concentration on our part, right? So maybe some tea, coffee would be good enough, right? If it's 10 in right ovary and 10 left ovary, it will not be. It will not be. Yeah. ऐसा नहीं, combined polycystic appearance नहीं. It's one. Okay, so you are right. It will not be polycystic appearance, right? Right. And don't worry, they generally don't ask you this question. But just remember that it's an either ovary. Even if one ovary is one ovary is qualifying the criteria. So one ovary could have more than or equal to 20 follicles, other is not qualifying the criteria, but one is na. So in either ovary it is polycystic appearance, the criteria will be fulfilled. Okay. And before only you have answered this question, but I will take up the explanation after a break, and I will just take 10 minutes break, and you people have got these 10 minutes. If you want to grab a cup of coffee, tea, and just take your breaks, do that, and I'll see you in 10 minutes. Be back in 10 minutes. So we're back after the break, and I can see few questions here that do we give metformin? Vishal is asking. I don't know if Vishal has come back from the break or not. Is metformin given to all patients with PCOS? No, not necessary. Metformin is given if there is features of insulin resistance. One of the feature of insulin resistance is acanthosis nigricans also, right? And yes, the best way to countering insulin resistance is actually by lifestyle modification, isn't it? But then again, it will not, I mean, it will take some time for that lifestyle modification to set in, right? So metformin as and when indicated. So sometimes, you know, women have problems dealing with their weight and they're not able to, you know, go for weight reduction with that rate, and features of insulin resistance are there, then metformin can be given. Another situation where metformin we give is, let's say for example, we were trying for ovulation induction, right, with these patients with letrozole or with clomiphene citrate, and it's not working. We before gonadotropins, we want to try giving metformin along with the ovulation induction agent. So that also we have tried, right? So it's not, or let's say for example, a patient with PCOS has got you know, features of metabolic syndrome, right? Like for example, this waist to hip ratio and all. It's very important that we go for this, you know, GTT testing and lipid profile testing in women with PCOS also, because they are at risk of metabolic syndrome. So if they have features of metabolic syndrome, then also it would be a good thing to give them metformin, right? So if indicated, it's not needed for all PCOS patients. In fact, even ovulation induction is not necessary for all patients. We have seen women with PCOS and they are young in age, and you know, maybe you know, they are, and with lifestyle modification alone, their cycles become regular, their cycles become ovulatory, and they go on to have spontaneous conception. It is only when they have difficulty conceiving, right, then we can give them ovulation induction. So even ovulation induction is not necessary, if you see, in all women with PCOS. All right. So I guess that has answered the question. And so the ones who were answering, the ones who were active on the group chat, let me get a thumbs up that you are back, right? So that we can start off with the next question. Amenorrheas is always a hot topic with INI-CET, right? So let's just see now. Okay, so one thing about these questions, okay, these amenorrhea questions, they are best solved by eliminating options and by having a clear understanding of the basics. There are huge flowcharts that I will lay out in front of you. The thing is that whenever you are solving these questions, no, it happens to me also. The flowchart doesn't flash in front of my eyes. Okay, it never does, right? Nobody remembers it like a photograph of a flowchart that you remember like that. Okay, this is not how it works. Flowchart helps you in revising. When you read a flowchart, what do you understand out of that and what do you recall out of that flowchart is important, because that is how you are going to attempt these questions, by logic, by eliminating options. That is the best way, I have figured. Okay, so 16-year-old girl presents with primary amenorrhea. Breast development is Tanner stage 3. That means breast development is normal. If the breast development is normal, estrogen levels must be normal. Pubic hair is present, that means androgen levels must also be normal. Androgen is acting also on the tissues, that is why pubic hair is. So there is no problem in the hormones. If there is no problem in the hormones, right, if the estrogen levels are normal, that means nothing is wrong with the HPO axis. That means the pituitary must also be normal, the hypothalamus must also be fine, the ovaries must also be fine. That's why the hormones are absolutely normal. So where is the problem now? Problem is in the uterus. So Coleman syndrome, you should know what these syndromes are. Now, to attempt such questions, you should know what these syndromes are. So, Coleman syndrome is not the answer. Even in Coleman syndrome, the karyotype will be 46XX. No problem with the karyotype there. But there is congenital deficiency of GnRH. So, FSH and LH levels have to be low. And a pubertal girl, in this young girl, anything less than 5 would be considered low. Androgen insensitivity out, it is 46XY. I don't need to read anything. Pubic hair absent, uterus is absent. Gonadal dysgenesis. Gonadal dysgenesis. In gonadal dysgenesis means, it could be any kind of gonadal dysgenesis. This here is not Turner syndrome obviously. But gonadal dysgenesis, what does it mean? That the gonads are not producing hormones. So, if the gonads are not producing hormones, estrogen deficiency should be there, breast should be absent. So, this is not the answer. So, answer is Mullerian agenesis. Even if they have not told you, have they told you anything about the uterus? No, they have not told you anything about the uterus, but the uterus must be, because other diagnosis is not fitting in. So, it must be Mullerian agenesis. That is your answer. This is how you best attempt such questions. Okay. So, let's see the flow chart now. And the flow chart is not for mugging up. The flow chart is for understanding the basics. See, absence of menses by 13 years of age, in the absence of secondary sexual characteristics, and by 15 years of age in the presence of secondary sexual characteristics, that is when you will say delayed puberty or primary amenorrhea. The first thing that I want to know is, like I told you, breast development is present or not. If the breast development is present, that means there is no estrogen deficiency. That means problem must be with the uterus. If breast development is absent, it is estrogen deficiency. The moment I see breast development absent, I think it's estrogen deficiency. Now, why estrogen deficiency is there? That's another matter. We'll come to it in the second part of the flowchart. So, if the uterus is, so then I have to focus on the uterus. Is the uterus present or not? If the uterus is present, how do you know that the uterus is present? How do you know that the uterus is present? They will give you some information. They will tell you straight away that the uterus is present on transvaginal sonography, or they will say that there is history of cryptomenorrhea. History of cryptomenorrhea means hidden menses, cyclical abdominal pain but no menses outflow coming out. So, where is it going? It is collecting inside. It may collect to the extent that it becomes a hematocolpos, a hematometra, hematosalpinx, and it can cause an abdominal lump also. It may collect to that extent also. So, such kind of clinical profile, such kind of clue would be given to tell you that the uterus is present. And if they tell you that there is a bluish bulge at the introitus, it's straightforward image-based diagnosis, it is imperforate hymen. Okay, this is most of the times, almost always an isolated anomaly. That means there is no other problem, there is no other Mullerian problem, just an imperforate hymen, right? So, no extensive workup is needed, right? At the most, you can go for an ultrasound to check for the amount of collection, and the treatment is a cruciate incision given over the hymen and let it drain on its own. On its own is the important thing. No matter how much is collecting inside, no matter how much is collecting inside the uterus, there is no going inside the uterus and sucking it out. No instrumentation of any kind. Okay, let it drain on its own. Right? If the local examination, let's say, is normal, then you can think about the possibility of transverse vaginal septum, which will present in a similar manner. And then, yes, MRI is better for the diagnosis of transverse vaginal septum and for surgical planning. It will need septum resection. All right, Hemant? Fine. So, cryptomenorrhea also seen in transverse vaginal septum, similar clinical picture, but local examination is usually normal because the location of the septum is usually higher up, right? Now, if the uterus is absent, how will you know that the uterus is absent? How will you know? Either they will tell you ultrasound shows uterus absent, or on clinical examination there is a blind vaginal pouch. How do you know it is a blind vaginal pouch? Think about it. It's a young girl. Right? It's not like PV is contraindicated, but generally not preferred. Even if we do a gentle one finger PV, maybe there's a blind vaginal pouch. Another way of knowing that it is a blind vaginal pouch. Blind vaginal pouch means there's just end vagina. There's no cervix there. That is what it means by blind vaginal pouch. Nothing is opening into the vagina. So sometimes they trick you. See, understand, what do they tell you? That you do a per rectum examination. On per rectal examination, they will say cervix is absent or cervix is not felt. That is a clue. That is a clue that the uterus must be absent. If the uterus is absent, you think about two possibilities, Mullerian agenesis versus complete androgen insensitivity syndrome. Then how do you differentiate? Mullerian agenesis, gonads are ovaries, androgen insensitivity, testes. Serum testosterone is in the normal range in Mullerian agenesis, and in androgen insensitivity syndrome, it is elevated in the male range, and definitively you can confirm with the help of the karyotype. Karyotyping will give you the definitive diagnosis. All right, fine. Now, these gonads that are testes, they can be located inside the abdomen, intra-abdominal, or they can be located anywhere along the inguinal canal or underneath the labia also, right? And like that. Fine. Now, next situation here. What about if the breast development is absent? Delayed puberty and breast development is absent. So, I told you that there is estrogen deficiency. There is estrogen deficiency. Now, why? It could be that the ovaries are the problem and ovaries are not producing estrogen. Doesn't matter how much stimulus is being given to the ovaries. Problem is with the ovaries. The other thing is that the ovaries must be normal and the signal from the pituitary hypothalamus, that is not coming. Right? For that, if there is one hormone you are asked to choose, you choose FSH as the answer. If there's one hormone you have to choose. But in clinical practice, we go for ideally a full clinical profile at this point in time, where we want to do the FSH, LH, estradiol levels, TSH and prolactin levels also. Please remember that hyperprolactinemia inhibits excess prolactin, inhibits GnRH, right? And it suppresses the HPO axis. Right. So, please remember this also, and these causes need to be ruled out. These common hormonal causes like thyroid disorders and hyperprolactinemia, they need to be ruled out also. But if there is one you have to choose, pick FSH, because FSH will streamline into two different directions. Like if FSH is high, that means hypergonadotropic hypogonadism, that means ovaries must not be producing the hormone. That is why there is increase in FSH, feedback stimulation, right? So, if they mention short height, streak ovaries, hypoplastic uterus and plus minus all the other stigmata, they may tell you. The most important stigmata is short height. The diagnosis is Turner syndrome. The diagnosis is Turner syndrome. The most important is short height. Okay, other stigmata may or may not be there, but height short is always there. Now, tall patient, streak gonads and uterus is present. Then it is gonadal dysgenesis, but other types. Gonadal dysgenesis, but other types of gonadal dysgenesis. What other types? 46XX pure gonadal dysgenesis can be there. Other one is 46XY pure gonadal dysgenesis, which is also called as Swyer syndrome. 46XY type of gonadal dysgenesis is also called as Swyer syndrome. So, these are the possibilities. So, if I were to ask you that a patient with delayed puberty is there, absent breast development is there, FSH is high, and I tell you what is the next investigation, what do you want to do? If I ask you what is the next investigation, what do you want to do? Tell me. Yes, these are the possibilities, these are the common possibilities. What do you want to do? Yes, it is gonadal dysgenesis of some or the other kind. Even if it is looking like Turner syndrome, you have to have a karyotype. You have to have a karyotype, right? So, next investigation, very good, is a karyotype. Okay, and so with Turner syndrome, most commonly it is 45XO, but mosaic, Turner mosaic can also be there. Okay, and whenever there is a gonadal dysgenesis, please remember, whenever there is a gonadal dysgenesis patient with a Y chromosome, this is particularly important for INI-CET, gonadal dysgenesis with Y chromosome patient need a gonadectomy also. need a gonadectomy also as soon as diagnosis is made, because these are Y chromosome, meaning these could be, they have testicular elements, okay. So these dysgenetic gonads, they are at risk of gonadoblastoma and also germ cell malignancies, and they are undescended gonads. So they need to be removed as soon as the diagnosis is made. And from this I also remember another thing, that this androgen insensitivity syndrome, please mark it a point. These patients also need a gonadectomy. Gonadectomy is done, but after pubertal development is complete, or by the age of 18 years, or by the age of 18 years. So that's a difference. Or by the age of 18 years. So that is a difference, okay. Remember this extra bit as well. Now, let's come to the second part of the flow chart. If the FSH is low, if the FSH is low, that means FSH is low, that is why estradiol deficiency is there. So this is hypogonadotropic hypogonadism. If they tell you tall plus anosmia, your diagnosis is, yes, tall plus anosmia, somebody had already answered, this is Coleman syndrome. Right now, the possibility of CNS tumor should also be kept in mind. In the profile of primary amenorrhea, in the profile of primary amenorrhea delayed puberty, the most common CNS tumor is a craniopharyngioma. Craniopharyngioma. Most common tumor in the setting of a primary amenorrhea is craniopharyngioma. So one should always see if there is a CNS tumor, there may be other symptoms of space occupying lesions like headache or visual field defects, they may be there, right. So symptoms, signs and symptoms of space occupying lesion may be there, and other hormones may also be affected, not just your gonadotropins. So that possibility is also there, right. So one should always rule out CNS tumor also based on history and also based on examination and investigation. Like if there is a doubt about CNS tumor, a brain MRI can be done, right. So MRI brain can be done if that is the suspicion. And if the patient is short and other causes have been ruled out, short in height, all other causes have been ruled out, FSH tends to be in the low normal range, then what do we do? This is a diagnosis of exclusion, constitutional. This is called as constitutional, and this is a diagnosis of exclusion. Okay, why I say diagnosis of exclusion? Because you will also have to exclude other causes, like for example this anorexia nervosa and bulimia, stress related, you will have to exclude. So everything else you will have to exclude, then only in the end one labels it as constitutional. So history and examination and all of these things go hand in hand in making the diagnosis. So this is how you apply your basic concepts into understanding and trying to remember the flowchart. So whenever you revise a flowchart, don't mug up the flowchart. Keep it half, like I keep it half. So whenever I keep it half filled, I kind of recall the information. This is one way you need to keep in mind. Now let's see this. A mother has brought her 15-year-old girl to gynae OPD with concern of pubertal delay. On examination, breasts are Tanner stage 1. So Tanner stage 1 meaning that breast development is absent. Pubic hair are absent. Pubic hair are absent meaning androgens, they are not doing their job. Whether they are decreased, whether androgens are not getting synthesized, or androgen is there but not able to act on tissues is another matter, but they are not doing their job. Bilateral inguinal masses are palpable. There is a blind vaginal pouch. What did I tell you? There is a blind vaginal pouch means uterus is absent and bilateral inguinal masses are palpable. So bilateral inguinal masses in a girl who's been born and brought up and raised as a female are almost always testes. Right. Now for those of you who jumped and answered androgen insensitivity syndrome, okay. Now please look here. If it is androgen insensitivity syndrome, okay, then your pubic hair are absent in androgen insensitivity syndrome, I agree, but breast development is there. Breast development is there. Okay, so it's not androgen insensitivity syndrome. Now, if you say and argue, madam, what about partial androgen insensitivity syndrome? So I will say if it is partial androgen insensitivity syndrome, then some androgen action should come, some virilization should be there, but there is no virilization at all. The only thing is that breast development is absent. So I am not thinking it is androgen insensitivity syndrome. So I am eliminating it, right? Swyer syndrome, 46XY gonadal dysgenesis. Swyer syndrome is one syndrome which you should read separately also. 46XY gonadal dysgenesis, I included it here. Uterus is present in Swyer syndrome. So please remember this, uterus is present. So this is why this is not the answer. And in Swyer syndrome, gonadal dysgenesis is there. The gonads are testes. The gonads are testes, they are dysgenetic testes. But androgens will still come from the adrenal glands. So pubic hair are present. Pubic hair are present. So that's why this is not the answer. Right. Now I have to choose between 21 alpha hydroxylase deficiency and 17 alpha hydroxylase deficiency. I have changed and twisted the question. This question has been asked 2 times. Okay, once in FMG, yes, after it was asked in INI-CET, and the option they had given here was hypergonadotropic hypogonadism. This is what they had given. So look at this. This is 46. 21 alpha hydroxylase deficiency is congenital adrenal hyperplasia. Either congenital adrenal hyperplasia of the classical type presents with ambiguous genitalia and virilization in the newborn female, right? Or the non-classical type of congenital adrenal gland hyperplasia can present but with features of virilization because of excess androgens. There is no virilization happening here. This is not the answer. Okay, and in for 20 it's the female, it's the karyotype is also female, and the uterus is also there, ovaries are also there. Problem is with adrenal gland hyperplasia, right? 17 alpha hydroxylase 17 alpha hydroxylase deficiency is your answer, right? 17 alpha hydroxylase deficiency. 21 alpha hydroxylase deficiency is for the in the kidneys, yes, for production of adrenal and mineralocorticoids and glucocorticoids, right? So deficiency of mineralocorticoids and glucocorticoids happens, and then the adrenal gland pathway is diverted towards the production of androgens in excess. That is what happens in 21 alpha hydroxylase deficiency. So obvious, that is your answer there. So here it is 17 alpha hydroxylase deficiency as the answer. I have eliminated the rest of the options, right? Now what is this this enzyme used for? This enzyme is the rate limiting step, is involved in the rate limiting step in androgen synthesis. Okay, so androgens are not getting synthesized from anywhere, be it the gonads, be it the adrenal glands. Since they are not getting synthesized, no androgens, no estrogens, right? So this is again a type of hypergonadotropic hypogonadism, hypergonadotropic hypogonadism. Okay, 17 alpha hydroxylase deficiency can be there in a 46XX fetus also. 17 alpha hydroxylase deficiency can be in a 46XY fetus also. Interesting. This is an autosomal recessive inherited disorder. So this is must have been a 46XY because almost always testes, must be a 46XY fetus. Okay. Androgens are not getting synthesized in this particular fetus. Because androgens are not getting synthesized, what happened? Because androgens are not getting synthesized, the Wolffian duct didn't develop. The Wolffian duct didn't develop, right? And that is why the Mullerian duct regressed, because these gonads must have been testes. These are inguinal masses, they must have been testes. In the fetal life, they must have produced anti-Mullerian hormone, AMH, Mullerian inhibiting substance. So that is why uterus is absent. Okay. So this is what how this question is attempted, right? Now the point I'm trying to make here is that it becomes complicated if your basics about the embryonic development of sex is not clear. Right? If your basics are clear, this will make sense because these are the very few little keywords that you need to remember. So in this rapid revision, I'm just going to give you keywords now, right? So young girl with primary amenorrhea, inguinal or labial mass, it's almost always testes and the karyotype must be 46XY. So they may give you this information or they may not give you this information. But in this scenario, it's almost always going to be a 46XY karyotype. If the uterus is present and pubic hair are present, it is Swyer syndrome. Okay. If the uterus is absent, right, and the well-developed breasts are there, pubic hair is absent, it is complete androgen insensitivity. If the breast development is absent and features of virilized, and there is no virilization, like we discussed in the previous scenario. If the breast development is also absent, no virilization is there, that means neither the androgens are there, neither the estrogens are there. That means problem is with the androgen synthesis deficiency to begin with, and hypergonadotropic hypogonadism results. Okay. And if virilization is there, so much excess androgens are there that because of those excess androgens, one thing is happening is virilization, the other thing is happening breast development, breast atrophy is happening, right? So the male pattern changes are there. Right. Then two possibilities are there, 5-alpha reductase deficiency and partial androgen insensitivity syndrome. Either of the two possibilities is there. With 5-alpha reductase deficiency, serum testosterone to serum DHT values would be the ratio, because this enzyme helps convert, this 5-alpha reductase converts testosterone to DHT, right? So if the deficiency is there, then this ratio is elevated. Partial androgen insensitivity, this ratio is normal. And I'm talking about in the male range, normal in the male range, okay? So this is about the flow chart which will help you attempt questions like this, okay? Scenarios of young girl with primary amenorrhea, inguinal mass or a labial mass they may say, and karyotype 46XY, right? Now, next question. 37-year-old comes with amenorrhea for 9 months. Now, this is 37-year-old. This is a case of secondary amenorrhea. Okay. Use the same logic that I explained in the previous slides. There's no withdrawal bleeding on progesterone challenge test. Now, that is something interesting. No withdrawal bleeding on progesterone challenge test. That means we gave progesterone from outside, but bleeding did not happen. So, that means the possibility is that there may be estrogen deficiency, okay, or the endometrium may be the problem. Okay, that is the two possibilities. Physical examination is normal, dryness during sexual intercourse. See, dryness during sexual intercourse. So, vaginal dryness, again pointing towards estrogen deficiency. That is what it is pointing towards, right? So, the clue is there in your question. UPT is negative, FSH levels of 36. They are on the higher side, they are not coming in the menopausal range, right? But they are on the higher side. Anything more than 20, anything more than 20 in a reproductive age group woman is concerning to me. Okay, so this is 36 on the higher side. AMH of 0.05 nanogram per ml, this is less than 1, this is low AMH and this is high FSH. Okay, so what is the most likely diagnosis now? If it would have been pituitary failure, the FSH levels would have been low. If it would have been uterine synechia or Asherman syndrome, there must have been some history of uterine curettage and the hormone levels should be normal. If it was PCOS, then the PCOS patient will have a withdrawal bleeding on progesterone challenge test, right? And PCOS will not present with such high FSH levels. Such high FSH levels it will not present. And just before a couple of slides earlier, I told you in PCOS patients AMH levels are raised. So, it does not fit in the criteria of PCOS. Then PCOS will not suddenly present a 37-year-old with secondary amenorrhea. Generally, the menstrual problems start happening from pubertal life itself. So, this is not the answer. It's premature ovarian insufficiency. Right, premature ovarian insufficiency is the answer. The most common cause is idiopathic And if idiopathic is not in the option, the other thing that we are looking at is autoimmune causes. Okay. So that's your answer. So this is how you are going to attempt. You're going to use, again, I'm telling you, logic and concepts. That is how you best attempt these questions, especially in INI-CET, where you have got very less time to devote to a particular question. You will not be able to solve this in 1 minute if you're not applying logic and eliminating options. Next question. 31-year-old, inability to conceive for past 1.5 years. And she's been advised to undergo HSG for evaluation of tubal patency. Understand the profile. Infertility and HSG, she has been advised. 3 prior first trimester spontaneous abortions, curettage was done each time. So that's your clue there. Pelvic ultrasound reports are normal. Menstrual cycles are regular but scanty in amount. Hypomenorrhea is there. She is otherwise healthy and the pelvic examination is also normal. So given her history, what are you expecting that HSG report would show? You are expecting that this HSG report would show excellent intrauterine synechia. Right? Based on her history, it seems likely that she's had the hypomenorrhea is also there, could have been amenorrhea, amenorrhea could have been there, and history of abortions, history of curetages go in favor of intrauterine synechia, Asherman syndrome. Right? Now, if I want to go for the confirmation, if I want to go for the confirmation, or if they had asked you the best to diagnose, how will I go for it? How will I go for this? Yes, hysteroscopy. Hysteroscopy, right? Hysteroscopy is also best. Why? Because it will at the same time allow us to go for hysteroscopic adhesiolysis. Treatment is hysteroscopic adhesiolysis. HSG is a screening test for tubal patency, nothing else. Hysterosalpingography, HSG is already done. It is nothing but a screening test for tubal patency, right? And it is not going to help you confirm anything. For confirmation, if you have a clinical doubt of intrauterine synechia, Asherman syndrome, it is hysteroscopy, right? And hysteroscopic adhesiolysis is going to be diagnostic as well as therapeutic. Yes. And once I do the adhesiolysis, after the adhesiolysis, what is done? After the adhesiolysis, it is followed by high dose estrogen therapy. Why high dose estrogen therapy? Needed to be given for a couple of weeks to rebuild the endometrium. We have removed the adhesions, we have created raw surfaces. If you're going to leave it, it is going to the uterine walls, anterior posterior walls are going to collapse on each other, adhesions are going to form again. So high dose estrogen therapy, and we place an intrauterine device inside to keep the walls of the uterus separated. If I say intrauterine device, it means without the copper wire, without any hormone, okay? Plain intrauterine device inside, and this is generally done, okay? Fine. Now, next question. A couple is being evaluated for infertility. The woman is 28 years old, regular cycles. So, before I read this question, Hemant, you said E plus P and IUD. E plus P, first you give high dose estrogen therapy, then you give progesterone. Like that happens in normal menstrual cycle. If you give E plus P together, it will be more of progesterone effect on the endometrium. You first need to build the endometrium. So give estrogen first to build up the endometrium. Then we have to monitor. We have to check how the endometrium is building up, and then later on we add progesterone for the withdrawal bleeding to take place. Okay, so it's like that. Okay, followed by progesterone withdrawal. Okay. Next question. Yes. A couple is being evaluated for infertility and she is 28 years old, regular cycles. The only significant history is PID in the past. Physical exam normal, HSG is done for testing tubal patency. What is the most likely diagnosis? So think about it. Yes, it is hydrosalpinx. This is distal tubal block. This is distal tubal block. Right. If it was a tubo-ovarian mass, right, this dies inside the fallopian tube. That is what we are seeing in the image. Tubo-ovarian mass would be picked up on physical examination. There will be a neck cell mass. If they had to ask you about a tubo-ovarian mass, they would give you ultrasound finding, a physical examination finding, not HSG finding. Endometriosis also will show a neck cell mass because of the ovarian endometrioma. So this is not endometriosis. Endometriosis will have a different clinical picture. We'll see it in the next question. Leave it for now. And Asherman syndrome will show filling defects inside the uterus. Asherman syndrome will show filling defects inside the uterus. This is not the answer. This is hydrosalpinx, right? If I ask you what is the next investigation, what would be your answer? Yes? Next investigation, first choice answer, second choice answer. If they say laparoscopy plus hysteroscopy, that should be your first choice answer in this clinical profile. Okay. If there is an option of laparoscopy plus hysteroscopy, that is your answer. Laparoscopy will help us look at the pelvis also, and hysteroscopy will simultaneously let us evaluate for the uterine cavity. I will give you the logic why, if such a clinical picture is given, such a clinical context is given with a distal tubal blockage and tubal damage like that, the next thing that we are looking at, what is the best treatment for tubal factor infertility? It is IVF, right? The next thing that we are looking at is planning for IVF. For that, I also want to ensure that the uterus lining and the uterine cavity is absolutely healthy, and it is better that we plan for a laparoscopy plus hysteroscopy in one sitting itself, rather than doing a laparoscopy one time and then doing a hysteroscopy another time. So if this is in the option, then this is a better choice answer, in case it is there provided in the options. Otherwise, the second choice option should be laparoscopic chromopertubation. So even when we are doing laparoscopy, hysteroscopy, chromopertubation, we will do in the same sitting, right? So laparoscopic chromopertubation. Right. Now identify this image here. This image is showing. What is this image showing? Identify this image here. What is this image showing? This image is showing bilateral cornual block. Bilateral cornual block. It could be a false block. Why could it be a false block? Because it could be because of cornual spasm. Okay, it could be because of cornual spasm, right? When we are introducing the cannula inside, the cornua here can undergo spasm, and it could be a false block, right? Now, this patient also, if I say next investigation, what would be the better choice answer? Laparoscopy plus hysteroscopy. That would be your answer. If best next investigation, this would be your best choice answer. Why? Because if needed, then hysteroscopic cannulation can be attempted. And we are simultaneously doing laparoscopy, so it will be laparoscopic guided also. So hysteroscopic cannulation can be attempted. That's why. Okay. So if this is in the option, that is a better answer. Otherwise, laparoscopic chromopertubation, because gold standard for checking for tubal patency is laparoscopic chromopertubation. Okay. Fine. And also please remember that this cornual block is something that is very specific for genital tuberculosis. Genital tuberculosis. Please remember this also. Right, genital tuberculosis, because what happens is that from the fallopian tubes, most of the times fallopian tubes are involved. Now, almost always fallopian tubes are involved with genital tuberculosis. From the fallopian tubes, it enters into the endometrium by direct spread. So that entry point, the cornual region, that is where adhesions form with genital tuberculosis. So this cornual block is something also that turns out to be very specific for genital tuberculosis. Keep that extra bit in mind. Now, coming to hydrosalpinx, this is one image for hydrosalpinx, right? This is the adnexal mass, okay, and we can see that there are these projections inside, this hyperechoic projection. So this dark color inside is all the fluid, and these white projections are basically the flimsy adhesions, okay. So this is hydrosalpinx on ultrasound, and this is called as the cogwheel sign. There is another sign which is called as the waist sign. This one here is the cogwheel sign. There's another sign which is called as the waist sign, right? So that can also be there. So this patient also, she was having infertility, and on ultrasound, this is what was found, okay, fine. We did a laparoscopy for her because we wanted to check, and she had a history of multiple episodes of PID in the past also, right. So we did a laparoscopy for her. This is the laparoscopic chromoperturbation image. So this is the hydrosalpinx, dilated distended tube, can you see, and it is filled with the dye that we have pushed in. This is the methylene blue dye. This is the methylene blue dye. Okay, now the side that hydrosalpinx was there, that side tube was blocked. So the dye must have come from the other side. वैसे most of the times hydrosalpinx and PID related changes and genital tuberculosis related changes in the pelvis in these patients are most of the times bilateral. And in this particular image, what we are seeing is, you can see these damaged tubes. You can see this beaded tube appearance, okay, and it's also thickened, damaged, thickened, beaded tubes. And something else that you are appreciating is these white tubercles, right, white tubercles. Now that, please, if that is the image given to you, where these white tubercles are present on the serosal surface of the tube, they could be present on the serosal surface of the uterus also, and in extensive cases they are found on the serosal surface of the otherwise other pelvic peritoneal structures also. Then your diagnosis is, yes, these white tubercles, then your diagnosis is genital tuberculosis, right. So to prove, obviously we'll have to go for the biopsy of these, and we'll have to subject them to AFB and histopath, right. To subject them to histopath, we'll try to isolate bacteria from there, right, backtech and culture. The way that you diagnose tuberculosis elsewhere, you'll have to have some histopathological or microbiological evidence of isolating and finding suggestive of Mycobacterium tuberculosis infection, right. So that is what you will need in these circumstances, right. So this is how, again, gynae bit is this much, but yes, again, it can get integrated with your with your microbiology as well and pathology as well. Like, for example, they could say that we biopsied from this lesion, and we found granulomas or crassious granulomas like that on histopath. Then what is the diagnosis? So all of this could be integrated also. Clear with these images? Let's look at the next question. So I was telling you that I'll talk about endometriosis in a while. So a young woman is being evaluated for infertility, severe dysmenorrhea and dyspareunia. So these three things that I have circled is the classic triad for again endometriosis. On pelvic examination, uterus is retroverted, tender nodularity felt through the posterior vaginal fornix. And there is an ovarian mass of about 5 centimeters. CA-125 levels are mildly elevated, and CA-125 levels in reproductive age group women can be elevated in a lot of conditions wherever there is peritoneal inflammation of some sort. So endometriosis, even fibroid, and even other ovarian cyst. This CA-125 is a very non-specific kind of a marker. Even in genital tuberculosis, it can be raised. So we're not thinking about the possibility of malignancy or anything, right? And there is this appearance. This appearance is the classic ground glass appearance. So now when you put it all together, now those of you who are choosing dermoid cyst as the answer, dermoid cyst will have a very distinct other appearance. I will show them to you, right? But dermoid cyst will not fit into the other findings. Na? Think about it. Uterus is retroverted, tender nodularity through the posterior vaginal fornix. What is that? Uterus is retroverted. Why? Because it has been pulled back. Something is pulling the uterus in the pouch of Douglas and not letting it go anteverted. So these are pelvic adhesions. The findings are suggestive of pelvic adhesions. These tender nodularity fell through the posterior vaginal fornix. There can be nodules, deposits, endometriotic deposits in the pouch of Douglas. Right. So the clinical profile plus the examination findings are all going in favor of endometriosis and the classic ground glass appearance of the endometriotic cyst. In this question, if they had not mentioned the ultrasound image also, then also I would have picked up endometriosis as the answer. So it's not dermoid cyst. With genital tuberculosis, infertility will be there, but dysmenorrhea and dyspareunia are very unlikely with genital tuberculosis. Genital tuberculosis mostly involves the fallopian tubes, then the endometrium, and for genital tuberculosis to present as an adnexal mass is very unlikely and uncommon until unless the ovaries are also simultaneously involved, which is very less often. So when it is less often, it is less likely the answer. Okay, they're asking you what is more likely the diagnosis. And dysgerminoma. If they wanted to ask you about dysgerminoma, they would have mentioned, at least they would have not mentioned CA125 as the tumor marker. They would have mentioned dysgerminoma, a marker like LDH, right? But again, it is not fitting into this clinical picture at all, where the woman is being evaluated for long-standing infertility and there's a small ovarian mass with a classic appearance, right? So answer is endometriosis. If they were to ask you how do you make the diagnosis, how do you confirm, then your answer would be next step, this clinical profile of the patient, and you have to go for a plan for a next investigation. It is going to be a diagnostic laparoscopy, right? You confirm with a diagnostic laparoscopy. If possible, we remove, if possible, we go for histopath confirmation. If possible, histopath confirmation. But the lesions are always very classical looking. So histopath confirmation may or may not come, may or may not be there. It doesn't matter. Visual identification of these endometriotic lesions is fair enough, right? So the one thing that you see on the left here is chocolate cyst, because it is filled with old collected blood, hemosiderin, right? So this is also endometrioma. Chocolate cyst, endometrioma. Then there can be subtle lesions. So these are image-based identification. Subtle flame, red looking lesions, powder burn deposits, right? Areas of fibrosis in the peritoneal cavity, these white areas, and blackish nodules can be there. These are fresh deposits of blackish nodules, right? So these are all endometriotic lesions, right? Now, also please remember that for a chocolate cyst, okay, for a chocolate cyst, if it is causing pain, if it is causing persistent pain, okay, or if it is basically more than or equal to 4 centimeters in size, more than equal to 4 centimeter in size, this is a bit controversial. Many people are saying that let's not touch it if we are doing, dealing with an infertile patient, but let's not go with the controversial areas. Let's stick to basic points, that if it is causing persistent pain, if it is more than 4 centimeter in size and you have to treat for the pain, if you have to treat for the pain, best is to go for a cystectomy. Right? Because it leads to the least risk of recurrence. Okay. So in a patient with chocolate cyst, endometrioma, when you have to treat for pain, be it because of persistent pain or be it because when the size is more than or equal to 4 centimeter, best is to go for cystectomy, right? And when treating for pain, one also goes for medical treatment first. And also remember that if it is associated with infertility, what do we go for? We go for laparoscopic adhesiolysis first, followed by whatever our plan is later, followed by ovulation induction plus IUI, or followed by IVF depending upon case to case basis. So, followed by fertility treatment, basically followed by fertility treatment. Okay. So, surgery first and then some sort of fertility treatment is generally advised for these patients with endometriosis when they are dealing with infertility. Okay. Now, I told you that I will show you images for dermoid cyst also. So, compare with the gross, So, this is a dermoid cyst and this is the gross image, right, and again filled with hair and sebaceous cheesy material, and this is the solid nodule there, in which you will find all the protrusions coming out from there. So, if there are teeth and cartilage, they are in that solid protuberance. So, this solid protuberance is Rokitansky protuberance. Okay. Now, do we give OCPs in endometriosis? Yes. Medical management is done first. No? I was talking about, so if just to take up the doubt, do we give OCPs? So, medical treatment for pain is always tried first, and medical treatment for pain will involve hormonal treatment like continuous oral contraceptive pills or progesterone in some form. Progesterone can be oral, progesterone can be in the form of Mirena, it can be in the form of injectable. GnRH analog therapy is also used. So, medical treatment for pain is always tried first, right? And many times it works, but sometimes it doesn't. So, if there is failed medical management, persistent pain more than 4 centimeter in size, then best to treat with cystectomy for pain. Okay. So, coming back to the dermoid cyst, this is the Rokitansky protuberance, right. Now, you see this cyst here, this is the cyst, and this hyperechoic nodule, can you see this hyperechoic nodule is the Rokitansky protuberance, and in this cyst you are also able to appreciate these fine white lines like dashes and dots. So, this is the dash and dot appearance. So, this dash and dot, these hyperechoic lines, okay, of dashes and dots is the hair like projections. Okay. So, this is again very classical for dermoid. Dermoid is one cyst which can be like endometriosis has a classical ground glass appearance. Dermoid cyst can also be fairly diagnosed on ultrasound with these classic appearances. And if you look at the image on the left here, again this is the ovarian cyst. Okay. Now, what is happening here is this is the nodule, this is the Rokitansky protuberance, okay, hyperechoic nodule, and everything behind that, everything else inside the cyst is hidden. This is this posterior acoustic shadowing which we call it. Okay. So, everything else is hidden. So, this is like the tip of the iceberg sign. This is tip of the iceberg sign. These two are very typically seen in dermoid cyst, very typically seen in dermoid cyst. Okay. And dermoid cyst can also be bilateral, they are mostly unilateral. See, dermoid cyst is the most common germ cell tumor and it is benign. We know that it is benign. This is mature cystic teratoma. This is mature cystic teratoma containing elements of all three germ cells, right? Germ cell less. It can be bilateral in up to 10% cases also. It can be bilateral in up to 10% cases, and it is most common type of ovarian cyst to undergo torsion also, okay. And how are they managed? Again, since they are benign, the treatment for them is cystectomy. Okay. And laparoscopy wherever feasible is going to be preferable, right. So, laparoscopy wherever feasible is going to be preferable as far as treating the dermoids is concerned. Next question. 20-year-old girl presents with ultrasound report showing a right-sided simple ovarian cyst of 5 centimeter. So, what do we mean by simple? By simple we mean anechoic. Can you see anechoic simple cyst? And this anechoic, why? Because it must be containing clear fluid, Most likely this is a follicular cyst, okay. She has regular periods, there is no history of dysmenorrhea, she is not sexually active. What is the most appropriate step in management? Yes, this is an incidentally diagnosed cyst. Now, it happens to us sometimes, right? So, there's no need. So, these are most likely follicular cysts. They keep forming and keep disappearing also, right? So, there's no need for going for a diagnostic laparoscopy. There's no need for going for CA-125 levels. And there's no need to start her on oral contraceptive pills also. Please understand that oral contraceptive pills, oral contraceptive pills, they prevent new follicular cysts from forming because they suppress follicular growth. They don't make the one that is already there disappear. Right. So, oral contraceptive pills, they are often prescribed to such patients, but they usually should be prescribed if needed. Like she could be a sexually active patient who also needs contraception, or she could be having symptoms of dysmenorrhea which will resolve and she will feel better with oral contraceptive pills. So, if needed, they may be given, but they are not basically just unnecessarily given, right. So, follow up after 3 months is your best choice answer, right. Adnexal masses are being asked again and again with your exam. So, please remember here, what are the indications for surgery? If you look at the indications for surgery in a case of an adnexal mass, right. So, please remember that the size is more than or equal to 8 centimeter. Okay, then it needs to be operated. Adnexal mass, we're talking about ovarian mass. We're talking about ovarian mass. Or if the ultrasound is suspicious of malignancy, if the ultrasound is suspicious of malignancy, then we need to operate. And if there is an acute abdomen or torsion like situation, then size doesn't matter, then we will have to operate immediately, right. Now, also when there is ultrasound suspicion of malignancy, that doesn't mean straight away operate. Please, we send the relevant tumor markers also. We send the relevant tumor marker profile also. Okay, please remember that before operating on the patient, right, because we need to have a baseline. So, please keep this in mind, right. Now, another important thing is that another situation where we may encounter adnexal mass is in pregnancy. In pregnancy, the timing is crucial. If we are doing elective surgery, okay, if we are doing elective surgery, then 14 to 16 weeks is the time. Do not touch in the first trimester. Okay, because in the first trimester, there is anesthesia risk to the growing embryo and the fetus also, right. So, elective surgery reserved for 14 to 16 weeks, not touch in the first trimester. But if there is, let's say, torsion of ovary, then torsion of ovary is a surgical emergency, then operate immediately, operate immediately irrespective of period of gestation. Okay. Now, another important pointer I want to give you here, which they have asked questions in recent exams, is about this acute abdomen like situation where woman comes with abdominal pain, like abdominal pain, and there may be another complication of an ovarian cyst, which is a hemorrhagic cyst, bleeding inside the ovarian cyst. Okay. Now, the most likely cyst to have a hemorrhage inside it is a corpus luteal cyst. So, it is most likely a corpus luteal cyst that becomes hemorrhagic. Corpus luteum itself is a very vascular structure, right. Now, how do we manage will depend upon the hemodynamic status of the patient also, because many times what happens is that there is some bleeding inside the corpus luteum and then it stops on its own. Right. So, we may get a situation where we have an ultrasound showing reticular pattern which is suggestive of fibrin collection, old collected blood. Okay, reticular pattern, internal echo, suggestive of fibrin collection. If this is mentioned in the question, okay, please see what they are telling you about the hemodynamic status of the patient. If it is an uncomplicated situation, if the patient is hemodynamically unstable, then one can observe. Okay. But supposing if the patient is unstable, okay, there is a possibility that the hemorrhage is excessive. So much so that the patient is becoming unstable, or the cyst, whatever cyst was, has ruptured. Okay, so hemoperitoneum is there. Okay, maybe there is a hemorrhagic cyst that has ruptured causing hemoperitoneum, or there is peritonitis. Okay, now see, understand here, anything that is not supposed to be in the abdomen or in the pelvic cavity, when present in the pelvic cavity, will irritate the peritoneal lining and can cause peritonitis. So when you have hemoperitoneum, it can cause peritonitis. When you have especially dermoid cyst, I showed you dermoid cyst, remember, especially dermoid cyst, this cheesy sebaceous material. Dermoid cysts do not rupture that often, but when they do rupture, they can cause chemical peritonitis. Dermoid cysts, if they rupture, they can cause chemical peritonitis. Okay, so if that is the situation where you have unstable or hemoperitoneum features are there or peritonitis is there, then you can't sit and observe on it, no? Then you have to operate in such a situation. Clear? Then you have to operate in such a situation. And another important pointer here, another acute abdomen like situation which I will summarize for you, torsion. Ovarian torsion is a surgical emergency. Most of the time it is a clinical diagnosis. Most of the time it is a clinical diagnosis. Ultrasound tends to help, but many times ultrasound will not be giving us any clues. So clinical diagnosis in the sense, so I will describe it to you. So there is maybe a history of ovarian cyst is there, or history of ovarian mass is there. What did I tell you? Most likely dermoid cyst is the most likely kind of a cyst that undergoes torsion, because it is filled with heavy material, no? So it tends to make the ovaries heavier and bulky, and that is when they twist on their pedicle. Okay, so they twist, untwist, twist, untwist. So there is a history of, off and on waxing and waning kind of a pain going on for a couple of days to a week maybe. So preceding waxing, waning pain, finally one moment comes of that completely twist on its pedicle, and then suddenly the woman has an acute abdominal pain, and the patient deteriorates much faster in these situations. Why? Because of the release of inflammatory and ischemic mediators from the ovaries. Right? So it is more or less a clinical diagnosis, but yes, please look at an ultrasound clue of whirlpool sign. Ultrasound clue of whirlpool sign. And yes, ultrasound Doppler will be needed. This question was asked, and you would believe this question was asked in FMG. It is such an interesting thing. If you have to diagnose ovarian torsion, you need ultrasound, not plain ultrasound, you need Doppler, because you need to see the blood flows to the ovary. So blood flows to the ovary will be decreased, isn't it? Right? And then you have to go for an urgent laparotomy. You have to go for an urgent exploration. And please, let me remind you that whenever you have acute situations of blood loss or ovarian torsions like this, do not forget resuscitation. Okay, so exploration plus resuscitation go hand in hand, right? And this has to be urgent surgery. Okay, whether laparotomy or laparoscopy will depend. So please remember, most of the time it is a laparotomy only, but you could go for a laparoscopy also. Laparoscopy could also be done, but please remember that a laparoscopy is going to be contraindicated, and these are contraindications of laparoscopy per se, which you do in surgery also. So if there is a hemodynamically unstable patient, laparoscopy is not done. If there is peritonitis, laparoscopy is not done. Okay, so these are contraindications of laparoscopy per se. And on surgical exploration, what is done? First of all, untwisting of the ovary is done. Untwisting of the ovary is done. After untwisting, color will come to the ovary, blood flows will come to the ovary and everything, right? So that way we have a chance at saving the ovaries, right? And whatever cyst is there, if there is a cyst responsible, you go for a cystectomy, right? And if tissue necrosis is there, then we have no other choice but to go for a salpingo-oophorectomy. Salpingo-oophorectomy, if we don't want to go for it immediately, we will only do it if there is tissue necrosis. We try to save the ovaries as much as possible. Okay, so these are few pointers regarding ovarian torsion. Now look at the next question. An 18-year-old girl presents with abdominopelvic lump, which on ultrasound evaluation is solid cystic, measuring 10 centimeter, raised blood flow inside the mass on Doppler. And this is the mass. What can you appreciate about the mass? You can appreciate that this is the mass. There are solid areas. These solid areas are having a lot of blood flow. Tumor, cancer has what? Malignancy has what? This neovascularization. There are multiple septations, solid areas. These are all features suggestive of malignancy. Right. So, solid areas, multiple septations, bilaterality, raised blood flow inside the mass. These are all features suggestive of malignancy. So, now what is the most appropriate next step? I want to operate, yes, but I want to decide, no, ideally such patients, ideally please remember ovarian, when there is a suspicion of ovarian malignancy, they should be opened up by gynae surgeons, gynae oncosurgeons ideally. Right, because they need a preoperative workup. They need an extensive preoperative workup, right? Otherwise they end up having incomplete surgery. Okay, so yes, you want to, whatever you want to do, you want to operate on them, you want to decide what to do, that will come later. But for now, yes, what did I tell you? Send the tumor markers first. So send the tumor markers, and what will you send? The best choice is to send option B. This is the best profile that we need to send, a CA-125 basic. It's not like epithelial ovarian can never occur. Epithelial ovarian are obviously most likely going to occur in the older age group, but you want to send a baseline CA-125 also. There is more likely probability of this being a germ cell malignancy. So, you want to send the relevant markers like AFP, HCG and LDH. CEA is a marker for mucinous kind of histology, and mucinous is epithelial ovarian. So, it does not make sense to send this here. So, considering the age, this is more likely a germ cell malignancy. That is why answer is option number B. And there is no USG guided FNAC for ovarian masses, right? There is no USG guided FNAC or biopsy of ovarian masses. Like in other malignancies, we tend to do a biopsy, not this one here. Why? Because if we introduce a needle, please remember, recall. Why? Because ovarian cancer spreads by tumor exfoliation. That is the most common route. That is how ovarian malignancy spreads, tumor exfoliation along peritoneal surfaces. You want to puncture and biopsy the ovary so that, you know what, you just speed up the process of malignant spread. So, yes, that is not done. Ultrasound guided FNAC is not done. Exceptional circumstance. Let's say, for example, there is a woman, old age, okay, very advanced ovarian malignancy. Advanced ovarian malignancy in the sense that she has all the CT scan features, she has all the ultrasound features, and we are sure that this is an ovarian malignancy. We have the raised tumor markers also, but maybe she is unfit for surgery. Maybe she is unfit for surgery and we want to go for a chemotherapy. But before giving a high-end chemotherapy, we want a confirmation. So, already it is advanced stage, right? There you can go for an FNAC to have a biopsy report, proven diagnosis of malignancy, so that one can start the relevant chemotherapy. That is one situation where it would be justified, but not in every case. Am I clear about ultrasound guided FNAC? This is common sense, my dear friends, all right? So, it may not be useful in all the cases. In fact, we tend to avoid it most of the times, especially when you have just an adnexal mass. But yes, there are situations where it may serve the purpose, okay? It may serve a relevant purpose. Then it needs to be done, and then it is justified, right? So, next question. 60-year-old woman presents with long-standing complaints of dyspepsia, bloating, progressive abdominal distension. So, these non-specific GI symptoms, right? Imaging reveals ascites, omental caking, bilateral adnexal mass 6 cm each, multiple septations, papillary excrescences. These are your clues. These are your clues that there are solid areas. That is all they are telling you. These clues are telling you there are solid areas. This is solid cystic, bilaterality. Look at her age. What is omental caking telling you? Omental caking is telling you that it has spread to the omentum. Okay, clinical examination, per abdominal examination, you can feel it actually. like a doughy structure, as if it is, so basically it is telling you that spread to the omental surfaces is already there. So you already know this is advanced. This is already advanced anyways, right? Omental caking can also be appreciated on, it can be appreciated on ultrasound and very much so on CT. So they are mentioning imaging is showing omental caking and ascites. CA125 levels is 450. It is dramatically elevated. So this is epithelial ovarian cancer, right? Most likely diagnosis. Now think, if you are saying most likely diagnosis as mucinous cyst adenocarcinoma, why are you saying mucinous? 75% of the cases are of serous histology. So serous cyst adenocarcinoma. Obviously, the diagnosis has to be confirmed by final histopath. Obviously, the diagnosis has to be confirmed by final histopath. If they had raised CEA marker, in such a patient, if I have to send a tumor profile, in such a patient, if I have to send a tumor marker profile, I'll send CA125, I'll send CEA also. Okay. So mucinous, if they had to ask you, they would tell you the relevant tumor marker. Mucinous kind of tumors, how are they different from serous? Remember that. How are they different from serous? They tend to be, more likely tend to be unilateral. They tend to grow to large sizes, multiple loculi filled with mucin. That sort of description is not given to you, right? So that is why this is not the answer. Granulosa cell tumor is also not the answer, and frankly speaking, with granulosa cell tumor, this is a sex cord stromal cell tumor. It's not epithelial, so CA125 will not be a marker. Endometrioid is epithelial ovarian, but it is so much less common. So most likely diagnosis, I will say, is serous cyst adenocarcinoma. So remember these charts. Please remember this. This is often done in your patho lectures also. Dr. Preeti takes them and she tells you about all of these important findings. So I hope that we can quickly, recall this. So serous histology, we will see psammoma bodies on the histopath. Gynae part, there are two types of serous histology. Type 1, low grade mutation in KRAS and BRAF, and type 2 is the high grade serous where mutation is in P53 gene, right? And these are the corresponding gross images. Now this one here, multiple loculi filled with mucin, if this is given, right, then answer is mucinous histology. Tumor marker is CEA and CA199, and it can be associated with pseudomyxoma peritoni. Okay. Now other ovarian tumor, what is this? This one here. If they tell you that there is a woman in her let's say 40s to 50s, late 30s, 40s, 50s, like that, that is the middle age group, okay, associated with abnormal uterine bleeding, or a postmenopausal woman with postmenopausal bleeding, and a juvenile form is also there. So there can be a young girl with precocious puberty also. So juvenile form is also there. Tumor marker is inhibin, and histopath is showing what? Histopath is showing coffee bean nuclei and Call Exner bodies. So they will mention these things. Either they will give you the slide, okay, or they will give you a gross, or they will give you some of the other special feature. And then this is granulosa cell tumor. Very good. Excellent. So this is something that you have had a lecture on, right? Abhi last LRR of patho has been done, I know. If they say there is a woman with adnexal mass associated with hirsutism and virilization, right? And this is very rapidly progressing hirsutism in a middle-aged woman. Adnexal masses are also there. So they are most likely going to be the theca cell Leydig cell tumors. Okay, and fibroma is benign, right? Fibroma is benign. It is solid tumor and it is associated with Meek syndrome. What happens in Meeks syndrome? Ascites plus pleural effusion. What is this ascites? What is this pleural effusion? This is reactive, this is not malignant. So once the benign tumor mass is removed, this ascites and pleural effusion is going to settle down. And if you have this metastatic tumor to the ovaries, which is often bilateral, usually but not always, usually but not always, often bilateral. On histopath you see signet ring cells. This histopath is important. If on histopath there is signet ring cells, then only it is called as Krukenberg. Then only it is called as Krukenbergs. So please remember here one pointer: the most common metastatic tumor to the ovary is a gynae cancer coming from the endometrium, the endometrial cancer spreading to the ovary, most common metastatic tumor to the ovary. But if you say a non-gynae cancer spreading to the ovary, it is adenocarcinoma colon. Okay, but then this may not be the Krukenberg type of histology. This may not be a Krukenberg type of histology. CA stomach is the most common histology for Krukenberg. CA stomach is the most common histology for Krukenberg. Okay, so let's say there is a metastatic tumor to the ovary. If it is metastatic Krukenberg's tumor with the characteristic histopath of signet ring cells, its most common primary is CA stomach, right? But non-gynae cancer metastasizing to the ovary most commonly is adenocarcinoma colon. Okay, the two different things, very subtle but two different things. Next question. A pregnant woman is seen at 30 weeks of gestation. On examination, the symphysiofundal height is 26 centimeter, fetal heart rate is 140. So this is fundal height less than the period of gestation, right? So fundal height less than the period of gestation could be miscalculation of dates, could be any other number of things, could be fetal growth restriction, could be fetal death also, could be oligohydramnios also, right? You need to go for an ultrasound to help you confirm your diagnosis. So it is assessed for fetal growth. All of the following are used to diagnose fetal growth restriction except excellent. The ones that are quickly responding, it is uterine artery pulsatility index less than 95th centile. So for those of you who don't know this, there is a very latest Delphi consensus on the diagnosis of fetal growth restriction. All right. Now see, absent end diastolic flow in umbilical artery. Obviously, if umbilical artery is showing absent end diastolic flow, it is going to go in favor of fetal growth restriction. That is fairly obvious. Estimated fetal weight less than 3rd centile, less than AC less than 3rd centile, obviously going to go in favor of fetal growth restriction. Now, what do you understand by pulsatility index? So, pulsatility index is something that you read up in radiology. It is any blood flow, okay, in a vessel. We measure the systolic flow and the diastolic flow. So, systolic flow minus the diastolic flow divided by the average or mean gives the pulsatility index, okay. Please remember just a very basic concept that in pregnancy what happens is that the diastolic flow is going to increase as pregnancy advances, right, because there is vasodilatation, right. Diastolic flow increases as pregnancy advances normally, right. So this will be happening even in the umbilical artery. This will happen even also in the uterine artery. Diastolic flow is going to increase, right. Now if there is less of vasodilatation in the uterine artery, right, if there is decrease in the diastolic flow, okay, that means the perfusion of these vessels is getting compromised. Okay, the perfusion of these vessels is getting compromised and the pulsatility index will increase. Clear? Right. So, pulsatility index more than 95th centile, not less than 95th centile, will go in favor of the diagnosis of fetal growth restriction, not less. Okay. Now, uterine artery is perfusing the placenta. right? Uterine artery is perfusing the placenta, right? So if uterine artery is not getting perfused properly, obviously placental perfusion is expected to get compromised, isn't it? So look at this chart here. This is for diagnosis of late fetal growth restriction and early fetal growth restriction. Okay, at least remember that if there is AC or estimated fetal weight or abdominal circumference less than third centile, this is straight away enough. This is too much, this is too low, straight away enough to make the diagnosis of fetal growth restriction. But if the AC or estimated fetal weight is less than 10th centile, it is on the lower side, it is less than 10th centile, then at least 2 out of 3. You need something else also to help you make the diagnosis, like we go for repeated scans, we go for growth scans, and in the growth scans, the growth is lagging behind. So it is crossing more than 2 quartiles on growth centile. So this is repeated scanning over a period of time. Either that, or there is CPR less than 5th centile, cerebroplacental ratio. So CPR is basically cerebroplacental ratio. Okay, this is the peak systolic velocity of the cerebro is for the middle cerebral artery, and placental is for the umbilical artery peak systolic velocity. So if it is less than 5th centile, or the umbilical artery pulsatility index is more than 95th centile. So umbilical artery, please remember, umbilical artery SD ratio increases. That it itself is means that the umbilical artery pulsatility ratio must be more than 95th centile. So either of the two are needed, at least 2 of 3, to make the diagnosis of late onset fetal growth restriction. And look at this here, uterine artery pulsatility index can help make the diagnosis of early onset fetal growth restriction also. So these are some of the pointers, right? Again, this is most important for INI-CET perspective. This is the previous year question. So remember these important pointers as well. Most of the times they are going to ask you about late onset fetal growth restriction. Clear? Next question. Now a 35-year-old primee, now see, look what we have done, look what this question is all about. This question is about a clinical profile where A, you have to decide what is the diagnosis first of all, and secondly you have to decide whether or not you want to deliver immediately, right? So 35-year-old primee seen in emergency at 32 weeks, so she is preterm, blood pressure high, urine albumin 3+, so she is definitely preeclampsia, and look at the BP value, it is anyways high, right? So this is severe preeclampsia. Initial lab reports show hemoglobin fine, TLC fine, platelet count less than 80,000. This is less. So this is severe preeclampsia. Further confirms severe preeclampsia for me. LFT and KFT are otherwise normal. She has no complaint of headache, blurring of vision or epigastric pain. So right now impending eclampsia like features are not there. Okay. Ultrasound for fetus. So don't forget the fetus. Fetus is also there. Ultrasound for fetal well-being shows parameters corresponding to 28 weeks with oligo and absent end diastolic flow on Doppler. Right. So there is fetal growth restriction with absent end diastolic flow on Doppler. NST is otherwise reactive. So immediately right now the NST is reactive, right? NST tells you about the acute status of the fetus. So right now it is reactive. What is the next step? So A, she is having severe preeclampsia. B, she is also having fetal growth restriction with absent end diastolic flow. I have to stabilize her condition also. I have to think about delivering also. And at the same time, I want to give good outcome to the fetus also. So for now, there is no impending eclampsia. There is no placental abruption. Think about it. Urgency. One thing is immediately urgent, that needs to be done immediately straight away. So there is no eclampsia. It's not like she has thrown a convulsion. It's not like eclampsia is, the signs and symptoms of impending eclampsia are there. What are the signs and symptoms of impending eclampsia is another question, right? So blurring of vision, headache most important. Then second comes blurring of vision. So headache, blurring of vision, epigastric pain. right? These are the signs and symptoms of impending eclampsia. So those are not given, right? Placental abruption is not there, right? So immediately right now to do something is not needed. But what is the next step now? What is the next step now? Obviously, repeating Doppler after 1 week is out of the question. Just monitoring is out of the question. We have to choose between C and D. Like I told you, let's just work up the patient completely, admit, settle the patient up, give the antihypertensives right now at this point in time. If I have to give the drug of choice here, BP 160 by 110, managing such severe high BP, I'll need IV labetalol. I will need IV labetalol. I can give oral nifedipine also, but never sublingual. Okay. Steroid administration, yes, let's start with the steroid administration. Keep the patient under observation, and I might need to terminate and deliver anytime immediately, depending upon, obviously I'm monitoring the mother also, I'm monitoring the baby also, and I'm also starting with the magnesium sulfate because I know that this is severe preeclampsia. So severe preeclampsia patients in whom we think that we may need to deliver them anytime in the next 48 hours. Those 48 hours are very crucial. I need 48 hours to cover for the steroid. Right. So those 48 hours are very crucial. I feel that, you know, with this absent and diastolic flow, the condition may deteriorate any time and I may need to take up for immediate delivery. So I need to start magnesium sulfate also. That is the best choice answer. Option number D. So when you have severe preeclampsia, please remember that if she would have been 32 weeks, if she would have been 34 weeks, let's say if she were 34 weeks, if she was more than or equal to 34 weeks already, you would have delivered. Then your answer would have been delivered. Okay? If she would have already been more than or equal to 34 weeks, then your answer would have been to deliver her along with the supportive treatment. The fact that she is less than 32 weeks, that means, okay, immediately we don't want to deliver, there is no urgency. Right? Clear? Fine. And you will deliver irrespective of POG, irrespective of POG, if there is eclampsia, if there are signs and symptoms of impending eclampsia, if there is placental abruption, right? So these are few of the important indications, and also with HELP syndrome. Also with HELP syndrome. Okay. Now, other view, you are saying reversed end diastolic flow, deliver immediately. Reversed end diastolic flow is a little controversial, right? Most of us with reverse end diastolic flow, if she is reversed end diastolic flow, if she is more than or equal to 30 to 32 weeks, then we definitely deliver. Then we definitely deliver with steroid cover, right? And the further away from term she is, then it becomes very difficult, right? One has to make that case-to-case basis choice. Okay. Now, let's have, and also please remember, if it is mild preeclampsia, mild preeclampsia meaning no severe features, no severe features at all, BP under control, maybe with or without antihypertensive drugs, doesn't matter. You will deliver at after 37 completed weeks. 37 completed weeks. Induction of labor can be done. It is preferably vaginal delivery. Caesarean section is for obstetric indications. Okay? Fine. Now, next question, again from preeclampsia. Which of the following statements are incorrect regarding magnesium sulfate in preeclampsia? Yes, incorrect statement. Incorrect statement. Straight away incorrect statement. It causes uterine relaxation in a dose-dependent manner. The statement by itself is correct. Okay, but generally the dosages that we give in preeclampsia, generally the dosages that we give in preeclampsia, they are not the classic tocolytic dosages, right? They may cause some uterine relaxation when we are giving the loading dose, but if we are augmenting the patient with oxytocin, with the induction and augmentation can be easily done. So that's not a problem, right? So that's why option number A is a correct statement. It causes uterine relaxation, but in a dose dependent manner. The more that, so the dosages need to be higher. So this is a true statement. This is a correct statement. It has anticonvulsant and antihypertensive action. So it has anticonvulsant action, yes, but it does not have antihypertensive action. If that would have been the case, we would not have to give IV labetalol, no? Why would we need to give that if magnesium sulfate was also doing the job of antihypertensives? So it does not have any antihypertensive properties. It does cause smooth muscle relaxation. That is why with magnesium sulfate, generally the patient tends to complain of, feels a sense of flushing, and warmth because of the increase in peripheral circulation, but it does not cause any it does not lead to any significant antihypertensive action, right? If there is renal dysfunction, the initial loading dose can still be given. See, magnesium sulfate, please remember, is excreted renally. It is excreted renally. Okay, and in preeclampsia, eclampsia patients, there can be renal dysfunction, there can be oliguria, right? But even in that case, the loading dose can still be given and later maintenance doses can be titrated according to the GFR. So this is also a true statement. And neuroprotective role, yes, it is there. It prevents convulsions, yes, it is there. Why do we give magnesium sulfate? When a patient is having eclampsia, then also you say the drug of choice is magnesium sulfate. See, eclampsia, the convulsion that is happening in eclampsia is a generalized tonic-clonic convulsion. It is going to last for a minute or two and then it is going to subside on its own. That is what happens. We are giving magnesium sulfate to prevent further convulsion because the state of eclampsia has set in and convulsions can keep on happening again and again. So that is the role of magnesium sulfate, centrally acting anticonvulsant properties to prevent further convulsions. That is why we are giving it also in cases of severe preeclampsia or in cases of impending eclampsia when we are planning for a delivery also. So we are giving it. Why? Because we want to prevent convulsions. So this is also true. Okay. So the incorrect statement is option number B. That is the incorrect statement. And what are we monitoring when we are giving magnesium sulfate? What are we monitoring when we are giving magnesium sulfate? Remember, first of all, knee jerk, because this is the first to disappear. This is the first to disappear when there is toxicity, right? So knee jerk, that is obviously, yes, deep tendon reflexes we check. We also check the respiratory rate. So knee jerk should be present. It should be present. Okay. Respiratory rate, it should be, it can cause respiratory depression, right? So less than, if it is less than 16 per minute, it should be more. This is when alert is raised. This is when alert is raised. Okay, so please remember, if this is the case, all right, or let's say, what are we also measuring? Urine output. Urine output, if less than 100 ml in 4 hours, okay, less than 100 ml in 4 hours. If this is the case, then you stop further dosing. Stop further dosing. But your respiratory rate less than 12, to ho gaya respiratory depression. Okay, then you will need to give an antidote. Right. So respiratory rate less than 16 is when the alert is raised. At the undergraduate level, this is the level at which alert is raised. One should stop at least further dosing. At least that much needs to be done, right? We will not wait. If it is less than 16, you have not gotten alerted and you end up a couple of hours later with a respiratory rate of less than 12. Now what alert has to be raised before that, no? Right? So that is the thing. And yes, antidote will be needed if in case respiratory depression is actually happening, and antidote you are rightly saying is calcium gluconate. Right, 10% calcium gluconate over 10 minutes given slow IV. Yes, correct. Okay. Now, next question. 45-year-old multiparous woman presented with heavy menstrual bleeding and severe congestive dysmenorrhea for 4 years. Examination, uterus appears uniformly enlarged to 14-week size, tender, adnexa free. Okay, remember this question, these findings are very classical. Ultrasound shows myometrial cyst. What is the next step in management? What is the next step in management? Okay, so please understand, okay. So adenomyosis, right, adenomyosis, right, okay. Do you have a doubt about the diagnosis of adenomyosis that you want to go for an expensive MRI pelvis? What MRI pelvis will tell you now that you don't already know? When your ultrasound is telling you that there are myometrial cysts, which is a very specific finding, when your clinical profile is and the age and everything is telling you that is going in favor of adenomyosis only, you have no doubt that it is a fibroid. There is no suspicion. There is no inconclusive findings also. Why do you want to add an MRI? What extra information will MRI give you in deciding the management? Maybe if she was younger, much younger, where you wanted a confirmation of adenomyosis before trying for conservative treatment options, right? Or let's say there is a type of adenomyosis generally is diffuse adenomyosis, right? That there is a focal adenomyosis also, where adenomyomas are there in the myometrium, small adenomyomas are there, and then it can be confused with a fibroid, but that is not there. Right. So, MRI pelvis is not helping in me the management, right? Now, hysterectomy. So, when you are saying a hysterectomy, okay, hysteroscopy, nobody is saying, which is fine. Hysteroscopy, nobody is saying, which is fine. But nobody is still telling me what endometrial cancer, see, hysterectomy straight away. This is adenomyosis. Right now, the features are suggestive of adenomyosis. Profile suggestive of adenomyosis, right? Do you want to do anything before planning a hysterectomy? Okay, you've made up your mind that adenomyosis, multiparous woman, family complete, age more than 40. Let's go for a hysterectomy as a definitive modality of treatment. I agree with you there, that the treatment of choice for adenomyosis under these circumstances would be a simple hysterectomy, right? But I am asking you, next step, I want to ask you if there is one investigation you may want to do before the treatment. Yes, very good. Now, Vishal and the other one, yes, endometrial aspiration, workup complete. Work up completely, right? This is a woman who is more than 40 years of age, right? She has a complaint for 4 years, right? With her age alone, she qualifies to rule out endometrial hyperplasia that has the potential for changing the management, right? So, endometrial aspiration needs to be done before deciding on a definitive treatment strategy. They have asked this question not in this manner but in another manner. When they gave the question, they said that a woman is obviously more than 40 years old and she had a small intramural fibroid. Okay, or they can say that the woman is, on tamoxifen therapy and, she's having this perimenopausal age group and she's on tamoxifen therapy, and then they will frame it around in a manner that will make you think that endometrial aspiration is needed and justified before deciding the treatment. This is an often repeated question in different setups and scenarios. Right. So, keep this in mind. Endometrial aspiration is your answer right now. Right. So, AUB in reproductive age group, always rule out pregnancy also, especially in acute episodes of bleeding. Palm-Cohen is the classification system where we broadly classify the diagnosis one way or the other. Structural causes broadly means that they can be picked up. See, investigation of choice is a transvaginal sonography. Structural causes means that they can be picked up and seen on ultrasound imaging. So, basically, structural causes means that there is some evidence on imaging or histopath. That is what structural causes mean. Non-structural causes are the Cohen group. There is no evidence on imaging or histopath. That is basic difference, right? So, some evidence for polyps, adenome, leiomyoma and malignancy will be there on imaging or histopath, and there will be a clinical profile. Don't forget history and examination. Like for example, adenomyosis will present in the manner that I discussed in the question. With fibroid uterus, the dysmenorrhea is very unlikely with fibroid uterus. isn't it? Like that. And again, the clinical examination findings will be different. I'll tell you, wait a bit. And polyps also present differently. Polyps will present with intermenstrual bleeding. They can present with any sort of abnormal uterine bleeding pattern, but intermenstrual bleeding is going to be very typically specific for endometrial polyps or even fibroid polyps that are protruding into the uterine cavity. So, if you have a high degree of suspicion for polyps, your investigative framework will change, right? So, depending upon what your initial workup shows, initial workup meaning workup involving history, workup involving clinical examination and a baseline ultrasound to begin with, which will clear a lot of things, will decide what further investigations are needed. And in non-structural causes, these are the Cohen group. You will not find anything in the examination findings or in the imaging or histopath. And then you need to remember the indications of endometrial aspiration separately. So, age more than 40 years, right, in like, and or the other is when there is multiple risk factors for endometrial cancer, or even if failed management, medical management, then can be done earlier also, can be done earlier also if there are multiple risk factors for endometrial cancer. Like for example, let's say history of prolonged anovulatory cycles. And like I said, if there is history of tamoxifen therapy also, so keep that in mind. Okay, and also if the ET is more than 12 mm, more than or equal to 12 mm. So, in reproductive age group, the cutoff for endometrial sampling or endometrial aspiration is 12 mm. Right. So, all perimenopausal cases and any postmenopausal endometrial aspiration should be done irrespective of ultrasound findings. Very good. That is a very good way to remember and summarize. Now, what is the indication of hysteroscopy? Indication for hysteroscopy is when there is a strong clinical suspicion of intracavitary lesions, like for example, if there is persistent intermenstrual bleeding or ultrasound is showing findings suggestive of an intracavitary lesion and you are not sure on ultrasound, you want to doubly sure, right? Then of course you want. So, persistent symptoms even after medical treatment or curettage, you have done a curettage but your symptoms are persisting. That means maybe there is some endometrial focal pathology that has been missed out when we are blindly curating the endometrium. So, these are important pointers as indications for hysteroscopy. And the other important thing you need to make a note of is the changes between fibroid versus adenomyosis. This is an often asked question and this is an often asked images, right? So, you can see here, this is the adenomyosis gross specimen, right, thickened myometrium, and here this is the classic world appearance of fibroid, right, and you can see these benign tumors here. Okay. Ultrasound is often the first line investigation and is often, so this is TVS has been done, often good enough to make the diagnosis. Like for example here, this is what you see here, this is the outline of the uterus, this is the lining and cavity, where the endometrium is ending, where the myometrium is beginning, that loss of endomyometrial junction. Look at all this hyperechoic area here, look at all of this hyperechoic area here, right. So, this is loss of endomyometrial junction. These black areas here, these here, hypoechoic black areas, right, these are the myometrial cysts. These are the myometrial cysts which are very typical of adenomyosis, and then we have this as the rays of the sun like appearance, you know, where you have the blind on the window panes. So, this is called as the Venetian blind appearance. Sometimes you have not in this image, but you can have a salt and pepper appearance. Not in this image, but you can have a salt and pepper appearance. So, they are very typical of adenomyosis. And look at this here, fibroid can be very easily diagnosed on scan. So, this is the image and uterus outline, this is the cavity, and this is, right, this is a heterogeneous, well defined mass in the myometrium. Okay, this is the boundaries here, right? So this is a fibroid. This is a fibroid, right? Very clearly. So ultrasound is often good enough. This time they also asked MRI images. Now please remember here that MRI is not always necessary to differentiate between a fibroid and a adenomyosis. If there is a confusion, okay, then yes, one may, or if one needs to differentiate whether it is an adenomyoma, focal adenomyoma, or a fibroid, then it can be used to differentiate. Now look at this. This is MRI imaging showing adenomyosis. Okay. So this is the outline of the uterus, okay, and you can see this thickened myometrium. What you're also appreciating in this image, can you see this hyper intense white line in the center? This hyper intense white line in the center here, this is the endometrium, right? And then you can also see these white dots, hyper intense white dots in the myometrium in the junctional zone. The junctional zone thickening is also there, and myometrial cysts on MRI will give these hyperintense foci on MRI. So that is also what we are appreciating here. You can see here, you are not seeing too much of myometrial cysts, maybe one here, a couple of here, but what you are seeing is junctional zone thickness. So what you are appreciating is junctional zone thickness. If it is more than 12 mm, it is diagnostic of adenomyosis. If it is less than 8 mm, it excludes the diagnosis of adenomyosis. If it is in between, again it becomes unequivocal. So frankly speaking, the definitive diagnosis of adenomyosis is made after a final hysterectomy specimen. Most often, the 100% definitive diagnosis is made on the final hysterectomy specimen. Many times this happens. Okay, and now compare, this is fibroid. So this is fibroid. Now why would a, if the scan showed a single intramural fibroid like that, I don't need MRI to diagnose, no. So MRI for fibroid diagnosis is required if there is some discrepancy between ultrasound may not be showing unequivocal findings between fibroid and adenomyosis, or let's say like in this particular patient. So this is a huge uterus. I mean, you know what, this is the endometrial lining. I'll have to give you the findings straight away. This is the endometrial. This is distorted. This is the uterus distorted outline. See, irregularly enlarged uterus. There's a huge cervical fibroid. There are multiple fibroids like this. Okay, and maybe this patient was being planned for a myomectomy surgery, and I want the precise fibroid mapping, and I want the precise location of where these fibroids are. So the investigation has to serve a purpose. Okay, so yes, there is a role of fibroid diagnosis by MRI also, but not in all cases, not routinely. Next question. 32-year-old multiparous woman presents with complaint of heavy menstrual bleeding for 8 months. She was using OC pills earlier but now wants to conceive. Physical exam findings are normal, and transvaginal sonography shows a 4 centimeter submucosal fibroid. So generally if there is a fibroid, right, fibroid feels firm, fibroid uterus feels firm, irregularly enlarged uterus can be there, or it could be normal physical findings. Makes sense. It is a submucosal fibroid protruding into the uterine cavity. It is not big enough to distort the size of the uterus or distort the outline of the uterus, quite possible. And it is protruding into the uterine cavity. What is the treatment of choice? Excellent. The treatment of choice is a hysteroscopic myomectomy. So please remember, we have FIGO type 0 and type 1. Okay, type 0 is when it is protruding into uterine cavity completely, and type 1 is it is less than 50% into the myometrium. Okay, so basically more of it is into the cavity. When more of it is into the cavity, that means it is either like this type 0 or like this. More of it is outside. Okay, type 0 or type 1. Then it is approached hysteroscopically. All right. Now, if you have a let's say intramural fibroid or a subserosal fibroid, then you'll have to approach it laparoscopically. And wherever laparoscopy is feasible, minimally invasive surgery will be more preferable than an open myomectomy or an abdominal myomectomy, right? So the answer here is hysteroscopic myomectomy. GnRH analog is not the answer because she wants to conceive. Right? GnRH analog is not the treatment because she wants to conceive, and when she is on GnRH analogs, the follicular growths and everything, she will not be able to get pregnant while on therapy. Moreover, the fibroid will shrink, and then after a couple of months down the line, when you will stop the GnRH analog treatment, it will increase in size again. So it is just temporary. So that is not going to work. And uterine artery embolization is also not preferable in women who are wanting to conceive. So that is why those are not the answers. So look at this here. This is the patient we were talking about, this particular patient with the submucosal fibroid. Look at this. Appreciate the difference between two images. Both are intracavitary lesions. Let's just appreciate the ultrasound images first. Okay. Look at this one here. This one here is the uterine lining. This is the endometrium, and this is a mass which is inside, all inside, right? Fine. And if you look at this one here, this is also the lining, and this is the mass here. This is hyperechoic. Can you see this is more white? So they will describe it as hyperechoic. They will describe it as hyperechoic lesion inside the uterine cavity with a single vessel feeding into the lesion. Feeding vessel sign. Then the answer is endometrial polyp. Then the answer is endometrial polyp. And obviously best for diagnosis is a hysteroscopy. Hysteroscopy will tell us, okay, it looks like an endometrial polyp. It is very friable, reddish looking, right? So hysteroscopy, but final diagnosis will be when I remove it. Hysteroscopy, polypectomy will be done. I will send it for histopath, and then I will have the ultimate final diagnosis. Right? Now, look at this. Here you have, it's not hyperechoic, it's not all white, it's heterogeneous appearance, that which is going in favor of a fibroid, right? And remember, a fibroid has peripheral vascularity. If you remember the pathology of a fibroid, you'll remember that the center is least vascular and the vascularity comes from the periphery. Here you will see peripheral vascularity. They may describe it to you, they may give it as an image. So this is basically an intracavitary or submucous fibroid. So this is fibroid myoma. This is the hysteroscopy image, looking more solid, right, looking more pale. So this is the fibroid here, intracavitary fibroid, right? So again, for any intracavitary lesions, hysteroscopy is often the best for making the diagnosis. Now you're asking, saline infusion sonography has a role? Yes, it has a role. Why not? Saline infusion sonography is better for diagnosis of intracavitary lesions, and saline infusion sonography will be done when we are doing a like, for example, I'll just give you an example. I have a classical patient. I have a patient with a history of intermenstrual bleeding. Okay, I have a patient with a history of intermenstrual bleeding. I have a patient, maybe along with that she has also infertility and difficulty conceiving. This is her scan. There is a hyperechoic lesion with the feeding vessel sign. Now I have a choice of going for a saline infusion sonography. If I wanted to do it, I should have done it at the same time when I was doing the scan. And the other choice is that I go for a hysteroscopy. Bhai, I will choose a hysteroscopy na. The clinical profile of the patient, the ultrasound findings, which is very much pointing in the direction by saline infusion sonography, and then I will decide whether I not to do, right? So I may as well go for a hysteroscopy, which will be diagnostic and therapeutic in the same setting. That would be a better thing to offer. Right, and obviously if the patients can then choose or not to give consent, right? Similarly, if I have a patient like this intracavitary myoma, which is clearly seen, right, then no need, then we can plan for a hysteroscopy if we want to go for a therapeutic, like if you want to plan a surgery also, then hysteroscopy will be done at that time and diagnosis can be confirmed at that time also. So it this thing. So how to differentiate from ring of fire from fibroid on use? So ring of fire simply means that there is vascularity in the periphery. You find the ring of fire in corpus luteum also. You find a ring of fire in an ovarian cyst, which could be a corpus luteal cyst with a ring of fire. You find a ring of fire in the tubal ring of fire sign because it is in the tube, it is an adnexal mass in the tube, ring of fire, vascularity from the chorionic vessels and everything. That's tubal ring of fire sign, right? So ring of fire can be just basically Doppler is being used to look at the vascularity around the periphery of the mass. That is ring of fire. And yes, Rukmini is rightly pointing out the clinical context differs. So many times radiology report, they will tell you correlate clinically, isn't it? So there is no radiological assessment without a clinical correlation. Next question. 46-year-old woman complained of postcoital bleeding and is found to have cervical erosion on speculum examination. What are the most appropriate steps taken? Now, clinical approach to postcoital bleeding is an often repeated question, right? So, postcoital bleeding is a very specific complaint that something is on the cervix. And postcoital bleeding is a very specific complaint of CA cervix, and CA cervix is the most common gynae cancer in Indian women. And in our country also, we tend to see CA cervix with this bimodal age also. We see it in older postmenopausal women, and we see it in younger women in their late 30s and 40s also. So CA cervix being a very, very possible diagnosis for us, right? So yes, we want to go for some form of cervical cancer evaluation, but obviously we begin with a per speculum examination first. That is what we are going to do. And in the beginning of the lectures where we were talking about the vaginal discharge, I told you whenever you are putting in a speculum, if there is any sample that needs to be taken, please take it first and then complete your PV later. So yes, we did a per speculum examination. If there is a growth on the cervix, you will biopsy it straight away. But if there is no growth, right, many times what happens in our country is that patients are inappropriately screened, right? Go for some sort of screening for cervical cancer. Go for some sort of screening for cervical cancer. Do this much at least, right? So the answer here is liquid based cytology, HPV DNA testing and cervical biopsy. Depending upon what the findings are, that would be the most appropriate step. Okay, HBV, HCV out, hepatitis B, C, whatever, these are bekar options, and HIV DNA testing is also not needed. So the question here was about the possibility of finding cervical cancer there. So if there is no growth, then also we do some sort of screening for cervical cancer when there is postcoital bleeding. Let's say that we found the abnormal results, and then of course we will further go for colposcopy and directed biopsy and further workup. Colposcopy and directed biopsy and further workup, like that, okay? But if screening for cervical cancer results, let's say, are normal, screening for cervical cancer results are normal, and she has persistent symptoms, can you just leave it at that? Can you just leave it at that? Screening is for asymptomatic patients, for general population of patients, right? And this is a symptomatic patient, and this is the symptomatic patients. So if nothing else is there, your screening is normal, she is having persistent symptoms, right? Let's say, for example, if she had, abnormal uterine bleeding also, if she had intermenstrual bleeding also. So if there were other associated symptoms, then we would have gone for a transvaginal sonography also. But let's assume that none of that thing is there. Let's say everything else is normal, the screening results have also come normal, still she is having persistent symptoms. Screening can have false positive, false negative. In a symptomatic patient, normal screening results will not be very reassuring. So with persistent symptoms, please go ahead and go for a colposcopy and a directed biopsy if needed. So that is your flow chart for clinical approach to postcoital bleeding. Okay, and one more thing which we did not do earlier. There are 3 more questions left, but I need a page. Wait. Oh, where's my page? Oh. come somewhere.
पेज पे क्लिक कीजिएगा।
कहाँ पे? यहाँ पे?
नहीं।
हाँ, got it. Thank you. Add page. Okay. So one more thing that I want to, acha, this is I've added incorrectly. Undo. Here I will add page. Okay, whatever. Let's just do one more flow chart, okay? So this is postmenopausal bleeding. This is postmenopausal bleeding. Again, the most common cause of postmenopausal bleeding, when you talk about India, it is CA cervix. Okay, when you look at the uterus, 10% cases are because of endometrial cancer. Otherwise, in the uterus, most commonly it is atrophic endometritis. Atrophic endometritis. Okay. Overall, it is CA cervix. So, when we have postmenopausal bleeding, again, go for a history examination, go for a pars speculum examination also. Right. If there is a growth on the cervix, then you need to take a cervical punch biopsy straight away. If everything else seems normal, then we can go for a transvaginal sonography, right? And a PV is also normal, let's say. Everything else, physical examination is normal. We can go for a transvaginal sonography and we can see the endometrial thickness. Okay, if the endometrial thickness is more than or equal to 4 mm. So that's the difference here. In postmenopausal women, the cutoff is 4 mm because we are expecting endometrium to be atrophic in postmenopausal women. So if it's more than or equal to 4 mm, then you go for endometrial aspiration, right? As the this is office-based, OPD-based investigation where, you know, Pipel's cannula is used. Another important point to remember, Pipel cannula is used. This is an OPD-based procedure. Okay. So, this has to be done to rule out endometrial hyperplasia or cancer. And if the endometrial thickness is less than 4 mm, one can observe. But if she is having persistent symptoms, then you go for an endometrial aspiration. Because remember, endometrial cancer can arise in an atrophic endometrium also. So, persistent symptoms in a postmenopausal woman will deserve evaluation. Don't take it lightly, right? So, that is the thing, right? Now, the other thing is that if we have done an endometrial aspiration, it comes out to be normal and yet we have persistent symptoms, right? Then what do we do? See, endometrial aspiration, we can have 10% false positive also because we're doing it in the OPD, we are putting in the cannula, sucking out the endometrium, we're going in blind. So, there's a possibility of missing, which the false negative can be there, but most of the times it will pick it up for us. But if it is normal, yet she is having persistent symptom, there's a possibility that some part of the endometrial cavity evaluation was missing. Maybe we failed to suck that endometrium out, or maybe it is the focal pathology. Maybe the endometrial pathology is focal hyperplasia is there, you know. So, best to go for hysteroscopy, hysteroscopy guided biopsy. Hysteroscopy guided endometrial biopsy, right? Now, when you are saying fractional curettage of endometrium, fractional curettage na, we used to do is obsolete now. I'll tell you why. Understand what does fractional curettage mean. Fractional curettage means, initially there is a concern for malignancy, right? So initially when hysteroscopy was still evolving, right, they thought that, you know, in hysteroscopy we put the fluid inside and we distend the uterine cavity, it may disseminate the malignancy upwards. Later on, studies have shown that this was not true. So, in suspicion of cancer patients, people used to avoid a hysteroscopy, right? Instead, what they used to do, and hysteroscopy was not available too much also. So, what they used to do, fractional curettage. Take the patient up under GA, dilate the cervix, and fractional curettage meaning curate out, again, this is still blind. This is still going in blind without vision and curating out the anterior wall, posterior wall, lateral wall, endocervical area, every nook and corner curating out, making sure that you curate out every bit of endometrium inside. That is what was fractional curettage. It was still a blind procedure without any vision, not doing under vision. But now it is hysteroscopy guided endometrial biopsy. You can go for hysteroscopy. Hysteroscopy guided endometrial biopsy, right? So that is this thing, and or sometimes they also call it hysteroscopy guided fractional curettage. Sometimes they also call it that. Okay, but between fractional curettage and hysteroscopy guided biopsy should be the better answer. All right, so this is it. Now, if they ask you, there is a woman with postmenopausal bleeding. Okay, there's a woman with postmenopausal bleeding. Let's say everything is normal, PSPV normal, and they ask you investigation of choice, single investigation of choice. And you had to, you know that it is not hysteroscopy, it is not the first line investigation. You have to choose between ultrasound and endometrial aspiration. What would be your investigation of choice if you had to pick one? Huh? Anybody answering? What would your investigation of choice be? I have to given you a clue also because I was too quick in circling. If you have one thing to choose in this particular patient, you will have endometrial aspiration as the investigation of choice because you don't want to miss out on malignancy. The fact that she is postmenopausal with persistent postmenopausal bleeding, malignancy is very high on the list of concerns. You don't want to miss it out. So, if you have just one choice, TVS or endometrial aspiration, pick endometrial aspiration as the answer. Now, next question. A woman is seen with history of recurrent transverse lie in her 3 pregnancies. Which uterine anomaly is most likely? Actually, I just built in this question. It's a very easy question. Let's see if you can answer this. But I want to show you slides and images of these anomalies because again, image-based questions direct have been asked in recent exams. Right. What is the difference between endometrial aspiration and biopsy? Endometrial aspiration is when we use a Pipel's cannula. That is why I said office-based Pipel's cannula, right? Cannula is inserted. The technique of sampling is different, right? So, endometrial aspiration is done. This is a form of endometrial sampling. There are times where Pipel cannula is not there. You want to use a Carman's number 4 cannula also with a 20 cc syringe. You're still aspirating the endometrium. Go inside with the cannula, aspirate, right? There are times when one would go for endometrial sampling using an endometrial biopsy curette. The metallic endometrial biopsy curette. Sometimes in Sarkari Aspitals, this Pipel cannula is not there. When we were doing our post-graduation, we did not have Pipel cannula in the OPD. What did we have? We either asked the patient to get a Carman's cannula number 4, buy it, or otherwise we were left with the choice of an endometrial biopsy curette, which is a metallic curette. But then it has to be, you have to curate it out. So that's endometrial biopsy curette that we do. How we sample out the endometrium, that is the difference between aspiration and biopsy. All right. So, aspiration is when you're taking the tissue out, but you're just aspirating it. The technique is a little subtle difference. Sometimes even that endometrial biopsy is not there. I've worked in peripheral healthcare centers where I have sampled the endometrium doing DNC. I did not have an endometrial curette, I had a uterine curette. What was available, we make do with that. But then again, Pipel's cannula is the cannula which is preferably used because it's soft, it is plastic, right? Very it can be introduced even without causing any cervical dilatation, right? The procedure becomes very patient friendly, can be done in the OPD with ease and will yield the results also like that. Okay, so where were we? Yes, what is the answer? History of recurrent transverse lie in 3 pregnancies. Okay. Recurrent malpresentations. So, it could be recurrent transverse lie, they could have mentioned recurrent malpresentations or recurrent breaches also. Which uterine anomaly is most likely? Think, please. Okay. When there are uterine anomalies, structural uterine anomalies which are Mullerian anomalies, yes, recurrent pregnancy loss, especially in the 2nd trimester, is one outcome that can happen. It is very difficult to predict who will have this recurrent pregnancy loss. If the pregnancy does happen to continue, there is risk of fetal growth restriction because of the restricted space. There is chances of placenta implanting on the septum also. Uteroplacental insufficiency risk is also there. Going into preterm labor is also the risk, right? And this is something very specific. Bar, every time she is having recurrent transverse lie. It means that the cavity is distorted. So, it is either a septate uterus or a bicornuate uterus where the cavity is distorted, and that is why this recurrent malpresentation, most likely if the cavity is distorted, right. With the uterine didelphys, there is that dual uterus, double uterus is there. Double uterus, double cervix, double uterus, double cervix, complete in itself. In fact, with arcuate uterus, the cavity is essentially normal only. It is just a mild variation. With unicornuate also, there is one side uterus. The other side, one side Mullerian duct is developing. The other side is not developing. But the cavity isn't distorted. So, when the cavity is distorted, then recurrent malpresentations, recurrent transverse are more likely. That means it is something like this. Maybe the cavity is distorted, and that is why every time it is a transverse lie. So, among the options, bicornuate uterus fits. That would be the answer. Yeah, it could be septate also. It could be septate also. Septate is more common than bicornuate uterus. Septate is in fact the most common type, right. So, there are certain unusual, we all know that these anomalies can cause recurrent pregnancy loss. And also septate uterus is more likely, septate is the most problematic. Septate uterus is the most problematic. Remember this line. It is the most common, it is the most problematic. Why? Because you will think that it is a small septa. Even if it is a small septa, it can create more problems than a bicornuate uterus, right. There is a pregnancy, early pregnancy, small pregnancy trying to implant on the septum, can lead to implantation failure, can lead to infertility complications. As such, in general, these anomalies don't cause infertility. As such, these anomalies, mind my words, as such, these Mullerian anomalies don't cause infertility. But there is one which is capable of contributing to infertility, and that is septate uterus, capable of contributing to infertility. As such, these Mullerian anomalies, they cause recurrent pregnancy loss. They can cause recurrent pregnancy loss in second trimester. If there is one anomaly that is capable of causing first trimester abortion, it is septate uterus. But if they ask you, most commonly septate uterus will cause which kind of abortion? It will cause second trimester abortion most commonly. But it is capable of causing first trimester abortion also. So, septate uterus is the most problematic. Okay. Now, so the answer here is bicornuate uterus. Now, if you look at these images, Ritvik, bachche 2 times speed, I am completely exhausted. This is as fast as I can go because, if I go with a lot of speed, then what is happening? Wrong words are coming out of my mouth somehow. Now, let's get started. If we have these HSG images, okay, very quickly we will go through the images, and the this is also the gross imaging is also there, and the HSG imaging is also there. So, this is like, these are the HSG images. This is likely bicornuate. You can see the dip here at the fundus. And one thing that you note here in this HSG images is the angle. The angle is obtuse, okay. The angle is obtuse, wider angle is there. So, this one is likely bicornuate, okay. And if this is the situation here, you can see here there is no dip at the fundus, okay. There is a single cervix in both the things, and the 2 uterine cavities are there. And if you look at the HSG film, you can see that the angle is acute. So, this is likely septate, okay. I am saying likely Likely, I don't know for sure. Likely, I don't know for sure. Okay. And in this, they will tell you something or the other. They will tell you 2 separate services seen. They will tell you this. 2 separate services seen. 2 separate uterine cavity, dip at the fundus. HSG image, you will see 2 cannulas. Then this is didelphys uterus. Then this is didelphys uterus. Okay. Here you can see going into one side only, this is unicornuate. This is unicornuate uterus. Okay. Fine. And the investigation of choice for these Mullerian anomalies is 3D transvaginal sonography. MRI can be done for complex anomalies when 3D USG is not able to give the diagnosis or is giving inconclusive diagnosis. So here can you see, I will just outline it for you. So this is the uterine outline, this is the cavity, right? No, this is the uterine outline, and this is the cavity, and this is the cavity. Right. So this is bicornuate. This is the same, that is why it is kept under that. Here you can see this is the outline. This is the outline of the uterus, this is the cavity, and this is the septum. This one is septate. This one is bicornuate. Right. And if you look at this 3D ultrasound image, the cavity is more or less normal. There is no dip at the fundus, and this septum length here, this septum length, look at this septum length, this is the length of the septum. Here what is the septum length? Here the septum length is less than 1 centimeter, this is arcuate uterus. The cavity is more or less normal only. Okay. So investigation of choice is 3D transvaginal sonography. MRI can be done for complicated anomalies, and yes, gold standard, very good, lap plus hysteroscopy. That is obviously the gold standard, but is not necessary in all the cases. I do not have a 3D ultrasound image of a didelphys uterus, it's extremely rare. Next question. 28-year-old woman, para 3, live 3, presents with something coming out of vagina for past 1 year. In prolapse questions, what you tend to remember here is mostly they are asking questions about matching the kind of surgery and where it is done, right? So she also reports discomfort. The story is this, that she has prolapse. There is a uterocervical descent beyond the introitus. If uterocervical descent is happening beyond the introitus, it is at least third degree prolapse. Which of the following is the most acceptable management option for this patient? She is young. She is multiparous. Young multiparous women, when they have uterocervical descent, it is mostly associated with elongation, supravaginal elongation of the cervix. That is why they tend to benefit from a surgery that is called as Fothergill repair, which is also called as Manchester repair. It is the same thing. Manchester repair is from the Manchester hospital where it is done. Fothergill is from the person who gave the Fothergill stitch to cover the cervical stump. So this is where the cervix is amputated. Right, and the cardinal ligaments are basically pulled up and tied in front of the amputated cervix. So answer is Fothergill's repair. For such a young woman, hysterectomy is not the choice. Okay, she has a long way to go. She is only 28. You do a hysterectomy now, get rid of all the supports of the uterus. People are moving. We are moving away from hysterectomy for prolapse cases. All right. With hysterectomy, there is future risk of post-hysterectomy prolapse also. At such young age, hysterectomy is never the answer. Please remember. Colpose suspension surgeries. You will feel that colpose suspension surgeries, please remember, are suspending the vagina. Right. So basically they are lifting the vaginal wall up. This is how I remember it. Colpo is for the vagina, suspension is suspending the vagina. But what they are actually doing is, in front of the vagina is the the urethra. Right. So when we are suspending the vaginal walls, we are kind of lifting up the urethra. Okay, so colposuspension surgeries are for stress urinary incontinence, like Birch colposuspension surgeries, like MMK procedures. These are for stress urinary incontinence. But even nowadays, you know, these surgeries are not the first line. If you have first line therapy for stress urinary incontinence, it is pelvic floor exercises. They are tried for a couple of months, right? If they work fine, otherwise first line surgery for stress urinary incontinence is the mid urethral sling, Mid urethral slings are the TOTs and the transvaginal tapes, transobturator tapes and transvaginal tapes. These are the first line surgery for first line procedures for stress urinary incontinence. Now, what is Lefort's repair? Lefort's repair is or this is also called as Lefort's colpoclysis. If you remember the complete name, colpoclysis, okay? Colpo, again, vaginal walls, and clysis, they're stitched together. So, anterior and posterior vaginal walls are stitched together. Prolapse is pushed in, okay, repositioned, and then anterior posterior vaginal walls are close together. And that is going to be an option where surgery or a major surgery, a patient is not fit for a major surgery. So, the patient is not going to be sexually active, Okay, we have ruled out the possibility of genital malignancy. And I'm putting more emphasis on the fact that she is not going to be sexually active. Generally, you tend to say postmenopausal. Postmenopausal does not necessarily mean not going to be sexually active. The primary thing is not going to be sexually active, and yes, she should not be menstruating, obviously, because, you know, if she's going to menstruate, you close off the vaginal walls, then, you know, outflow, where will it happen? So, yes, postmenopausal, yes, but yes, not going to be sexually active. Postmenopausal, we ruled out the possibility of genital malignancy and everything, and then one can go for, and not fit for a major surgery, then one can go for Lefort's repair. Okay, fine. Otherwise, in postmenopausal women, what is going to be the treatment? Otherwise, in postmenopausal women, what is the general treatment? Vaginal hysterectomy with pelvic floor repair. What is pelvic floor repair? If there is a cystocele, it will involve anterior colporrhaphy. If there is a rectocele, it will involve posterior colporrhaphy, and perineal repair, perineorrhaphy. So, the entire thing, vaginal hysterectomy with pelvic floor repair. Now, which of the following is an absolute contraindication for the insertion of the device that is shown in the image? It is copper T, 380A. 380A is in the image shown. It could be any copper T for that matter. So, absolute contraindication. Yes, absolute contraindication. Copper T can be introduced as long as we are certain that the woman is not pregnant. Okay, so post-menstrually, generally we prefer to insert it after 5 days, you know, post the LMP, because, you know, with the bleeding we preferably don't want to, it is uncomfortable also for the patient, you know. So, we tend to tell her, okay, after 5 days you come when your bleeding has stopped, right. So, any time in the month it can be introduced, preferably post-menstrually, but as such menstruation is not a contraindication, right. Immediately after delivery also we can introduce. Post-placental insertion can be done within 10 minutes. So, post-placental can be done within 10 minutes. And also, if this opportunity is missed, then postpartum within 48 hours. If this opportunity is also missed, then after 6 weeks. Okay. So, trophoblastic disease, if it is there, then, like for example, you have a molar pregnancy and we've done the evacuation and then we are following up that patient. Meanwhile, the patient is put on contraception, but copper T will not be used. Any intrauterine device, even copper T, even Mirena, any intrauterine device with trophoblastic disease is supposed to be contraindicated. Ruptured condom during intercourse, of course, it can be used as an emergency contraceptive also. It is the most effective emergency contraceptive. Okay, it can be inserted within 5 days of unprotected sexual intercourse. Within 5 days of unprotected sexual intercourse, it can also be put even after ovulation has occurred. Even after ovulation has occurred. So that is why it is the most effective, right? In fact, if you remember that copper T acts by inhibition of fertilization more than inhibition of implantation, and it starts to work immediately after insertion, right? So it can be, it doesn't depend upon its contraceptive efficacy does not depend upon inhibiting ovulation at all. Please remember that Mirena is not an emergency contraception. Please keep that in mind also. Please keep in mind that when you talk about hormonal emergency contraception, the one that is available over the counter, which anybody, you and I, can buy is levonorgestrel eye pill, right? Please remember the dose, 1.5 milligrams single dose, right? To be taken ASAP, as soon as possible after unprotected intercourse, preferably within 72 hours of unprotected sexual intercourse, right? Now, there is another hormonal EC, which is ulipristal acetate. There's another hormonal and emergency contraception, that is ulipristal acetate. Under the trade name LR, 30 milligram is the dose, right? And it can be taken within 5 days or within 120 hours of unprotected sexual intercourse, but prescription will be required. It is not available over the counter, and in general, yes, this is more effective as compared to levonorgestrel eye pill, but then it is requires a prescription. Okay, so this is about your LRR, and that finishes the number of questions I had. My target was 4 hours, but I think we have extended this thing. Now, for previous question, which is the prolapse question, Hemant, you are saying, no, Doc Vishnu is saying, sacrocolpopexy would have been a better option if it was there. Sacrocolpopexy. First of all, it will become sacrohistropexy. है ना? It would become sacrohistropexy. Sacrocolpopexy, sacrum and the vaginal vault, colpopexy. That's for vault prolapse, right? And yes, you are right. If there was sacrohistropexy, though they have better results as compared to Fothergill's, but sacrohistropexy is much more preferable if, you know, if future fertility is also required, you know, like that. As far as the results of the surgery are concerned, sacrohistropexy will give good results, mesh surgery, but then surgical expertise for sacrohistropexy is very limited, right? So, multiparous in the Indian context, I think Fothergill's repair, they will not put you in this situation, is what I feel, because even I don't think that there is one right answer there. In case of a multiparous woman, if you have to choose between Fothergill's versus sacrohistropexy, sacrohistropexy is a mesh surgery, will turn out to be expensive, will turn out to be will need more expertise, and will be an abdominal or a laparoscopic procedure and everything. So, the choice is very difficult as such, right? So, they will not put you in that choice where there are no straight answers, right? So, that is why you've never found this question where you have a multiparous woman and sacrohistropexy is in the option, right? I will not put you in this, I will not put an undergraduate student in this situation, right? Now, Chaya contraception. Chaya is basically Saheli, right? Chaya is Saheli centchromen. Saheli was the previous name, and centchromen is it is a selective now my pages are over. Selective estrogen receptor modulator, right? It acts with estrogen antagonistic action on the endometrium. Chaya, previously Saheli, centchromen, right? SERM, causes endometrial thinning, estrogen antagonistic effect, prevents implantation. That is how it works. Once a week pill, it is called. Initially it has to be given twice a week. Initially it has to be given twice a week, but then later on it has to be given once a week. Now, what else? Better option between letrozole and clomiphene citrate in case of PCOS, in case of infertility. See, letrozole and clomiphene citrate both are first line drugs. Okay, letrozole came in a lot of controversy in the past couple of years because it was being used off label for ovulation induction. It was not really marketed for ovulation induction in infertility cases, right? So if there is any doubt regarding your letrozole or clomiphene citrate, there was a concern earlier, but letrozole is more preferable because studies in PCOS women have shown that there is a more pregnancy rate, less of abortion rate, you know, with letrozole induced cycles, and also monofollicular development also happens. So letrozole is preferred. If you have to pick one answer, then for drug of choice with PCOS for ovulation induction, pick letrozole over clomiphene citrate. However, both are first line drugs. Okay, what else? In Fothergill, cervix is removed, so done if not planned for future pregnancy. Yeah, that's correct. So Fothergill's is, and especially when there is supravaginal elongation of the cervix. So that's why it is applicable in young multiparous women, you know, where there is supravaginal elongation of the cervix, they benefit from cervical amputation. Okay. And cervical amputation is not going to be an option for nulliparous prolapse, right? With nulliparous prolapse, this will not be an option. So sling surgeries are going to be an option there. And like this sacrohysteropexy, which we were talking about earlier. Okay. During our internship, I remember your young woman's fertility should always be preserved irrespective of her parity. Well, that's the correct way to look at it. That is a way to look at it, yes. That fertility should be preserved irrespective of parity because you don't know what life holds in the future. So even if his family is complete, then one should definitely offer her sacrohysteropexy, like you said, that preservation of fertility option should be there, depending upon whether they are made available or no. Right. So many times preservation of fertility option may not be available because of the limitation of the services that can be provided. So that is also there. Right. So though that statement you are saying is correct, that I do believe, yes, a fertility should be preserved irrespective of a parity, uterus should be preserved irrespective of the parity, and uterus should be preserved irrespective of the parity. So like I said, that it's a very difficult choice to make if both are in the option, because advantages of both are there. Right, that is why they will not give you a question in which both options are there. Now, let's see. About OHHS and drugs causing OHHS. OHHS is ovarian hyperstimulation syndrome, right? It will happen typically in gonadotropin-induced cycles. So, OHHS, gonadotropin-induced cycles. Where are we using gonadotropins to induce follicular development? We are doing in IVF cycles where we are doing controlled hyperstimulation. Where we are doing controlled hyperstimulation. We are wanting many follicles, but we are doing it in a controlled manner, titrating the dose of gonadotropins with the amount of estradiol that is rising in the serum and tracking the growth of the number of follicles and everything. But with gonadotropin, the risk of overstimulating is always there. The risk is almost not there with letrozole, and very minimal with clomiphene citrate. With clomiphene citrate, letrozole anyways for control hyperstimulation we can't do with these. When we are using gonadotropin, that is the thing. So the drug that is responsible is gonadotropin. And also remember here that it is very likely, more likely when you are using HCG as a trigger for ovulation. So the second trigger comes from HCG. HCG also stimulates the ovarian stroma. Okay, so the next trigger comes from HCG when we are using HCG as a trigger for ovulation. So one time the early onset OHHS happens when we give the ovulation trigger and it can present at that time. Then there is also a late onset OHHS which comes when the woman conceives, because when she gets pregnant, HCG is coming from the pregnancy, from the syncytial trophoblast of the implanting pregnancy. Then there is a late onset OHHS also. With an early onset OHHS, one can discard the cycle, one can stop right there. With a late onset OHHS, once the pregnancy is already implanted, it becomes very difficult to, it becomes a very tricky situation, because obviously it's a very precious pregnancy and you don't want to sacrifice that pregnancy. So many times the management is, obviously if it is an already pregnant patient, management is conservative. The only option is management is conservative. But if it is a patient where we are inducing and we may have to sacrifice the cycle if we are giving the trigger for ovulation, or we could withhold the cycle. There we could withhold the trigger, maybe delay the trigger a little bit, or maybe just do away with the cycle completely. These are certain options. So broadly this is about the OHHS. Right. Now, any new update or drugs in OBGYN which we should look forward? The only drug update but I don't think a question will be asked on that, because it's not yet available in our country, but there came this Phexi, no? I don't know if I'm spelling it correctly. There, this contraceptive, this new contraceptive that has come. I think there's a double X there. So this new contraceptive gel has come, which is a hormone-free method. Okay, it is a vaginal gel. It is a vaginal gel. So it is a barrier sort of a, it's not even spermicidal. It's not even spermicidal. It basically alters the vaginal pH, makes it more acidic and makes the sperms immotile, and prevents the ascent of sperms, right? When it is being marketed, this is the latest, I think, that has come up. Phexi, it's a new contraceptive gel. It has been approved by the FDA. This is new. Non-hormonal contraceptive gel. But then it will be used like a spermicidal jelly every time with sexual intercourse. With every episode, it needs to be used like that. Okay. Right. Now, why do Braxton Hicks contractions not cause cervical dilatation? Okay. There are things that you mug up. Who's this answer? Ranga Prasant. So, you always mug up, right? That the cervical, the contractions of the uterus that are capable of causing cervical dilatation should cross a minimum threshold of intensity, right? And those thresholds of intensity you tend to mug up. See, uterus is like this, when the uterus is contracting and the cervix is closed, right? This is a closed system. Okay, in that closed system, when the uterus is contracting, there is increase in intrauterine pressure. That is what we say when we talk about the intensity of contractions, the increase in intrauterine pressure, intensity-wise, right? So, Braxton Hicks contractions would be like, say, for example, continuing painless contractions. They are not even felt by the woman, so they are not palpable because the intensity is very low. 8 to 10 mm intensity, not enough to dilate the cervix, right? Then when the intensity further rises to about 10 mm edge and crosses beyond that, they start becoming palpable. They may not still be painful. They are intense enough to cause pain when they cross a threshold of 15 mm edge. And once that threshold is crossed, then they start becoming painful. Then they start being capable of causing cervical dilatation. So the answer to why Baxter Hicks do not contribute to cervical dilatation is because they're very low in intensity. Okay. ओवैस ये छाया एंड सहेली विच वन इज बेस्ट देखो अब तो इट इज कमिंग अंडर द नेम ऑफ छाया ओनली सहेली वाज द प्रीवियस नेम अब तो आई डोंट इट इज नॉट कमिंग इन सो इफ यू हैव टू पिक वन दैट I don't know with which context you are asking this question, right? So if you are asking which pill is centrochromin containing pill that is available free of cost in the government of India supply, it is centrochromin wala pill, then it is Chaya, because now it is coming in the trade name Chaya. Okay. Now I think yes, Oves, you are right. Fexi contains lactic acid, citric acid, potassium bitartrate. Yes, those are the compounds that it contains, right? So I think that is it. No more questions coming up, right? So for now, I would like to sign off, guys. I mean, you've given too much of your time already. This is very crucial time, let me tell you, right? So the most important PYQs, most of the flowcharts, like we did the AUBs and postmenopausal bleeding and postcoital bleeding, we did the amenorrhea flowcharts, right? So the most important areas are mota mota, they have been covered in this, right? Even in obstetrics, let me remind you what we are the trend that we are seeing in INI-CET and even in your other exams for that matter is anything that has to do with labor room dynamics is important, okay? So be it anything that you may have seen in the labor room dynamics, that is important. That is why they are asking you questions on basics, on PPH, on APH, the preeclampsia, immediate management when the patient comes in an emergency, right? So labor room dynamics wale questions, whether it is acute complications like uterine inversion or cord prolapse, or these are the questions that they are asking if you look at the clinical aspect of it. So that becomes important. And other than that, early pregnancy complications is always an important area. Okay. Oves, I'm telling you na bacha, what are you, what is the question? हाँ, सेंट क्रोमन किस में होता है? तो छाया एक ही चूज करना है, गलत मिसप्रिंट भी हो सकता है यार क्वेश्चन में, बट आई थिंक अगर रिकॉल क्वेश्चन नहीं है एंड यू योरसेल्फ गेव द एग्जाम और दोनों थे तो छाया और सहेली दोनों ऑप्शन में था तो फिर छाया ही है आंसर अभी करंटली, तो उसी में है, वही उसी नाम से आ रही है छाया, सेंट क्रोमन वाली, ठीक है? ओके, चलो फिर. So I think that is done. I've given you a broad overview of what are the important areas, right? So stick to the previous year topics. In any subject for that matter, stick to the previous year topics. Don't add new material. जहाँ से पढ़ रहे हो वहीं से पढ़ते रहो. Wherever you are studying from, study from those sources only. Study from those notes only, right? That is going to be the most helpful. Chalo. Thank you so much, guys. We'll end the class now. Bye-bye.